Welcome to our 26th Dr. B. Mukhopadhyaya. एक मिनट के इतना इको क्यों आ रहा है? बहुत सारे कंप्यूटर है बेटे, सब बंद करो ना, इतने सारे कंप्यूटर नहीं। This is the 26th our B. Mukhopadhyaya postgraduate instructional say that for this second virtual course we have a tremendous, and you will be happy to know that we have more than 250 postgraduate students all over the world, and to let you know their students India, Egypt, Iraq, Jordan, Libya, Nepal, Pakistan, Saudi Arabia, Sudan, United Kingdom, and Deven. This encourages all of us. Now, genesis of this course is that I have been a founder.
Dr. Taneja, we can't hear you.
And Dr. B. Mukhopadhyaya, and you all know in the January.
So, Dr. Taneja, the sound is not very clear from your side, sir.
We can't hear.
Dr. Taneja, sir, make your earphones on. Make your earphones on. They are not on here. Hello.
And I'm happy to say that this course is has been supported and coached by the national program. Because most of the students find hard work. The Indian Orthopedic Station is a big support. I am happy Dr. Chapter from Patella Baja is also with us. Dr. Sheikh, the chief guest of the here, and they all have been helping us to unusually as well as moral support. And we have been getting
Dr. Taneja, you have to get your earphones on.
And they all come here and give their expertise to our students. The whole idea is the students are encouraged to ask questions. We try to find out what are the techniques in their presentation. We try to clear their doubts, and that is where we give them a mock examination. And with that, the performance of with these words, I would now request Dr. John Mukhopadhyaya, the chairman of the panel we have been organizing to tell us how the students and the practical.
Thank you very much, Dr. Taneja. Unfortunately, the sound from your end was not very clear. I hope I can be heard.
Yeah, very clear. Yes.
Okay. Welcome to all the dignitaries who are here today. And just a few words regarding the Orthopedic Research and Education Foundation. I think Professor B. Mukhopadhyaya in the late 70s was he realized that in India, once orthopedic surgeons had graduated or done their MS or DOth, there was very little scope for updating their knowledge or skills once they had done their MS or DOth. There was very few formal CME programs. In those days, journals were hard to get, and there were very few libraries which had all the necessary journals available. The internet revolution had not yet started, and to travel abroad was difficult as well as expensive and really not possible for most orthopedic surgeons to do. So during his travels to the US and interacting with various friends, including Dr. Dilip Pal from Lubbock and Dr. Satish Lal from California, he realized that it was important to have some kind of graduate or postgraduate training program for orthopedic surgeons. So he talked to some of his like-minded friends, including Dr. Sethi, Dr. Joshi, Dr. Taneja, Dr. Shailin Bhattacharya, etc. And he started the first course, the Orthopedic Research Education COE course in Patna in 1983. For that meeting, he Two of his close friends from Liverpool, Professor Owen and Professor Osborne, had also come. And we had Dr. B.B. Joshi, Dr. P.K. Sethi from Jaipur, and other luminaries who attended the course. Subsequently, many other friends of his and colleagues of his joined him in this foundation and helped with future courses. People like Dr. D.K. Taneja, who was one of the leading or most dynamic members of this group. We had Dr. Shailen Bhattacharya, Dr. Chako from Manipal, Dr. Sriram from Chennai, Dr. B.B. Joshi, as I mentioned, Dr. Lad from Mumbai, Dr. Karchu from Jaipur, some of whom unfortunately are no longer with us, who were all involved very keenly and helped with sort of organizing this program and changing how the course every year as we went along. I think this course started with being held in different cities of the country. So we went from north to south, east to west, and gradually it became one of the most popular courses for orthopedic surgeons all over India. And people from all over the country would attend this every year. It became a necessary part of their calendar. Subsequently, Dr. Taneja, as I mentioned, was the most dynamic person in this group, started with courses for the PGs. And today what we are having online is a course which he normally holds in Indore every year. And also for the theater personnel, so the ORPs, etc. And such, because of all this, the program grew from year to year. And became one of the necessary or most important events in the calendar. Of course, things are very different today. Journals are much more easily accessed by people. There are a plethora of courses all over the country being held. But it all really started from the Orthopaedic Research and Education Foundation courses, which were started by Professor Mukhopadhyaya in 1983. So with these few words, I'd welcome all of you and hope we have a really successful program. Thank you very much for being here with us to help us organizing this program. Thank you.
The Under Secretary of the Indian Orthopedic Association. Because the Indian Orthopedic Association has been associated with a very big name. And to tell us something about the association.
Yeah, your voice is not clear, but what I heard is thank you, sir, for inviting us from the Indian Orthopedic Association for this program. And this is a very popular PG next course. And Indian Orthopedic Association has their own PG committee, and here the PG committee member, chair Dr. Raj Gopalan sir is here, and he's assisting in this course. And Dr. S.C. Goel is also here. And we are thankful to Dr. Mukhopadhyaya for such a wonderful course. And we at Indian Orthopedic Association urge every PG student to become a member, associate member of the Indian Orthopedic Association. And for every college, any PG teaching program, the IO is helping by the faculty and also by financial help to them for making a physical course at every place. A real course of examination for the DNB students and MS Orthopedic students. So thank you very much, Taneja sir, for inviting us and making us a participant in this course. And I wish a great success to this program. Thank you very much, sir.
Thank you,
and
Naveen.
Dr. Abhijit is also here. He is a
Yes.
good friend of mine. We did undergraduate and postgraduate together in Ahmedabad only. And he will be also guiding us for the DNB students, being a president of NB. Thank you, Abhijit. Good morning.
Thank you,
Morning.
Naveen, for a very wonderful presentation. We have Dr. S.C. Goel, who is the president of the Orthopedic Association Department in India. I request Satish Goel to say a few words about this. Satish.
You are muted, sir. You are muted. Unmute yourself. Well, sir, unmute yourself.
Oh, sorry. Good morning.
Good morning.
I'm very happy to be associated with the inaugural function today. I am associated with this program of Dr. Taneja organizing in Indore. I have visited Indore a couple of times and also attended the COE in Aurangabad earlier, and I am sure these programs are very good to enlighten the orthopedic surgeons as well as postgraduates about the newer developments in the field, because COE, continuous education, is an important part for every orthopedic surgeon wherever he may be working. Be a bigger institute or maybe a small peripheral area. And on this side, even the OSEC side also, we are organizing some programs for the continuing medical education. And I am very happy this program being organized today. I wish all good luck. Thank you.
Words and for good wishes for our course. I will now request, I think Dr. Alaa has been held up somewhere. He is not with us at the moment because this course is endorsed by the World Orthopedic Concern. Arindam is here. Arindam, can you say a few words on behalf of the World Orthopedic Concern? Arindam?
Unmute, Rindam, unmute.
Yeah. Okay. So since Dr. Alaa has been held up, I will just speak on behalf of the World Orthopedic Concern. The World Orthopedic Concern was led from the front by Dr. Taneja as president until last year. And this year, Dr. Alaa has taken over. We are organizing a lot of courses and several activities all over the world. And we have now representatives from the different continents, South America, Africa, Asia. And we are trying to take our message through our newsletter to various parts of the world. We hope this is one of our going to be one of our official courses, and we are going to use our whatever means we have to propagate all the message of postgraduate education to all the people who follow our newsletter and follow our videos. Thank you.
Arindam is our dynamic Secretary General of International WOC. Thanks so much, Arindam, for joining us. I will now request Professor Buti. Professor Buti, as you see, outside the field of medicine, he is an internationally renowned astrophysicist. I worked with Professor Chandrasekhar, who was a Nobel laureate, and Professor Buti runs a very big foundation called as a Buti Foundation, of which she is the chairperson, and she is all the time ready to promote any program related to the science society. May I request Professor Buti to say a few words of the Buti Foundation?
Thank you, Dr. Taneja. I feel honored to be with you this afternoon for the inauguration of an important PG instructional course to be hosted by Dr. Taneja and his colleagues. On behalf of Buti Foundation and its 4 centers for science and society spread over the country, I would like to extend my greetings to all the dignitaries, Dr. Mukhopadhyaya, Dr. Thakkar, Dr. Ahmed, Dr. Sheikh, Dr. Kumar, Dr. Taneja, and also to all the speakers and the participants of this course. You know, on my superannuation from Physical Research Laboratory, Ahmedabad, I had decided to devote some of my time besides my research work to contribute a little bit to the society. For this very purpose, I had founded Buti Foundation in 2003 for education in general and science education in particular. To meet these objectives, the foundation has started a number of projects. First of all, we have initiated a number of awards for students, young scientists, and not so young scientists through various institutes. We have also instituted some gold medals for women scientists at different IITs in the country. And I'm proud to tell you that we have instituted awards for the visually challenged students of BA, BSc honors in Miranda House College of Delhi University. The next project that we have started is the center at Bareilly, Cancer Care Center at Bareilly. And this is in association with Bareilly Cancer Charitable Trust, whose president is an oncologist. Under this, we provide free consultation, free medicine, and prerequisite tests for the breast cancer and blood cancer patients. On top of this, we organize cancer awareness camps twice a month. We have set up a public library in Basantpur, New Delhi, and I'm glad to inform you that we started from scratch, but now we have more than 5,000 books which are catalogued, and the library is being managed by a full-fledged librarian who holds MLib degree. Then I come to the centers of science and society that I mentioned in the beginning. We have 4 such centers at Ahmedabad, Bareilly, Delhi, and Indore. The present course which is being held is jointly sponsorship of CSS Indore, whose executive director is your host, Dr. Taneja. The aims of these centers are to increase the interaction between scientists and non-scientists, between natural scientists and social scientists, and also to attract the students, in particular girls, to science career. Let's see how far we succeed. The other activities taken up by these centers include organization of science awareness competitions for school children, public lectures, awareness medical camps, and CSS Indore has been very successfully organizing the first aid training courses for ambulance drivers and police constables. With these few words, I would like to extend my sincere wishes for the great success of the workshop or the instructional course that you are holding. Thank you.
Thank you, Buti, so much. And we are indeed very grateful to you because you have been a great source of inspiration and energy to all of us, and that we have been continuing with this course for so many years. Now, ladies and gentlemen, I invite Professor Abhijit J, the President of the National Board of Examination, and who has been all from the very first course the National Board Examination has been associated with us. The National Board Examination has been helping us potentially in providing us the faculty, and their all expenses are taken care of. And as you all know, the National Board Examination is the body of the Government of India, well, it is written into the postgraduate training program of the country. And may I request Professor Sheikh to share some ideas with our students. Thank you, Professor Sheikh.
Am I here all right to all of you?
Yes.
Yeah. Thank you. Namaste and very good afternoon to all my colleagues. It is wonderful not to see only the very well-known colleagues of mine, but at the same time, very passionate and committed senior faculties across the country who wants to drive the orthopedic medical education to the next level. And this is not my first interaction with you. I have been with this organization a couple of times, and I have seen the dedication. And certainly I am seeing the new passionate faces and committed faces like my senior colleague, Dr. Naveen. who is now becoming a front face of IOA. And certainly, on behalf of the National Board of Examination, I extend my gratitude to Professor Taneja and all senior faculties who are present in this inauguration. Talking to the National Board of Organization, certainly after we took the tenure in 2016, we have taken a positive approach. I think the one biggest step which we take it is a positive approach. In positive approach, I'll give you an example. Like when we visited our auditorium in the National Board of Examination, the most of the time of the year, except big inauguration and things, the auditorium stays empty. And I always say that we will be successful in our tenure only when this auditorium will have around the year courses running for the benefit of the National Board of Examination students across the country. And certainly that is the path, that is the final destination where we want to reach. Second is, we have been successful in increasing the numbers from 4,500 to now almost 12,500. And we are committed to align with the government to create more and more postgraduate opportunities across the country. But while doing so, we want to make sure that we are not diluting the quality of education. And hence, these activities are very vital for us. What we have developed at National Board of Examination is we are developing 3 pillars, as rightly said by our colleague in the previous talk, that physical education is one of the must and it's a gold standard. And there is no way we can replace the physical education. And certainly we have to provide as many students as possible to have an opportunity for physical education. Simultaneously, with the technological advancement and the complexity of the medicine, the skill enhancement and virtual learning has become a need for the hour. And also, there are so many innovations in the learning modules has happened in this area. So certainly, the skill development and virtual learning is the another pillar of teaching and training. The third pillar is a digital learning, which is e-learning. The biggest advantage with the digital learning is it's standardized and it makes your learning uniform. And at the same time, you can attract the global talent, you can attract the national talent very easily on digital platform. Only thing which we believe that neither skill enhancement nor digital or nor the new methods like artificial intelligence, they're not going to replace the basic physical education, but they will complement the physical education. And keeping it in the mind, national body is going to develop their strategies and planning for the next level of education. And I always say to the people that if you want to develop better academician, you have to integrate, you have to accept criticism, you have to debate, you have to argue, because if you don't have such virtues within yourself, you will never be able to introspect yourself and your shortcomings, and you won't be able to upgrade to the or upscale to the next level. So this is very, very important for us. The last thing which I would say that we are also looking at the examination and assessment methods to make sure that it becomes more user-friendly. And certainly any shortcomings, we are going to look at it in a critical way. And certainly with the help of the Specialist Board of Orthopedics, we will take it to the next level. With these words, I must say that the National Board of Examination in Medical Science is open to receive any positive recommendation from your organizations and all the senior faculties, and any suggestion which will be useful and which will be certainly a futuristic for the next generation of students. We will not be shy to accept it and to develop it as quickly and as fast as possible. With this few words, I must seek a blessing of Professor Taneja and all senior faculties here. And I must extend my thanks and gratitude once again to all of you. Thank you so much. Thank you.
Thank you, Professor Sheth. It has been you have always been very kind, and you have always supported our course and encouraged our students. And this is one of the demand of our student. Sir, you must invite Dr. Sheth to this course. This time we are having virtual, but in a physical course, the students always try to ask you many questions and their doubts about the national board dealing with them. With these things, I think now I request Dr. Pranaw, who has been working very hard from last 1 month, who is the course coordinator, to just propose a vote of thanks. Dr. Pranaw.
Can you hear me now?
Yeah.
Okay. At the outset, I would like to thank all the faculty members and all the people present here for such a valuable opportunity to learn and learn from the students, learn ourselves, and enrich our knowledge. We can't thank Dr. Taneja enough for first of all starting this and envisioning this thing and continuing for 26 long years. And despite the pandemic, embracing the virtual platform, which is not very easy after a certain age, but although it's just a number. I would like to thank Dr. Mukhopadhyaya for being with Dr. Taneja and supporting this course wholeheartedly. Can't thank you enough, sir. Would like to thank Dr. Thakkar from the Indian Orthopaedic Association, and I would request all the members, all the people who are not the members of IOA to become a member as soon as possible and reap the benefits of IOA. Thank you, Dr. Banerjee from the World Orthopedic Conference for embracing this August gathering. Thank you, Dr. Buti from the Buti Foundation. Thank you, ma'am, so much. So we thank you from the bottom of our heart. Thank you, Dr. Sheikh from the National Board for sharing your vision and knowledge with us. And I would like to thank all the participants who's come in today. I think we have 78 participants today. I hope we have more number and just make it a success. And what we would try to do is try and make it a hybrid kind of platform from the next year so that we can go forward and embrace this thing and continue for years to come. Thank you very much.
Thank you, Pranaw, and thanks everybody, all my dignitaries who have spent a very valuable time to be with us this morning in our inauguration program. Now, we'll start with our proper course, and I will request Dr. Mukhopadhyaya and Professor Khushnood from Peshawar, Pakistan, to share this session.
Thank you very much, Dr. Taneja, and welcome, Professor Khushnood. It's a pleasure to see you with us here today. I think we should get started with the actual program. I think, Dr. Taneja, your sound is better, but still not very clear at the moment. So I don't know if there's much you can do about it, but we'll have to continue. And so the first talk is going to be by Dr. Taneja, and he's going to talk about the evolution of orthopedics. So over to you, Dr. Taneja.
Good afternoon, everybody. The very first lecture that we have chosen for this course is on the evolution of the science of orthopedics. I come from a city in India called as Indore, which is the cleanest city of this country, as you can see this thing. And The subject that I have chosen is the science of orthopedics evolved, resolved, and dissolved. That how we have come where we are today. And my agenda is going to be that we are going to relook into the science of orthopedics, starting from a primitive era to the modern period, and what is going to be the future of the orthopedics as on today in year 2022. We all are very familiar with this Nicola Henry tree, and that is how we have all adopted this as a logo internationally for the orthopedics. And then Nicola Henry, in 18th century, at the age of 80 years, he wrote a book on the preventive of the deformities in orthopedics and gave an example that how a crooked tree can be straightened by putting in a split. This is the very basics of the use of splints in correction of the deformities in orthopedics. If we go into the primitive era, the archaeologists, when they were making and digging all over the world to find it out about the human civilization, they got many bones which were fractured. You see, if that time, there were two things only the human race knew, that they were getting themselves injured, two, that they were pregnancy and delivery. Beyond these two things, they knew nothing. So how did they treat their fractures and injuries? They knew nothing about the science of medicine. And I feel and presume that they kept lying in their caves and not mobilizing their limbs. And gradually, the nature helped them to make the fracture unite. So this is what we have been teaching to our students even today, that by masterly inactivity, do no harm. So you can see that many of the fracture must have united, but of course, this must have been into a malunion. And few, of course, the patient must have gone into a non-union also. You see this skull, which was also found by the archaeologists. The perimeter of the hole in the skull is rounded off by the ingrowth of the newly bony tissue, which is indicating that the patient survived the operation. Now we go to the ancient Egypt. The Egypt civilization is one of the oldest civilizations, which was from 3050 to 2686 before Christ. And we all have heard about this thing, but know nothing about that. What is this papyrus? Now, the papyrus is something which has been written on the bark of the trees or some other things, whatever they got it. And this papyrus was stolen from the tomb in 1862. It was sold to one American gentleman whose name was Ahmed Smith. We do not know whether the Ahmed Smith himself was the author, but as the story goes, that after the death of Mr. Edwin Smith, his daughter found some material lying on the top of Elmira, and she took out that material, read it, and found it was the storehouse of the knowledge in the field of medicine. Therefore, she got it organized and published a book which she named as Edwin Smith Papyrus, which was considered to be the first textbook of surgery in the world. And in this book, you see that what was written. It is written that first listen to the patient. Second, use your hand and eye to examine. Third, make the provisional diagnosis and then take decision. To treat or to be contended or not to treat, same as we are teaching today. In that book, it is also mentioned that the fractures can be treated by traction and bandaging.
So there's a lot of sound coming from the background. I don't know where it is from. So can they mute everybody who's not actually speaking?
बेटे आप लोग इसको बंद कर दो ना बेटे Yes, please. And it has also found that the splints were found on the mummies made of bamboos, wood, and bark, but they were padded with linen. Use of crutches have been found on the carvings of 2830 BC on the entrance of the portal of Hyrkakov's dome. As you can see this thing, people have been using the crutches, and you can see that probably this gentleman had a polio, as the foot is in the, you can see that is in the equinus, and this is what shares the diseases that were at that time. In 5th dynasty of the Egypt, there is a first record of the splinting and a first successful amputation which was done in a particular patient. So they also mentioned that the jaw which gets dislocated can be treated by the thumb pressure. They also talked about the fractured clavicle, that if you put a block between the two shoulder blades, the fractured clavicle can be treated. They mentioned about the cervical spine dislocation with transection of the spinal cord, and they say this is not the condition to be treated. They mentioned about the signs of torticollis, and they also mentioned about the discharge from the bone, what they called as a rit, which is basically a pus, and what we call, as on today, osteomyelitis. They mentioned about the infected compound fracture. They say it is a grave injury, and they used to do the dressing by a fresh meat, as it has a hemostatic properties. Alexandrian School of Medicine in 3rd century BC, they found that the Orbiceros said that you reduce the fracture dislocation first and then the fracture. This is what we are doing it today also, that if you have a fracture dislocation, like in this case, that we reduce this dislocation and then we try to do something to the greater tuberosity. This is a very famous thing that I found in the literature. It's called as the secret of user Montu. Many scientists from America and other advanced countries got the mummies, examined them, dissected them, got the whole body X-ray to find it out what exactly was going on at that period. To one of their surprises, they found that there was a X-ray in which they found a intramedullary nail, as you can see this thing. Probably the pharaohs of or the king of Egypt at that time was suffering from a very painful joint, and they made it an orthodesis of this thing joint. And the whole credit in the modern science, we give it to the Kunscher, a German surgeon, for the intramedullary nailing. But whereas this was persisting way back many years ago, the people knew how to use metal and how to put them into intramedullary canal. And this work has been by the Wilford Grigg from the Brigham Young University in America. We all know the Cocker's method of reducing a dislocation. This is nothing, but it is the Egyptian method of reducing a dislocation 3,000 years ago, which in the modern science we know as a Cocker's method of dislocation. Now, this is very interesting. You see the logo of the Egyptian Orthopedic Association. All the orthopedic association of the world, they have in their logo the Nicola Andri tree. But this is the only association in the world which does not have the Nicola Andri tree. And instead of that, they have their famous photograph in which they are showing that how that dislocation of the shoulder used to be reduced as way back at 3,000 years back. We come to our own country, our Vedas, there's enough evidence in that. There is a mention of the diseases, the medicines, the herbal plants, the instrument, and the all type of fracture, etc. is mentioned this thing. The Khushnood era, which was 600 before Christ, is known to be the father still that he is known to be father of the plastic surgery. Khushnood Samhita and Khushnood said that if the fracture united without gap, shortening, angulation, and return of the painless early movement, if this exists, then the bone has united. Khushnood talked about the science of orthopedics and named it as Bhagna Chikitsa. In the Khushnood Samhita, there are 184 chapters, 1,120 illnesses, 700 medicinal plants, 64 preparations from minerals, 67 preparations from animals. And so we know that the Khushnood knew how to make incision, he knew how to probe, how to remove a foreign body. He used the thermal cauterization. He described 6 types of dislocation, 12 types of fracture, classification of bone, reaction to the injury, and of course, the different surgical instruments. Now you are seeing these photographs of the instruments and tell me which instrument we are still not using today. So these instruments, he designed them 600 BC, and these instruments are still being used by all of us. The Khushnood Samhita became very popular and was translated into Arabic by Boone in 8th century, and it was translated into English by Kaviraj Kunjalal in 1916. And you can see this is the front page of that book. He talked about the 4 principles of the treatment of fractures, and that is the first thing you have to say that give a traction, what he called as anchana. Then he said you should do a manipulation, which he called as a pidana. And then he said the 2 ends of the fracture must be opposed to each other and they must be stabilized, what he called as sankshepana. Then he talked that it must be immobilized once you have got this thing by any way of explaining, what he called as bandhu. And he said that if you need a bone grafting, he talked it as asti purna. And if she said you need a skeletal traction, he talked about chakra yoga. So what we can say that the vast medical literature of the ancient India practically remains as yet unexplored. We do not know because there is no scientific research on Ayurveda, although the Ayush ministry is now done a lot of work into this thing. From this period, we now come to a Greek civilization, which was existing from 500 to 336 BC. And this whole Greek period can be divided into different periods, out of which the Mycenaean age was a very important because there was a high cultural achievement into that. From the Greece, the many big names we all know, Homer, Herophilus, Hector, Hippocrates. The Homer was a known man of literature and his poems are known and taught into the children in their school. We know that Herophilus, Hector, the great warrior, and of course, the day we entered into the medical school, we have been hearing the name of the Hippocrates. And this is the temple of the Mohd, where the science of medicine was being taught. When I was in America, and I used to go to the Yale School of Medicine and in their library, and I found it was loaded with many original books. And this is the photograph which I took from in the Yale University from their library. Very good collection of very old classic books with them. So in that they mentioned about the Hippocrates that the fracture must be reduced by traction and then bandaging. The oil better be applied before you do any bandaging. And the Hippocratic method of reducing a shoulder dislocation, we are still practicing in old and difficult cases, which don't get reduced by a simple Cocker's method. Hippocrates talked about the fracture humerus, and he said this fracture humerus will unite definitely in 40 days. He talked about the varus deformity in the fracture humerus and gave the method to prevent it. There has been a mention about the different types of external fixator, from the time of the Hippocrates. Of course, we have got now a very sophisticated external fixator, but these external fixators existed even in the time of Hippocrates. The Paul of Aegina, his book Epitome Medical Timbri Septum, and he mentioned that the patient should lie till the callus is formed. That means the fracture is now getting stabilized. And he talked about the many serious complications which can take place by a tight bandaging. In ancient Greek, used this fraction, but this died till the Middle Ages. But it was revived by a French surgeon called as Guy de Chauliet in 1300 and 1368. From Greek civilization, we come now to the Roman era. As you all know that and aware of the history of the Roman Empire, which existed from 27 BC to 476 AD. This is the famous Colosseum of Rome you all have visited, and this is a beautiful thing to be seen. There are many famous persons like Celsus, Galen. The Celsus book on medical writing, De Medicina, his philosophy was accepted till late 19th century. Book written in Latin described different types of fracture and signs of fracture, importance of early reduction, bandaging on 7th or 8th day so that the swelling get reduced, which was followed by splinting. Galen, you know, was a very famous surgeon, and he was a surgeon to Gladiator. Now, you all might have seen this beautiful Hollywood movie, Gladiator, which is, they were the warriors in the Roman time. And Galen described the spinal cord and the cranial nerves. His work got burnt in a great fire of Alexandria library. He talked about fractures, dislocation, and different types of wounds. He was physician to Gladiator. He said, reduce the fracture, apply bandage, and splint on 7th day. He talked about the artificial limbs, the wooden legs, and the iron hands. So they have some idea of the orthotics and the prosthetics. Then came the Middle Ages. Middle Age, which is we consider from 5th to 15th century, that was a time when the people were just fighting and fighting and fighting. The idea was to grab the land as much as possible, and those who were high and mighty and a strong warrior, they will grab the land and really settle down this thing. And there were many injuries by the arrows and all other instruments that they used it. And the teaching and technique of the Galens were followed till the Middle Ages. The time came, the Renaissance period. We all know this was the most important period in the history, in the world history, which the Renaissance period is also called as the period of awakening in the world. There has been a great achievements and great things happened during this period in that field of art, literature, science, technology, engineering, sculptures, and you all know Mona Lisa, Leonardo da Vinci, the Michelangelo, they all were in this Renaissance period. This is a Michelangelo's photograph, and you all are very aware of this statue of David, which you all must have seen that. And then came the era in 16th century from 1510 to 1590, the era of Ambrose Pare, who is also considered to be the father of the modern science of surgery, and his famous book, The Livre de la Chirurgie, in which he talked about anatomy, physiology, surgery, and he talked about the orthopedic surgery, in which he also mentioned about the artificial limbs. He mentioned about the scoliosis corset, and he mentioned about the clubfoot splints. A book by the Peter Lowe in 1597 became very popular, a discourse of the whole art of surgery. And for the first time, he used the word amputation. And prior to this, it was called as cutting or chopping of the part. Benjamin Gooch described this first functional brace in 1767, which he will apply and will make the other joints move and make the patient stand and walk. So way back in 1972, I just devised this type of a brace, which I used to treat the fracture radius ulna. I had not heard the name of Sarmento or Gooch. And later on in 1976, I knew the work of Sarmento. In 1740 to 1708, Percival Potts era, a British surgeon, is very well known to all of us. His contribution on the first aid, ankle fracture, and Potts paraplegia. Of course, the John Hunter era was very, very landmark in the history of surgery. And because he put the practice of surgery on scientific foundation and laid the framework of our 20th century development. The museum in the Royal College of Surgeons of England is by his name, and anybody going there must visit that museum. In 1780, a gentleman called as Fadel in Switzerland established the first orthopedic institute of the world at Orbe in Canton, Vaud, Switzerland. He can be called as the first true orthopedic surgeon of the world. In early modern period, again, the wars were going on. And from 12th century, the awakening started. Up to 16th century, all the development that took place were under the shadow and influence of Hippocrates. Therefore, we all adopted all the philosophy on the conservatism in the treatment of the orthopedic condition. And we all absorbed those ideas and has been treating the orthopedic condition as per what has been told by our ancestors. The modern period started in 1800, and the big breakthrough came when in 1852, Antonius Mathieson, who was a Dutch army surgeon, used the plaster of Paris for the first time for the treatment of fracture. Of course, we now know that we have got the fiberglass bandages. Lucas Champagner, contemporary of the Hugh Thomas in UK, and he was in France, who talked about the early ambulation, early weight bearing, and knee in extension to be followed. Of course, the father of the modern orthopedic, Hugh Thomas, who worked in Liverpool for 35 years, and his philosophy was different, and he talked about that all orthopedic conditions can be treated by a prolonged, uninterrupted, and forced rest. His famous Thomas Splint saved many lives in the First World War, and then the many books in the orthopedics started coming in 1876, 83, and 1890. There was another breakthrough was made by a surgeon called as Hugh Lane in 1856, and when he introduced a steel screw, and in 1905 used a steel plate. Of course, we all know that in 1865, Joseph Lister worked on the antiseptic surgery was a big breakthrough in the development of surgery. These names must not be forgotten. Robert Jones, the nephew of Hugh Thomas, George Perkin, who worked in St. Thomas Hospital, and his book on the principle of the conservative treatment of fracture is well known. Watson Jones' book is a classic book, which we all have read. And of course, John Stanley, father of the orthoplasty, a mechanical engineer turned into an orthopedic surgeon. World War II gave us many lessons to this thing. So if we re-look into what has happened in last so many years, it convinces us that the principle of the conservative treatment of the fracture dislocation were well understood. External fixator and cast placing was known. Metal and intermediate nailing was also in use. Congenital and other deformities were being treated. There was an emphasis on the preventive aspects of orthopedic. Injury reaction was known. Basic surgical instruments were developed. Thermal cautery was in use. Orthotic and prosthetic science was known, but there was not much knowledge of the diseases in the orthopedics. Therefore, anyone who states that he has developed a technique that no one has thought of before, chances are that it has been thought of in the past as well. The surgical ideas were well ahead of techniques essential for their success. In 1775, a fractured humerus was wired, but infection killed the patient. In 1850, The hip flexor was made by Langenbeck, but failed
Under
due to
evaluation.
position.
Evaluation वो तो अभी भी है ही
The
नहीं
evolution of science of orthopedic depended on the development of other sciences, like in the field
नीचे
of
आई मीन रिपोर्ट्स अवेटेड
development anesthesia and antiseptic,
डिवीजन ऑफ ओपीडी इसमें नहीं है तो लोकल में डिस्चार्जिंग चैनल एक
MRI and
डिस्चार्जिंग
CT
चैनल
scan, biomechanics, joint replacement, material science, implants and bone cement, optics, we developed arthroscopy, and Ashok, computer science and internet, we have robotic surgery and computer navigation. So all the ideas that we learned gradually got dissolved, and from a conservatism, we have moved on to the surgical. More and more and more of surgery being done in the field of orthopedics. So what is going to be the future? My feeling is that most of the surgeries will be day surgeries. There will be minimal invasive surgery. There will be navigation, robotic, bone substitute, biodegradable implants, tissue transplant, advances in imaging, advances in rehabilitation, pain management, metal-free orthopedic, sensor equipped with titanium implant, ortho sensor for biological way to treat the arthritis. Day is not far off when a young resident might find this white bandage and ask a gray-haired consultant, sir, what is this white bandage? People will forget the total science of conservatism in orthopedics. Human race has evolved from the apes and monkeys, from the quadruped to they became the human life. And again, now you are seeing that how they got stuck to the computer. We have a mission to the Mars. So I believe the future, only the past again has entered through another gate. This is what I feel. Many of people may not agree with me. So from a crude splints to navigation and robotic, this is the evolution of the orthopedics over the years that we have seen. So it is important for my students to know some of the orthopedic surgeons of my country who have made an international impact, though there are many more which may not have been included into this thing. Professor John Mukhopadhyaya, the first Hunterian lecturer for his work on the osteoarticular tuberculosis. Dr. Joshi, a very famous hand surgeon and who popularized the chest. Dr. Rajashekharan, his work on TB spine and Ganga score is all mentioned in the international book. Dr. P. K. Sethi, Maxose Award winner for popularized the Jaipur foot. Dr. Anil Jain, his work on TB spine. Dr. S.M. Tuli, the work on the osteoarticular tuberculosis and TB spine. Dr. Sancheti, who designed the Indian total knee, and of course, Dr. Ranawat, his total knee design being used all over the world, and Dr. Lord, a very famous orthoplastic surgeon. Dr. Mid Mehta, whose work on the infantile scoliosis won her the Robert Jones Gold Medal for the best paper published in the Journal of Bone and Joint Surgery. Dr. Shanmukh Sundaram work on traumatic paraplegia, TB spine. And of course, Dr. R.L. Mittal, my very dear friend and my elder brother, his work on the club foot is internationally renowned. And I'm sure the students should remember these some names. And there are many more which were not possible to have been included into this thing, but we value their work, which has made an international impact. With these words, I thank my students and the faculty members for their peaceful listening to this thing. May I request all the students and my respective faculty members that when the lecture is going on, to keep their remain muted so that there is no disturbance. Thank you.
Thank you very much, Dr. Taneja. It was a very enlightening introduction to the history of orthopedics and medicines as such. Just to add that there are many more luminaries in the Indian Orthopedic Association who have done wonders in their field and have brought a big name to not only to Indian orthopedics, but orthopedics in general. Some of them are my friends, and I am very, very honored to have them as friends. Now, our next lecture is again going to be by Dr. Deven Taneja, and he's going to talk about gait analysis.
Thank you, Dr. Khushnood, for your words. And why I have chosen this lecture, which is on the gait analysis. The reason is that when a patient walks into our clinic, if we carefully observe the way he is walking, I'm sure you all will agree that you can make a 50% diagnosis of the condition, which will not be wrong at all. So what is a gait? All the living animals, creatures, they walk and they have their own pattern of walking, what we call as a gait. So my agenda would be to define the gait, then tell you what is a normal gait, what are the gait parameters, what are the abnormal gaits, and what is the gait observation. Okay, so my talk is going to be first on the normal gait, and then we go on to the abnormal gait. So let us come to the normal gait. It is interesting that an average person takes about 8,000 to 10,000 steps per day. That means 5 kilometers approximately every person walks. And if it is multiplied, taking into his age as about 65 years, he is walking 1,18,625 kilometers in his lifetime. Of course, my feeling is that now the walking has become much less. There is a lot of automobile boom and bikes on which the people are moving around rather than walking. So the definition is that it is a So walking is, what is a walking? Walking is a series of rhythmical alternating movements of the trunk and limbs which result in the forward progression and propulsion of the center of the gravity. So it is a series of a controlled falls. You don't fall, but you tend that probably you may not fall. And the important thing to remember is, it is for the postgraduate student, that the one foot is always in contact with the ground. Remember that. One foot is always in contact with the ground. However, in running, there is a period in which no foot is in contact with the ground, and this is called as a double float. So if the examiner asks you the difference between walking and running, this is the difference, that in running, a stage comes when both the foot are off the ground, what we call as the double float. You can see the people are walking, and you can see every time there's one or the other foot is on the ground. The gait can be analyzed into two phases. One is a stance phase and other is a swing phase. A stance phase is always longer than the swing phase, which is 60%, and swing phase is about the 40%. A stance phase means when your foot is on the ground, and swing phase means when the one leg is moving from one position to the other position. If we try to analyze this stance phase, you will find that there are 3 or 4 stages into that. Number one, that there is a initial contact, what is called as the heel strike. So the heel will strike, and then the whole foot comes to the ground, what we call as the foot flat. Then comes the mid stance phase, is a single leg stance because the other leg is now going to be into the swing phase. So there is a single support which is for about 40%. And then of course, there is a terminal stance when the heel off, and then there is a toe off like this thing, and this leg goes into the swing phase. Very simple thing, that there is a heel contact, then there is a foot flat, then there's a mid-stance phase, then heel off, and then to toe off. If you look into here, that the first pressure comes on the heel, it goes onto the lateral border of the foot, goes to the forefoot, goes to the great toe, and then comes to all the toes, and then there's a toe off. The pressure is only at this area, and limb goes into a swing phase. This is showing how the weight-bearing area takes place while you are walking. And this is the swing phase. In the swing phase, there are 3 stages. One is acceleration. That is, as soon as there's a toe off, there's a flexion of the knee and the hip joint, and this limb moves forward. Now, from toe off to coming up to the here is called as this is a mid-swing phase, and then it gets deaccelerated, and same thing happens. There's a heel contact, and then there is a foot flat here, and then later on there will be toe off. So this period is about 40% in the whole gait cycle. So in running, the stance is about 40%, and swing is in 30%. This is how it differed. Whereas in the walking, it was 60%, and this was as 40%. Where is the rest of the 30%? That it is a float time. There's a double float at this thing. You can see this thing. Gentleman is running, and then comes a stage when both the feet are off the ground. And now again, there is one foot is on the ground. He starts running, and then again a stage comes when there is both the feet are off the ground. This is called as the double float. So this is a very important thing, and you must understand this thing. See, these people, gentlemen, are running, and you can see that both the feet are off the ground. Okay, so the double leg stance, in both the feet are on the ground. In normal gait, it happens twice. In jogging, the double leg stance is shorter, and in running, the double leg stance totally disappears. Single leg stance, one foot is on the ground, and in normal gait, it happens twice, which is of 30% of the whole this thing. Now we come to the important parameter. When we are standing, both the feet are apart, and this is called as the walking pace, which is about 5 to 10 centimeters. Then what is a step? From right foot to the left foot, it's called as one step. And what is a stride? From right foot again to the right foot, it's called as a stride. And we walk not with the foot absolutely straight, we walk with an angle, and this angle is called as the heel to toe angle, which is about 70 degrees. Not only this thing, when we are walking, there is also a shift of the pelvis. In a normal walking, the pelvis shifts laterally, which is about 2.5 to 5 centimeters. It also shifts vertically, which is another 5 centimeters. And beside this thing, it also rotates both forward and backward. And this is how the propulsion takes place. Now, everything is concerned over the forward movement of the center of gravity. The center of gravity is all lying midway between the two hips joint and 5 centimeters in front of the sacral 2 vertebra. The least energy consumption will be if the center of gravity travels in a straight line, but it does not happen. What happens? That the center of gravity moves both in vertical plane and in horizontal plane. So the overall displacement of the gravity is the sum of vertical and horizontal displacement, and this is in the figure of 8 movement as of center of gravity as seen in this diagram. Now, once having understood that how the center of gravity moves forward, and we know what are the different parameters and the stance phase and the swing phase, difference between the walking jogging and running, we come to the abnormal gait, which can be divided into the orthopedic gait and neurogenic gait. Now, the gait to be examined in the beginning of the orthopedic examination, types of the gait can be only 3 types. Whether you have a painful gait, the patient says, I get a lot of pain, entalgic gait. Patient is a stable or an unstable gait. So, and whether it is aided or unaided, that he is walking with a walker or with the crutches. Okay. So 5 major components that are lost in a pathological gait are the stability and stance. Sufficient foot clearance is also altered. Appropriate swing phase and repositioning of the foot is also lost. There's adequate step length also get altered, and energy conservation also get affected. So all the gaits may not fit into a described pattern, but nothing to worry. If you think that this gait is not fitting into a particular gait which has been described, all you have to do is to describe how a patient is walking. We go on to the orthopedic gait, which are very commonly asked in the practical examination: entalgic gait, orthogenic gait, Trendelenburg gait, waddling gait, short leg gait. Okay. Now, entalgic gait is when you have a pain anywhere from the foot and hip, and it leads to reduced stance phase and a shortened steps, okay, and shortened stride. You can see this gentleman, his stance phase is reduced. He's quickly taking off his weight from the hip joint, because whenever he's putting his foot down to the ground, he is getting pain. The orthogenic gait, which is a stiff hip gait, you all know that for getting the road clearance, the whole entire leg has to be lifted high. And if you do not have a flexion of the hip joint, then how is going to get a road clearance? For that, you'll have to do a circumduction of the pelvis. So you can see this thing. It is stiff hip, and he is trying to do the circumduction for the forward propulsion. The stiff hip gait will show you diagrammatically that the 2 things happen. There's a rotation of the pelvis on a vertical axis, but there is a flexion at the hip joint. That's important. And that is how the pelvis moves forward. Okay. In case of when there's a stiff hip, there's a loss of flexion at the hip, and it is compensated by the exaggerated rotation of the pelvis. Okay. So this is here, and it moves forward, and there's exaggerated by forward movement and rotation of the pelvis, and this is a circumduction which takes the body forward. The gluteus medius or Trendelenburg gait is very important, and you must try to understand. This is also called the wobbling gait, chorus girl swing, and you must try to understand what is a Trendelenburg gait and Trendelenburg sign. The most important thing is that you should try to understand that the hip joint is like a fulcrum, neck is like a lever arm, and the gluteal power is like a power. This is the simple law of physics, a lever system. Now just imagine that if there's something happens with the hip joint, there's a dislocation or destruction, or there is a fractured neck of the femur, or coxa vara, or paralysis of the gluteus, the whole abductor mechanism is lost. This is what is happening. Normally, in a normal person, when you raise your leg here, then what happens? The glutei on this side, other side, will contract and will lift the pelvis upward. As the pelvis goes upward, you get the road clearance, okay, and you move forward propulsion. In case where the abductor mechanism has been affected, then as you raise the leg, this abductor mechanism is at fault and is not working. As a result of this thing, the pelvis goes down. Therefore, when you are now trying to walk and you want to get a road clearance, what will you do? That this is the affected side where the abductor mechanism is not working. You will lurch the whole trunk onto the affected side. And by doing so, you will be lifting the pelvis upward. And by lifting the pelvis upward, you will be getting the full road clearance and you will be able to walk. This is what is a Trendelenburg gait. Now, you see this thing that this gentleman is lurching towards the left side. You can see that. It's lurching. And this is, so important thing is that in the Trendelenburg gait, if the examiner asks you a question, the answer is that the trunk lurches towards the affected side. Trunk lurches towards the affected side. In a waddling gait, it is when the abductor mechanism of both the sides are disturbed. For example, bilateral congenital dislocation of hip, osteomalacia, myopathy, and paralysis of the abductor group of muscle. This child has got a bilateral coxavera, and you can see this child, that how this child is having a bilateral congenital dislocation of a hip, and this is how there is a waddling gait. In a short limb gait, if your limb is short, then what will you do? Here, instead of lurching of the trunk, the whole body will dip down on the affected side. This is the difference between the short limb gait and Trendelenburg gait, with a very common question in the examination. The answer is that in this case, the body dips down on the affected side. And you can see that there is a short limb gait, how the gentleman walk, the body is dipping down. The important thing to know that short limb gait is only positive when the shortening is more than 5 centimeters, for a simple reason that 1.5 to 2 to 2.5 centimeter of the shortening is well compensated by the tilt of the pelvis. In a neurological gait, we have 3-4 gaits: ataxic gait, hemiplegic gait, high stepping gait, and Parkinsonian gait. Let us go to ataxic gait. They have a poor sensation, and therefore they feel very loss of coordination. They feel very unstable. And if there is a feeling of instability, the first thing that happens is that there's a wide-based gait. So like this. The base get increased, and the patient moves with the forward list, and his walking is very irregular. You can see that, like people who are the drunkard, and the way they walk, the ataxic people and people who are drunkard. So the drunkard people, or reeling gait, what is we call, is they walk irregularly on the wide base and swinging sideways, also seen as in the cerebellar incoordination. What is a stamping gait? In a sensory ataxia, because we have no kinesthetic and no feeling that our foot is going to strike the ground. Therefore, what we do, we try to see that, we try to flex the hip and knee to this thing and put just a stamping on the ground, and this is called as the stamping gait, as it happens in ataxics where there is sensory, the kinesthetic loss is there. The high stepping gait is little different from a stamping gait. Here there is a weakness of the dorsiflexor, which may be because of any reason, and therefore, because your immediately foot goes into a plantar flexion, and therefore the patient will try to flex the hip joint, flex the knee joint high up, and then put it onto the ground. See that. Otherwise, the toes will go and strike onto the ground. So this is a high stepping gait. There are patients who will pose to fall every step as they are walking, but they never fall, and they are hysterical gaits. The hemiplegic gaits, the person who has got a spastic paraplegia, they have a very typical gait, how they walk. You can see that the arm is adducted, elbow is flexed, wrist is flexed, hip is flexed, knee is slightly flexed, limb is in slight abduction, and there is a subduction. Just watch this, how a hemiplegic people walk. See that adduction, flexion at elbow, flexion at wrist joint, limb in slight abduction. And now when he walks with a tacit. He walks with a circumduction because of the marked spasticity in the muscles of the right side. The Parkinsonian gait, we all know that it is also called as shuffling or short rapid steps. Mild forward list, patient is again feeling unstable, so there is a forward list. It is also called as the Fessitant gait or a short shuffling gait and toe heave gait also. It is due to the rigidity of the muscles that toes strikes first. Normally, it is the heel which strikes first. Here, the toes strikes first, also seen in cerebral atherosclerosis. Now, see this gentleman, how he is demonstrating the Parkinson gait. Very typical. So there is a flexion at hip and knee like a crouching. Then there he walks with a short step, with a forward list, and then he will show that how the hands are showing tremors like this thing. And it's a very typical Parkinsonian gait. The polio is these days not so common, but you should know about it. And there are three important muscles paralysis: the gluteus medius, the maximus, and the quadriceps paralysis. About this gluteus medius paralysis, which gives rise to Trendelenburg gait, we have already talked to you. But more important is a gluteus maximus paralysis gait, which is also called as a king's gait, as the king walk by backward lurch of the trunk at a heely strike. Okay, so gluteus maximus gait is called as king's gait and a rocking horse gait also. So this is, you can see that how a gentleman with a normal this thing is walking. There is no backward lurch of the trunk. Okay, so when there is gluteus maximus this thing, then the body at the heel strike goes back in order to stabilize itself. It occurs at a heel strike on a weakened side to interrupt the forward motion of the trunk. This compensates for the weakness of the hip in extension. This is the typical gluteus maximus gait. The quadriceps gait, we all know that it is called as the five-finger quadriceps. And here, in order to get stabilize the knee joint, there is a forward flexion of the trunk, the foot is in equinal, and the knee is put into extension by the use of the hand. As you can see in this gentleman, hand to knee gait, weak quadriceps, he's locking the knee joint to get the stability. This is called as hand to knee gait. Some other gaits like the genu recurvatum gait, hyperextension at the knee joint, and a slow swing phase. The gait in the cerebral palsy, we see lots of patients with cerebral palsy. The most important gait to appreciate is the gait in diplegic, a seizure gait, because of marked spasticity of the adductor group of muscle. So what the child is trying to do, he brings the knees together and then he's trying to swing the hip joint and knee is in flexion and in a couch position. Just look at this child of cerebral palsy, that he is being supported by his father. And now you carefully see that how he's doing the seizing. See that? He takes the leg and then he takes the other left leg and he's doing the seizing. See that? A typical diplegic seizure gait. Now you see this gentleman, he's trying to demonstrate that how a diplegic gait and seizuring gait takes place. And this is how, because of the lot of the spasm and spasticity of the adductor group of muscle, that he's trying to do the seizure. This is called as the seizuring gait. Lethargic gait in our country, especially in the area of Riva, there is a pulses in which we get this agent. And because of eating that, the patient get a lot of spasticity and they get in a spastic paraplegia. And that is called as the lethargic gait. There is a spasticity, there is a hyperabduction and dragging of the lower limbs. The people walk with the crutches, and therefore sometimes you have to describe the gait. Now all that you have to see whether the patient, it is a 2-point gait, or it is a 3-point gait, or it is a swing through gait. And this is what you can always describe how the patient is walking, whether he's using one crutch, or using two crutches, or is using just dragging the body forward. So remember that the posture of the head, the neck, the thorax, and the lumbar spine all affect the gait, even if sometimes there is no pathology in the lower limb. Confucius, a very renowned Chinese philosopher, he said that I hear and I forget, I see and I remember, I do and I understand. So this is my humble request to all my PGs, is that you try to emulate this gait yourself, and I can assure you, you will never forget these gaits, and you will be able to describe this gait correctly to a panel of examiners in your examination. And I would strongly recommend this book, The Orthopedic Physical Assessment by David Maggie, page 847. Publisher is Elsevier, and they have given a beautiful description of gait, which you can go through that book. And my lecture has been based after reading this chapter. With these words, I thank you all very much for your patient hearing. I'm sure you all must have understood the basics of the gait, which is so very important to orthopedic surgeons. Thank you all.
Thank you very much, Dr. Taneja. That was excellent, and a lot of information conveyed in that talk. I think the next speaker is going to be Dr. S.S. Mohanty, who's going to talk about hip examination. Please keep your questions ready for the end of the session, where we'll have a question and answer session and discussions. So over to you, Dr. Mohanty.
Good afternoon. Thanks, John. I'll just share my screen. Am I visible and audible? My screen is visible?
Yes,
okay.
Absolutely. Yeah.
Okay. Thanks, John. Respected teachers in this group and dear friends, I'm greatly indebted to Professor D.K. Taneja for giving me an opportunity to share my views about hip examination in this 26B Mukhopadhyaya International PG Instructional course. And it's been a pleasure and honor also to be part of this course in the past as well. Now, for the students who are attending this, as you know, though Corona has played a havoc throughout the world, but to take a positive note, it has also helped us to be together on a virtual platform. It won't be possible, today that from all over the world's best of the teachers are there on this platform to teach you, and you can acquire knowledge from each and everybody. No, I have not moved my slides. I'll do that, sir. And yes, I'm doing that.
Hello?
Are you able to hear me?
Yes,
yeah.
Please go ahead.
Yeah, I have not moved my slides. Okay. So,
Dr. Mohanty, your slides are not moving. Sorry to disturb.
No,
but
I
your
have
slides
not moved
are
my
not
slides.
moving at all.
I have not moved my
first slide.
Yeah, I'm with the first slide only. I have not started moving. Now it will move. Now it is moving. Yeah. Okay. Thanks for that. Okay. So the world's best of the teachers are there on this virtual platform to teach you today. And really, it's a pleasure and honor to be here. And I learned a lot from the GATE lecture. I always learn more and more when Dr. Taneja gives his GATE lecture.
Dr. Mohanty, we again have the same problem.
Sorry?
So you just need to, don't expand this. Just present the way you are, all right?
Now,
don't try to expand the middle bit. And you should be all right.
And are you able to see my slides?
Yes, I think we can see all right. He hasn't actually moved his slides. So once he does, we'll know if he's working all right or not. So carry on, Dr. Mohanty.
Okay. So I'll move on.
Yeah.
So you must remember, you should read this book as thus. All your examiners have gone through this book in detail, and they will ask questions only from Esdas. There are other books are also there, but make Esdas as your Bible, because here the long cases is given and you have to proceed in an order. This book I bought in 1986 when I went into clinical years, and for the last 30 years I'm having this book, and every time I read I also get more and more, right from the medical till I passed my MS Ortho, and also being a teacher in a premier institute also. Now, first thing and important thing is the history. History is his story. You must listen to this patient very carefully, because almost 50% of your diagnosis can be done from the history itself. The age of onset of the symptoms, right from the childhood, it until 5 years, it is maybe, related to the dysplasia or developmental dysplasia. 5 to 10 years, it is something to do with probably Perthes disease. Then 10 to 20 years, 15 to 20 years, it may be sleeve capital femoral epiphysis. 20 to 40 years, it may lead to some kind of inflammatory arthritis. And 40 to 60 years, secondary osteoarthritis, and beyond 60 years, it is a primary osteoarthritis. And please remember that tuberculosis is very common in our country. Still, we see many cases of tuberculosis of the hip, and tuberculosis can occur at any age, right from childhood till adult and the old age. Next, we discuss about the pain, swelling, loss of function, and I'll tell you a little bit detail about this. Now, pain, when the pain started, what is the duration, hours, days, weeks, or years? Of course, if it is, within a couple of days, then it may be related to some traumatic episode, or it may be weeks and years, it may be some kind of arthritis. What is the character of the pain? Usually, sharp shooting pain occurs in fracture and muscle tear, but in a dull-looking pain, maybe due to arthritis. How is the radiation of the pain? Usually, hip pain may radiate to the knee. Sometimes, small children, Perthes disease, you may ask the history, and the children will point out that there is some disturbance. Can you please mute? The pain may radiate to the knee. So, it is
can I
due
just
to the
request, sorry, just the people who are taking care of the broadcast, make sure that everyone is muted and except the speaker, okay?
Live.
Too much disturbance coming in from people, yeah?
Okay. You can mute him, possible. Okay. So the pain may radiate down to the knee. That is because of common nerve supply. Sometimes, examiner tries to ask you that which nerve is responsible for this. Remember the Hilton's law, the nerve which crosses a joint supplies, that joint. So it is mostly in, knee medial aspect, the obturator nerve, which is responsible for common supply between the hip and knee, and that's why it radiates down to the knee. And small children, they may complain of pain in the knee more, and when you examine the knee, you don't find anything, whereas if you just move the hip, you will get an idea that there's a hip joint affection. So pain in the hip radiates towards the knee, but rarely it will go down below the knee. If the pain is going down below the knee, that means it is something to do with the spine. So you have to suspect that there might be some spine affection. Now remember this mechanical type of pain, they get relieved with the rest and get aggravated with the activity. For example, avascular necrosis. So there is a segment which is avascular necrosis, and that's why there is some restriction of movement in some position. They get relieved with rest and aggravated with the activity. Whereas inflammatory kind of pain, like rheumatoid arthritis of the hip, the pain get aggravated at the rest. That's why this patient, they get morning stiffness, and once they are mobile, start walking and all, the pain gradually becomes eased off. So they get relieved with the activity, this inflammatory kind of pain. That is because of the inflammatory mediators which are accumulated inside the joint, they gradually released into circulation and pain becomes better. Whereas infective and neoplastic pain, they are present in the rest, but with activity they get aggravated. Especially this kind of patient, they present more of a night pain kind of thing. You must have seen patients of tuberculosis and or any tumors. So the night pain especially, and with activity, this pain gets aggravated. So you must remember certain principles so that in order to get a differential diagnosis. Now swelling, what is the site of the swelling, what is the size of the swelling, onset, duration. There is a whole chapter on the swelling in this SAARC book. You can go through that. When there is a swelling present around the hip joint, just describe that swelling depending upon this, where the swelling is there and what is the character of that swelling. And whether it is associated with pain or painless swelling. Painless swelling sometimes may be a cold abscess which is there present in the hip, trickle down from the pelvis or somewhere, and that may give rise to painless swelling there. Now, limping is usually noted by the relatives first. Patient doesn't know himself, and later on, patient becomes aware. What is the onset, duration, whether it is associated with pain, and whether in the ambulatory status of the patient. That is extremely important. How the patient is mobile, whether he is using a stick or a walker or some kind of thing. So, ambulatory status about the patient, and the gait has been discussed extensively by Professor Taneja sir. The lurching gait usually painful. Never ever tell lurching gait without pain. Lurching gait is usually associated with pain. Trendelenburg gait, waddling gait, when there is a bilateral involvement, there is of the congenital dislocation, if that is waddling gait, and unilaterally there will be Trendelenburg gait. Next, past history is important. Whether there is history of trauma and all these things, all these symptoms which followed the traumatic episode. So that will lead to certain things. Whether there is a history of tuberculosis or any surgery done around the hip region. If there is surgery done, there will be some incision mark, and depending on the incision mark, you can guess that what kind of surgery was done. Whether the patient had some skin disorders and what are the drugs taken. Many drugs which has got effect on the hip joint, especially steroid intake. You must ask these patients. Patient never cannot tell that whether they has taken a steroid, but usually chronic dermatological conditions, asthmatic condition or respiratory conditions, or any nephrotic syndrome kind of chronic kidney conditions. These are the three conditions people take, or the physician prescribes steroid commonly. So you can guess from that they might have taken steroid. Sometimes a young patient to build up the body, they take steroids. So that may be a reason of avascular necrosis. And of course, nowadays with COVID, we are seeing many patients who are post-COVID osteonecrosis of the head of the femur. And now we are taking routinely history, whether there is a COVID affection or he was admitted to the hospital where he was treated with steroids for a acute fulminant COVID. So these are the important history taking that you must take in the past history. Personality was the occupation of the patient, because that has got a bearing on your treatment, that whether to allow what kind of work to be done, what is the work tolerance of the patient. Diet, smoking and alcohol, both are important for an avascular necrosis point of view, and smoking has got a cumulative effect. So chronic smokers can develop avascular necrosis, whereas alcohol also has got a cumulative effect that, if he takes at least 400 ml of alcohol for the last 10 years, 400 alcohol weekly for 10 years, then there is a significant increased risk or relative risk of increase in avascular necrosis is more compared to person who is taking less than 400 ml of alcohol per week. Post-menopausal history is especially important from osteoporosis point of view. Family history, you must take history of tuberculosis in the close contacts. Whether is there any dysplasias which runs in the family, metabolic storage disorders, and of course inflammatory arthritis like rheumatoid arthritis may run in the family. So that will give you an idea that what kind of arthritis this patient has. Next we come to the examination. So the prerequisites for examination is that patient should be dressed enough to cover the private parts. You have to take care of the patient's privacy. Patient should be lying down on a hard bed, and you should do all the markings with a skin marker. From examination point of view, of course, daily you don't do, but when you are appearing at an examination, it is expected that you mark with a skin marker. And especially if there is a female patient, remember to keep a sister at standby. And if the sister is not available, at least you keep the relative, standing there near you when you are examining the patients. Now, as you know, the hip examination, inspection, palpation, movements, measurements, special test, gait, other system examination like spine and SI joint. As Professor Taneja told, gait you should tell first, but all of us, we just tell our students that to tell the gait last, because people is always fear to answer about gait. Gait is a difficult subject. So if you are confident enough of answer that all other things, then probably it will be easier to answer the gait at last after the examination is over. Now inspection. So you examine the patient from the front, see the attitude and alignment. Is there any fixed deformities? See that both the anterosuperior spines both are same level, the level of the knee and the ankles. Whether there is wasting of any muscles like adductors and quadriceps. Is there any swelling, scars or sinuses which are visible? From the behind, you see if there is a scoliosis which is visible, whether the scoliosis is a primary or secondary. When you bend the patient forward, you will get to know that. If it is correctable, then it's probably secondary scoliosis. Then you have to see the posterosuperior spine, gluteal folds, etc. One word of caution is that sometimes, because of flexion deformity, the flattening of the buttocks may appear, so there is a loss of gluteal fold. So that may give you an erroneous idea that there is a flattening of the gluteal fold. But flexion deformity, if it is there, there is a possibility that it may be like that. From the side, you can see that what kind of deformity is there, as well as you can see the scars, whatever is there, what kind of surgery has been done. You can get an idea whether it's a posterior approach, whether it's a lateral approach or an anterior approach from the surgery. So kyphosis, lumbar lordosis, all these things can give you an idea from the side position. Next, you make the patient supine. Supine, first thing what you see is the attitude of the hip, knee and ankle, and lumbar lordosis, whether the increased lumbar lordosis, whether both the anterosuperior spine are at the same level, and the greater trochanter position and the prominence on either side. You can see the greater trochanter. Remember, the first thing what you tell in an inspection is the attitude of the lower limb. Next, to talk about the deformity. So attitude of the lower limb might be externally rotated or something like that. Then you tell about there is a hip appears to be flexed, knee appears to be flexed, ankle to be plantar flexed, like that. You can tell about in each joint what is the deformity, and it is the position on which the patient is lying comfortably. It is not that patient is keeping in some position, but it is a position when the patient is lying comfortable. That is the attitude of the limb. Next, you palpate, and remember during palpation, the first thing is look for the warmth, then tenderness, then the scars, and look for the deep tenderness, especially the lymph nodes. And sometimes the examiner tends to ask you about the lymph nodes around the hip joint. Remember, there are the superficial group are three groups, that superomedial and superolateral, and one is inferior superficial. So these are superficial group of lymph nodes, and there is one group of deep inguinal lymph nodes. And sometimes the examiner may ask you that hip joint drains into which group of lymph nodes. So the anterior part of the hip joint drains into deep inguinal lymph nodes, whereas the medial and posterior part, they travel along the obturator vessels to the internal iliac nodes. So some books you will find deep inguinal nodes, some book you may find internal iliac nodes. So if you are clear, then you can answer that which part of the hip drains into which group of the lymph nodes. On the palpation, next you confirm the findings on your inspection. The important thing on the palpation is about a hip joint line. Remember, there is an anterosuperior iliac spine, there is a pubic symphysis, and there is a pubic tubercle. So the line joining the pubic symphysis to anterosuperior iliac spine, the midpoint is known as the mid-inguinal point. Whereas the line joining the pubic tubercle to the anterosuperior iliac spine, the midpoint is known as midpoint of inguinal ligament. And hip joint line is about 2 centimeters below and lateral to this mid-inguinal point. Sometimes, people get confused about this, but remember, if you remember this diagram, it will be easier for you to, answer that this is a mid-inguinal point, and midpoint of the inguinal ligament is lateral to mid-inguinal point. That is because the pubic tubercle remains lateral to the pubic symphysis. So that is how it is related to the anterior joint line. Sometimes, some examiners may ask you, but routinely you don't comment about the posterior joint line. It is the point which is at the junction of the medial 2/3 and lateral 1/3 of a line joining the posterosuperior spine and the tip of the greater trochanter. So you draw this line, divide into 3 parts at the junction of the medial 2/3 and lateral 1/3. But because of the thick muscle around there, the gluteus maximus, it is difficult to palpate the posterior joint line. But if somebody asks you, then you can at least answer that there is a posterior joint line landmark. Next, you go after doing the palpating the anterior joint line and looking for the tenderness, go gradually laterally, the anterosuperior spine, go towards the iliac crest and to the posterosuperior spine. So you palpate and mark, and then you go down to the greater trochanter. So from anterior joint line, anterosuperior spine, iliac crest, posterosuperior spine, then you go down to the greater trochanter. So what is the level of the greater trochanter? If there is any broadening or thickening, or is there any tenderness in the greater trochanter, the edges, margin, contour, all these things you have to mention in your examination. And of course, at last you give a bitrochanteric steady pressure, so that in order to know that if it is painful, then probably there is a hip joint pathology, which will differentiate from any other pathology which is lying locally there anteriorly. And last thing in palpation is the vascular sign of Narath. Remember this vein, artery, and nerve. This is a relation of neurovascular structures at the anterior part of the hip joint from medial to lateral side. So artery remains in the middle. So you palpate the artery, and if the artery is palpable, then you tell that vascular sign of Narath is negative. If it is not palpable, then vascular sign of Narath is positive, and it happens in dislocated hip or CDH cases, it might be positive. Here also there is sometimes some confusion occurs during examination, but remember, false palpable, vascular sign of Narath negative, false not palpable, vascular sign of Narath is positive. Next we come to the movements. The most important aspects of the hip joint examination is movements and measurements. So these are the movements which possible in different planes. In the sagittal plane, there is flexion and extension. Normal amount of flexion in extended knee is about 90 degree, and in a flexed knee about 120 degree. Extension is about 15 degree, and abduction and adduction. Abduction is about 40 to 45 degree, and adduction is about 30 degree. And in the vertical plane, the movements are in the external rotation and internal rotation. So external rotation is about 45 degree, and internal rotation is about 30 degree. So there, which movement takes place in which plane you must know: sagittal plane, coronal plane, and vertical plane. And in case of fixed deformity, your starting point will be the degree of deformity. So if the 30 degree flexion deformity, you tell there is a fixed flexion deformity of 30 degree and further range of motion from 30 to 70 degree, which is painful or painless. Now, while talking about the movements, always mention about how much fixed deformity is present, what is the further range of movement which is possible, whether it is active or passive, and whether it is painful and painless. Okay, these are the things you must characterize. So the caution, one word of caution, that you have to stabilize the pelvis and always compare with the normal side. So this is Thomas test. If you are unable to tell anything about the Thomas test, then you are likely to fail in your examination. It is extremely important and very basic test of the hip examination. Thomas test is done to know about fixed flexion deformity. So when you make the patient lie down on a hard bed, you can insinuate your hand and see there is a increased lumbar lordosis there. So after that, what you do, the normal leg, you tell the patient to flex, and when you flex the normal leg, see that the lumbar lordosis is just obliterated. Okay, and the amount of angle which is made by the thigh of the affected side with the horizontal is the amount of flexion deformity. Remember, sometimes you tend to do more of flexion, so there is hyper, kyphosis, or the lumbar lordosis may be corrected to greater extent, giving rise to a more, flexion deformity. So what in that case, what will do? You just flex, just the lumbar lordosis gets obliterated, and you just try to, extend the hip little bit and see that again that lumbar lordosis is appearing. So that is the point where you must see how much flexion deformity is there. Sometimes the patient tends to flex himself. So you will you will just passively try to correct it and see that the lumbar lordosis is just appearing. So before the lumbar lordosis appears, how much angle is there? Is the amount of flexion deformity. So this is in a diagrammatical format that you flex the hip, just the lumbar lordosis gets obliterated. You may not have to flex it completely on the abdomen. It may be, something like 110 or 100 degrees, that when the lumbar lordosis gets obliterated, and that is the time you measure this angle, that is the amount of flexion deformity. Now, sometimes, while talking about a flexion, the patient drags the feet to show the flexion. If he drags the feet on the bed itself to show the flexion, it is not an active flexion. It is a passive flexion, and the examiner may try to trap you in this, that how much flexion that, you will tell that the active flexion this much, but remember, since he's taking the help of the bed, so it is a passive flexion which is there in the hip joint. Then you are asked questions like whether both hips are affected, how will you see the flexion deformity? You will tell that one by one. First do one side, Thomas test, see that how much flexion deformity is present on the right side. Then you do in the opposite way to look for how much flexion deformity is present. Or else like this, you can flex both the knees, the lumbar lordosis gets obliterated, then extend one hip to see that when the lumbar lordosis just appears, and that is the amount of flexion deformity in that particular leg. When there is associated a knee flexion deformity also, then what you do, you take the patient to the edge of the table so that knee flexion deformity is avoided, and then you can do the Thomas test at the edge of the table to see that how much deformity is present, like it is shown in this picture. So that is how these are the couple of tricky questions which are asked in the examination. Extension, you have to make the patient lie down prone on the couch, then immobilize the pelvis in one hand, then try to extend the hip. That will give rise to extension. How much extension is present? Suppose there is a fixed flexion deformity, never ever tell that extension is there so much. That means there is no extension, or extension is 0. Next, in a fixed coronal plane deformity, abduction or adduction deformity, how you will square the pelvis. When the right side is affected, there is a fixed adduction deformity. This side anterosuperior spine goes up. So in order to square the pelvis, you have to adduct the limb further down to bring the anterosuperior spine both at the same level. So when you bring the anterosuperior spine at the same level, this is known as the squaring of the pelvis. Similarly, in this patient, that you see there is a anterosuperior spine has gone down, so you have to adduct it further, and the amount of adduction which was required in order to bring the anterosuperior spine to the same level is the amount of adduction deformity which is present. So what happens, sometimes you may do further adduct it. So in order to again see that properly, so you abduct the limb little away. So see that when the pelvis is moving, then that is the point where you measure that amount of adduction deformity. Like in flexion deformity, you passively do little extension to see that lumbar lordosis just appears. That is the amount of flexural deformity. Here you abduct the limb little further in order to see that when the pelvis is not moving, then that is the point that you measure the fixed adduction deformity. On the opposite side, when there is a abduction deformity, right side is affected, the anterosuperior spine goes down, and hence you have to abduct the limb further in order to bring both the anterosuperior spine to the same level. Now, again, you have to, when you are measuring the abduction deformity, you adduct it little bit to see that pelvis is moving. So that point you measure that how much abduction deformity is present. And one word of caution here, that always inspect from the top so that you see that anterosuperior spine at the same level, or else there might be some parallax error giving you erroneous deformities. Now, sometimes question is asked, how will you measure the fixed coronal plane deformities without moving the hip? Then you answer that I will draw the Coteries angle. That I draw a midline there, I join 2 points of anterosuperior spine there, and next I draw a perpendicular from the affected hip to the midline, and the amount of angle, that angle tells you that is how much of adduction or abduction deformity is present. In this particular case, suppose right side is affected, so right anterosuperior spine has gone up, so this much amount of abduction deformity which is present there in this hip. Now, sometimes people ask, examiner ask, when the hip is very painful, how will you move the hip when it is very painful? Patient will complain of pain. You have to answer that I'll join both the ankles and move both the lower limbs together to square the pelvis. Okay, so that way, because the other leg will act like a splint, and hence it will be less painful for the patient. Remember, if there's a bilateral fixed coronal plane deformity, that means one side abduction, one side adduction, or both side abduction, and then you cannot square the pelvis. This is sometimes, examiner tries to trap you that when the bilateral coronal plane deformity is, how will you square the pelvis? That pelvis cannot be square. Next, you come to the rotational deformities. Internal rotation and external rotation always measured. Second toe is taken as the axis. So from the vertical, how much internal rotation you can measure like this. And if you are able to flex the hip to about 90 degrees, then also you can measure it, with a line which is parallel to the axis of the body, then how much is the internal rotation is there. Okay, that angle you can measure with your goniometer. Similarly, external rotation from the vertical, how much the second toe is deviating in the external rotation. In flexed hip also, you can measure the external rotation, that you take the foot in, then the hip rotates externally, you can measure it. So rotations are slightly more in knee flexed position. That is because the ligament below is relaxed, and hence the hip moves little further. And rotations can be measured again in prone position, exactly by keeping the hip in extension. Now, two things which is important in about rotations is sectoral sign and axis deviation. Remember, in case of avascular necrosis, when the anterior, superior, and lateral part of the head is, osteonecrosis is there, when the hip is flexed to 90-degree, limb goes into external rotation. So that is known as sectoral sign, which is usually seen in avascular necrosis. Another thing is axis deviation, which is asked, especially in, slipped capital femoral epiphysis, that when on full flexion hip and knee, limb is directed to the ipsilateral shoulder, then that is known as axis deviation. Normally, it should direct to the opposite shoulder. So as I told you, rotations also can be checked in the prone position. Last part of the examination is the measurements, that you measure the muscle wasting and all these things lines. I'll tell you a little bit in detail. The muscle wasting, you take a fixed bony landmark, either the epicondyles or the condyle of the tibia or the knee joint line, and take a fixed distance from there and take a measuring pad and measure the diameter of the thigh, and you compare with the opposite side. That is how you measure the muscle wasting. Next, we come to the apparent length and true length. That is another important aspect where the patient, the candidates fumble during examination. Remember, while measuring the apparent length, both the limbs should be parallel or lying in that position, and it is measured from the midpoint like Giffesternum or Manubrium sterni to the tip of the medial malleolus on either side in order to get the apparent length. Whereas true length, remember the pelvis should be squared. As I told you earlier, how to square the pelvis. Both the limbs should be kept in the identical position. That means if the knee is flexed in some side, then the other knee also has to be flexed while measuring the true length. And always it is from the anterior superior spine to the tip of the medial malleolus. This is how true length and apparent length is measured. Remember, there are two things, apparent length and true length. True lengthening of the hip is very rare, except, when there is a neglected anterior dislocation of the hip, there you will get true lengthening, which is a very rare. So most of the time you will find in your patient, there will be true shortening. And you will have an apparent lengthening and shortening. If your apparent length and true length both are same, that means there is no coronal plane deformity. Okay, remember. But if there is apparent lengthening, most likely there is a abduction deformity. But if there is apparent shortening, both adduction and abduction deformity is possible. And for every 10-degree deformity, remember about a 1 centimeter of limb length discrepancy is usually there. And this is most important slide that people confuse about that. Adduction deformity, what happens, the true shortening gets exaggerated by the deformity. And it is always the apparent shortening, whatever, is more than the true shortening. So when the apparent shortening is more than the true shortening, then there is a adduction deformity. Whereas in the abduction deformity, what happens, the true shortening first gets compensated by the abduction of the limb, and then there is a lengthening. So here the apparent shortening will be less than the true shortening, or apparent lengthening will be more than the true shortening. So there are two situations here. So when the apparent lengthening is more than the true shortening, usually candidates will tell that there is a about say 3 centimeter lengthening, so you can tell 30 degree of abduction deformity is present. But candidate fumbles when there is an apparent shortening becomes less than the true shortening, because it has already compensated, then it has become shorter. So here also the deformity is a abduction deformity. When you see more and more cases, you will get to know about this. But remember these 3 scenarios for your lifetime. So during true length, brand strangle, then brand strangles, pelvis should be squared, and both the lower limbs should be put in the identical position. So if it is flexion deformity, then you have to put the other leg also similar amount of flexed position. And it compares the both sides, not much helpful in the unilateral pathologies. So you join the anterosophilia spine to the tip of the greater trochanter, draw a line perpendicular to the bed or the horizontal, and measure this distance and compare with the both sides. So here you will know that this much amount of shortening which is there, supratrochanteric, that means it is above the trochanter, this much amount of shortening which is there at the joint level. Now, Nelletron's line is helpful in bilateral hip pathologies. So remember, Nelletron's line, different books have written 30 degree, 90 degree. It's an arc of motion, and always the greater trochanter remains touching this or below this line. So draw a line anterosophilia spine to the ischial tuberosity and see that whether the greater trochanter remains below or at that level. If it goes above, that means there is a supratrochanteric shortening. So it is better to do at 90 degree if possible, because greater trochanter becomes more prominent during that time. But if it is 30 degree, 40 degree, doesn't matter. You can see it, check it on both sides. And in bilateral hip pathology, it will give an idea if both sides there is a supratrochanteric shortening. The Shoemaker's line, normally you join the greater trochanter to the anterosophilia spine, then extend this line. Both the lines usually meet at or above the umbilicus, but if they meet below the umbilicus, that means both sides greater trochanter has gone up. And if one side it meets, then you can know that unilateral pathologies, and you will get detail when you examine more and more patients of this kind of bilateral hip pathologies. Remember, in bilateral hip pathology, Nelletron's line and Shoemaker's line are helpful to see the shortening, but brand strangle is only helpful for unilateral hip pathology. Next comes the special test, Trendelenburg test. Already, Taneja sir has told you about this. Negative Trendelenburg test, when this side hip, the leg which is elevated, has gone up because of contraction of the abductors on this side. That's why it has pulled the pelvis down and it has gone up. Whereas positive means it has dropped down. That means this side of abductors are not functioning, or the fulcrum or the center is not functioning. That's why this side abductor deficiency is there. That's why it has gone down. Sometimes patients should do exaggerated Trendelenburg test. This is a compensated Trendelenburg test when it tilts the upper trunk significantly to maintain an upright posture. So this is not exaggerated Trendelenburg test. Trendelenburg test, remember, should not be performed when there are coronal plane deformities, when the flexion deformity is more than 30 degree, or the patient is unable to stand unsupported. Any painful hips or ankylosed hips, and in case of children in less than 5 years, usually Trendelenburg should not be performed. Now, telescopic test.
Conclude, because your time is up.
Yeah. I'll just conclude. So this, you hold a hip in knee 90 degrees and just give couple of pushes to know the telescoping test. Ali's test to know shortening of the tibia from the front, shortening of the femur from the side. Autolani and Barlow to remember Baharlow, or the clunk of exit is Barlow's test. Autolani is Underlani or Autolani test. This is flexion, abduction, external rotation, or Patrick test to know if there is any iliopsoas or SI joint dysfunction. Fadel test, flexion, adduction, internal rotation to know about impingement of the hip, or is there any piriformis syndrome, then this test will become positive. And of course, gait, you have listened to the lecture. do not forget to examine the spine, SI joints, and both the knees. And you will, how will you test the SI joints without moving the hip joint? You have to do compression, distraction test, or Gunslens test. So then you give a clinical diagnosis, synovitis or arthritis or unstable hip or coxavara or protrusio or ankylosis. So take home message, do a careful history taking, do a meticulous examination in order. You must remember about Thomas test, squaring of pelvis, upper and true length in detail, because there you are cut in the examination. Special tests like Pranaw mount telescopic you must perform. And remember there may be associated spine or SI joint pathology. So you have to test for that. And then you have to give a summary with a provisional diagnosis. I thank you for a patient hearing.
Thank you very much, Dr. Mahanti. I think that was an excellent talk with a lot of informative sort of tips and tricks. So we would now request the next speaker, that's Dr. Bangani, to talk to us about examination of the knee. Thank you very much, Dr. Mahanti.
Thank you.
Good afternoon, everybody. I'm going to talk about the knee examination. Now, the agenda of this talk will be a revision about your knowledge you already have. We'll show you some video, some clinical demonstration, and then at the end, the students' participation about this talk. The knee joint is a triaxial joint. That means it has a flexion, extension, and lateral rotation. So this is important. Now, there is a lot of synovial reflection, which is extensive and complicated. You must understand that vastus medialis is the main dynamic stabilizer. Excursion of the medial malleolus is less than lateral malleolus. The restraint anteriorly and posteriorly are the anterior cruciate ligament and posterior cruciate ligament. Now, the weight transfer of your body to the knee joint is about 60% from the medial side and 40% from the lateral side. Why it is 60% from the medial side? The normal alignment of the knee joint is about 3 degrees varus. And so that's the short axis of weight transfer, and hence the more amount of body weight is transmitted medially. Next. Now, you must know about certain bursa around the knee joint. There are anterior, posterior, medial, lateral. If you look at this, the suprapatellar pouch, but the infrapatellar bursa, the prepatellar bursa, the pes insarine bursa, and posteriorly the bursa between the biceps tendon and the semimembranosus. Now, like it has been said earlier, history can make a 50% of your diagnosis. So you listen carefully. You can have a knee, we divide into two, a traumatic knee and a non-traumatic knee. The traumatic knee could be acute or it could be chronic. So while you are taking, don't forget the joint above and below, which has been discussed earlier also. So because your knee pain can come from the hip joints, from the sacroiliac joint, from the foot, so you have to examine accordingly. Now on examination, you have certain things which you look into it. Gait, you examine the patient standing, sitting, squatting and supine, and prone. Squatting sometimes is difficult if the patient has a knee joint injury or arthritis. Gait, Dr. Taneja has discussed it in very detail. So these are the gaits which are related to your knee joint pathology: Enterolateral gait, knock knee gait, genu Rickerwater gait, etc. Now the deformity. What are the deformities of the knee? So it's sometimes very confusing what is varus, what is valgus, especially for the student. So it's a simple way to learn is you draw a line from the center of your body to the floor or to the feet. And if your foot is close to the central line, or pointing towards the central line, it's the varus. And if it is pointing away from the central line, it will be valgus. So this is how you see here. And then the third deformity is the recurvatum, which you can see from the side, the hyperextension of the knee joint. Now these common, not very common terminology, but you have to understand this, that the position of the patella on the X-ray of the knee joint. There are two types, the patella alta and patella baja. Patella alta means your patella has been shifted proximally and patella baja is shifted distally. Now, normally, if you look at it, that you have an intercondylar line which comes down here, and your inferior pole of the patella should be close to it. Now, if it's further down, it's called patella baja. And this is because of some contracture into your hip joint or any shortening. Q angle about the knee joint, it's a simple thing. It's usually tells you about the varus valgus of the knee joint. It's formed by a line drawn from the tibial tubercle to the center of the patella, and then a line drawn from the anterior superior spine to the center of the patella. Normally, it's about 12 degree in a female, 15 degree in the male. If the angle increases, it tells you valgus deformity of the knee joint, and if its angle is reduced, it shows the varus deformity of the knee joint. Now we divide our talk into two areas, a traumatic knee and a degenerative knee or non-traumatic knee. So when you have a trauma, these are the structure which can be affected: bone, ligament, single or multiple, capsule, usually associated with ligament injury, and with severe injury of the knee, you can have a muscle injury also. Traumatic deformity, two important things which you must ask in the history. What was the mechanism of injury? What was the position of the leg? What was the position of the knee? What was the position of the body? And then secondly, whether it's a high energy injury or low energy injury. High energy injury means you have an automobile accident with high speed. Low energy injury means you're falling down from the stairs or something like that. Because this is important. When you have a high energy injury, you have involvement of the bone, muscles, tendon, and the capsule. Now, for any other examination in the body, there are certain things you must do: inspection, palpation. So in inspection, you look for any swelling, the swelling, contusion, abrasion, laceration, and see for any deformity. If the patient leg is lying down, whether it has a deformity, like if the patient has a posterior cruciate ligament, he will have a sagging. So the inspection is very important, and note of it. Palpation, superficial and deep. Now the palpation of the area of the soft tissue, which is the superficial, and deep, which goes to your bone and the collateral ligaments. On palpation, you should note the tender point. You must palpate the bony attachment of the medial and lateral collateral ligaments, because it tells you which side of the ligament is being injured. And you must check the joint above and below, and always see the popliteal area, because the capsule might be injured, or you may have some more injury to the posterior part of the knee joint. And you must check the neurovascular status of the lower extremity. Now, the injury to the extensor mechanism is mostly common in the sports people. It's not very common into the automobile accident, etc. Now, the extensor mechanism injury can be incomplete of the partial tear of the quad. It could be a complete quad tear, patient may have a fractured patella, you may have injury to the ligamentum patelli, and rarely you see the avulsion of the tibial tuberosity. These things should be examined properly so that you won't miss the diagnosis. Now, in the history, patient who has sudden pain, he has a sudden swelling. Now, if you have an injury to the knee and the knee swells up right after your accident or right after your injury, and there is quite a bit of fluid in the knee joint, it suggests that there is a definite intra-articular injury to the knee joint. Sometimes the patient who had a knee may have a torn meniscus. He keeps the knee joint in a slight flexion. These patients definitely will have difficulty in weight bearing. And if it's a later date, patient may have a history of locking or giving way. Now, the next thing we need to know whether the knee is stable or it's unstable. So what are the tests for the stability? As I have said already, that in the history, you must see that patient had a rotational injury or a strip stress injury, because it tells you which part of the ligament might be injured. So we must ask in that history. Now, instability can be in sagittal plane, in coronal plane, and in rotational plane. So we talk about these one by one. Ligament injury, you must feel the tenderness over the bony attachment of the MCL and LCL, medial collateral ligament, lateral collateral ligament, and posteriorly. The injury can be in the knee, it can be one plane or it can be two plane. The one plane means you have an injury either to the medial collateral ligament, lateral collateral ligament, ACL alone or PCL alone. Now, to check the laxity, there are various tests which I'm going to discuss with you. Now we talk about the single ligament injury. Let's say if it's a medial collateral ligament injury, you do the valgus test, which I'm going to show you some video. Now you check the valgus test, you do it in full extension of the knee and then in 30-degree of flexion. When you do the full extension of the knee and you have an opening of the medial joint suggestive of the medial collateral ligament, then it is definitely associated with either anterior or posterior cruciate ligament injury. While if you flex the knee at 30-degree and you get the medial stress, you do the medial stress test, then it's only the medial collateral ligament. The same thing is for the lateral collateral ligament. Now here is just a picture of it. As you see that you hold the distal femur tightly, bend the knee, and do the varus or valgus test. You do it in full extension and then you do it in 30-degree flexion. You see the obvious quite a bit laxity of the lateral collateral ligament. And this is the simple way to examine it. Now, we talk about the cruciate ligament. We have anterior posterior cruciate ligament. For anterior cruciate ligament, we'll have Leachman test and anterior drawer test, and posteriorly posterior drawer test, which we'll be discussing. Now, this is just showing the Leachman test. You hold the distal femur very tightly from your one hand. Another hand is like it's shown on your thumb on the anterior tibial spine, tibial tubercle, and move the tibia forward and backwards. If you have ACL tear, the tibia will fall back. And so when you move the tibia forward, it comes back and reduces on itself, which will be shown to you. Now here it is. He's demonstrating it. Hold it with distal femur, hold the proximal tibia, move it up and down, and you see the laxity there and movement. This is a positive Leishman test. Now we talk about the posterior cruciate ligament. I want you to tell one thing which is very important, and you should check on every knee. In a normal knee, when you flex the knee 90 degree, then your medial tibial condyle, medial tibial plateau is higher than the medial femoral condyle in a normal knee. So you put your finger on the top of on the medial malleolus, and you move your finger down, and here the medial tibial plateau should be anterior to the medial femoral condyle. If it is posterior, it gives you a suggestion that you may have a posterior cruciate ligament injury. Now we talk about the two-plane injury or the rotatory instability of the knee joint. There are 4 rotatory instability in anteromedial, anterolateral, posteromedial, posterolateral. What it means that when you have 2 ligament injury, anteromedial means anterior cruciate and medial collateral ligament. Posteromedial means posterior cruciate ligament here as well as the medial collateral ligament here. And similarly on anterolateral and posterolateral here. Now, how to examine the rotatory instability? We talk about the anteromedial instability, which is the tear of the anterior cruciate ligament as well as medial collateral ligament. There are several tests for it, but the most commonly used is the anterior dart test as well as the flexion of the external rotation at 30 degree and internal rotation at 30 degree. Now, this is the basic picture of the anterior dart test. You do the anterior dart test, turn the foot in external rotation, and do it again the dart test, and see if there is if the tibial plateau comes forward medially. That shows that the anteromedial instability is there, and the Slocum test is positive. We'll show you how to do it. And this is a enterolateral instability, which is also a reverse Slocum test and pivot shift test, which we will demonstrate to you just in a minute. Now, here is the patient who has a enteromedial instability of the knee joint. So you flex the hip 45 degree, you flex the knee at 90 degree, put your 2 thumbs on the tibial, either side of the tibial tuberosity, and do the anterior. Then you externally rotate the foot, and then do it again. If you have an anteromedial instability, the medial tibial plateau come forward. When you turn the foot internally and you do the same thing, you notice that the stability has gone out, that there is no more stability, which shows that there is a definite enteromedial instability. Now, the same thing can be done on the enterolateral instability. Now, one important anatomical structure which we must understand it, the role of the iliotibial band in pivot shift test, which we are going to talk about next. Now, the iliotibial band is extensor in extension position and flexor in the flex position, which we will talk about in a minute. Now, pivot shift test. This is being done for the enterolateral instability. Now, what you're seeing here is that you flex the knee to about 90 degree, do a valgus trace from your one hand and hold the foot just above the ankle, turn it internally and extend the knee. And I'll show you the movie, and you will find at about 30 degree of extension, patient have a sudden jerk, a thirst. And what happens at 30 degree, the iliotibial blend displaces from the flex to the external position, and the dislocated tibia will relocate on the lateral femoral condyle. Now here we first do the normal knee. You see the normal knee which is being tested. This is the anterior drawer sign. And you see that we'll check the other knee, which is the affected knee, and you will see the difference between the two. This is the affected knee. And we do the drawer test. You see how the tibia coming forward. Now, then you hold this is just the Leachman test which is being performed. Bend the knee to 90 degree, internally rotate and gently extend. And you see that there is at this point, there is a sudden drop of the feeling in the knee joint. And that's the time the posteriorly displaced tibia will rearticulate with now the same thing, which is called the jerk case of Dr. Houston, is done in the extension. Hold the foot in internal rotation, valgus trace, and flex it, and the same thing will happen. The posterolateral instability, in which you have a posterior cruciate ligament tear and lateral collateral ligament tear. So there are certain tests for that: tibial external rotation test, reverse pivot shift. Like we did the pivot shift just earlier with internal rotation, you do the same test with external rotation and flexion to extension, and it will be positive. And there will be external rotation test. We'll show it to you. Now the posterolateral instability has two components. One is the posterolateral corner injury, which is the arcuate ligament injury, the other tendon injury, and then it association or without association of posterior cruciate ligament injury. When we do the dial test, we will be able to differentiate whether it's only posterolateral corner injury or it's a combination of posterior corner and the posterior cruciate ligament tear. Now, this is the dial test. Patient lying down, you just turn the foot, and the affected foot will externally rotate more than that. Next thing, patient lying down, he's bending the knee, and you see that there is quite a bit external rotation of the knee at the 90 degree. But you have to check it at 30 degree and 90 degree. If it's at 30 degree external rotation, does not increase at 90 degree, it's the posterolateral corner. If at 90 degree, the external rotation increases, like you see it, it's increasing. So that means the patient has a posterior cruciate ligament as well as posterolateral corner injury. You see at this point, quite a bit external rotation, which is suggestive that this patient had a combination of PCL as well as posterolateral corner injury. Now, the third thing, which is common in the knee joint injury, is the meniscus injury. It can be a medial or lateral meniscus. Most of you know the McMurray test. You flex the knee fully. Now, remember, if you cannot flex the knee fully, you cannot run this test. So you flex the knee fully, rotate the foot in external rotation, put your one hand on the posteromedial corner or the medial side of the joint and slowly extend it. And a click at posteromedial corner gave you a suggestion of the medial meniscus. Now the medial meniscus has three parts. The tear could be posterior, the tear could be middle, or tear could be anterior. So when you start the flexion to extension, the first 30 degree, you get a jerk feeling, then it's the posterior medial meniscus injury. Middle part of the meniscus injury and anteriorly part of the meniscus injury. Now you internally rotate and do the same thing. Then it will be a lateral meniscus injury, like you see it, full flexion of the knee, rotation and extension. Now the other test is squat test. It is difficult to do for the patient who had a knee injury, but it's easier, one of the way to find it out. Patient can squat, extend the knee and rotate the knee internally and externally. If he has pain on external rotation, it's the medial meniscus injury. On internal rotation, it's the lateral meniscus injury. Osteochondritis dissecans is not a very uncommon problem. And so this is a Wilson test in which the patient flexes the knee 90 degrees, turn his foot internally, and then gradually extend it. And if he extend it, the moment the femoral condyle, affected femoral condyle come in contact with the tibia, patient will have pain. And if you externally rotate it, the pain goes away. Quickly, we'll talk about the non-traumatic knee joint problem. Like any history for any part of the body, you have to done certain basic things. You must know age, profession of the patient, duration of symptom, short, long term, pain, nature of the pain. Pain is associated with the activity, sitting to standing, running, going up and down, climbing up. Pain has showing suggestive of degenerative arthritis. Coming down, if the patient has pain, it's more suggestive of femoropatellar joint. You check for squatting, fever, fatigue, and weight loss. All these things should be recorded. Inspection, same thing. You check for swelling, suprapatellar swelling or any swelling around the knee joint, any deformity, varus valgus, muscle atrophy, healed scar, redness, that should be checked. Palpation, always check the local temperature, suggestive of any infective pathology or acute pathology. Deformity, varus valgus, swelling, you must check whether swelling is intra-articular, extra-articular. Tenderness, bony, soft tissue, ligament, bursa, which we have discussed. Effusion, it's a very common problem after trauma you have, or even after the degenerative arthritis with minimal trauma, is the effusion in the knee joint. So it may be a mild effusion or it may be a marked effusion. So we'll see about it. If you have a mild effusion, what you do is you push the suprapatellar pouch down and the distal portion up, and it brings the fluid together and you can feel the fluctuation. If you have quite a bit fluid in the knee joint, same thing, push the suprapatellar pouch, fluid into the distal part of the knee joint and tape it, and it will be positive. Trans-elimination can be done, but don't do very often. Synovial swelling. Now, patient who has a chronic problem in the knee joint, they have a synovial thickening. And the feel of the synovial thickening is doughy when you feel it. It's usually a little bit warm. It has a pseudo fluctuation. You feel it. There may be a fluctuation, but there is no fluctuation. The thickened synovium roll under your finger, and the trans-elimination test will be negative. Now we talk about the femoropatellar arthritis. One of the tests is common test is femoropatellar compression test. You compress the patella, ask the patient, flexion to extension, he will have pain suggestive of arthritic changes in the femoropatellar joint. The another thing, when a patient who doesn't have too much damage to the joint, to the femoropatellar joint, you push the patella distally, ask the patient to lift the leg up, and patient will have a severe pain, which is the Clark's test. Friction test for chondromalacia patella, move the patella up and down, move the patella sideways, and patient has pain in extension and flexion, it's positive. The apprehension test is being done for the recurrent dislocation, mostly subluxation and dislocation, knee slightly flexed, and you move the patella. As soon as you try to move it laterally, the patient tries to hold it and the test is positive.
So,
Squatting position, this is
please try to conclude. Okay.
Yes, sir. Yes, sir. Getting up from the squatting position, it causes the force on the back of the patella is 6 times to your body weight. So squatting to standing is always very difficult if you have a knee problem. Please always check the popliteal fossa, because you have a popliteal cyst or Baker's cyst, but sometimes you may have a popliteal artery aneurysm. You can put your stethoscope on, hear the bruit, and then you can differentiate between the cyst and the movement. We have flexion, extension, internal, external rotation, which about the knee joint. Okay, I'll go. And then there is a measurement, linear and circumferential measurement, which has been shown just in the previous talk. Now to make a diagnosis, history, physical examination, X-ray, stress view, MRI, CT scan. So these, always remember, when you take an X-ray of the knee joint, get in its standing position. AP views to give you the alignment of the leg. Lateral X-ray, 30-degree flexion, which is best than skyline view. 30-degree flexion, the Merchant's view or Laurent view is being done the way it is shown, and it shows you the knee joint beautifully, femoropatellar joint beautifully. So now if you can perform varus valgus test, Leishman test, Drawer's test, anterior posterior drawer test, Slocum test, pivot shift, dial test, and McMurray test. If you have done that, I think my purpose is solved. Thank you so much.
Thank you very much, Dr. Bangani.
Thank you, sir.
If you can, great. That was excellent. A lot of material to cover there. And I think the next talk is mine, which is on elbow, the examination of the elbow. So I'll try to finish in time so that we have some time for the questions. So I think just checking, is the slides okay? You can see it. Hello? Can anyone just let me know if...
Yes.
Okay.
Yeah, your slides are visible though.
Thank you very much. Okay, so I think to start with, we remember that a proper and thorough clinical examination is necessary for your diagnosis. And basically, a proper history guides you to what examination you need to do. It's important that you develop a system for whichever joint you're examining or the patient you're examining, have a system which you stick to when you're doing your examination and follow the sequence that you're supposed to. And remember that every clinical history really starts with every clinical examination starts with a good history, because that is often very essential for you to be able to get a good diagnosis. Now, the examination, once you've done your history, again goes in steps. You start with inspection, which is the look. Then you palpate the joint, means you feel the region or the joint. You do your passive range of movements for movement, and then you have some special tests. And don't forget the neurological examination to rule out any neurological problems in these patients. Now, for the elbow, what do you look for in the inspection? You look for attitude and any deformity. Remember the carrying angle, which is present in elbows. Look for any swelling in the paraolecranon area, the anconeus soft spot, and the radiocapitular joint, because these are the areas where the early swellings will appear. And check the skin for any scars, sinuses, any edema, or engorged veins. And of course, you need to look for any muscle wasting. So all these things come under inspection. Now, when you're dealing with a trauma case specifically, look for any bruising, swelling, or deformity. I think it's important. Sometimes you just look at the X-ray and you may not realize the significance of the injury. and the x-rays may look relatively innocuous. Here you can see a radial neck fracture with a sort of angulation, but it doesn't look like anything that dramatic. But then if you look at the arm and you can see the amount of bruising on the medial side, it should raise suspicions that this is a more significant injury. And if you investigate it further, you can see here this chip from the lateral epicondyle, from the medial epicondyle, where the entire medial ligamentous structure along with the attachments of the muscles has been avulsed. Okay, so, and if you examine this patient, obviously it's difficult to do this in the patient in an acute injury, but here we examined it under anesthesia because we are going to do surgery, and you can see that as you do a valgus stress, you can see the opening out. You can literally see that piece is coming out from the joint. Okay, and at surgery, you can see that there's an avulsion of this little tiny fragment with the entire medial collateral ligament attached to it. And then we had to fix it and also correct the radial neck angulation. Remember that the instability can sometimes be bony as well. So in this case, it was partly ligamentous, but it could be bony as well. For example, in these lateral condyle fractures, which have gone into non-union, you can see how when you give a valgus strain to the elbow, there's a tendency for this to open out. So again, important to check this because that may alter your decision-making in these patients. Olecranon bursitis is again a common problem that you might see from time to time. It could be related to trauma or just the posture where someone is sitting with prolonged pressure on the olecranon. Could be infective, so you need to very carefully rule that out. And some medical conditions such as gout or rheumatoid arthritis can be also responsible for this bursitis. So again, to get your diagnosis, you need to do a good history, a good clinical examination, and make sure you've ruled out infection in those. We talked about the carrying angle, and this varies. If you look at different literatures, you'll get varying angles that you're given. But remember, it's generally more in girls than in boys. And it is to be done with the elbow extended and supinated. So it must be in full extension and with supination. That is when you see the carrying angle, and you need to compare the two sides to check out if there's a deformity. So you can have a cubitus varus or a valgus or a cubitus rectus where the valgus, normal slight valgus is gone and you have a straight arm. So the normal is a slight valgus for the carrying angle. If you have a cubitus varus, it's a deformity, and a cubitus rectus also shows that there's actually some varus deformity. And again, if you have more than full extension, that would be recurvatum. And this is one of the joints where you would test for sort of if there is any of the elastic tissue disorders leading to hypermobility. So cubitus varus is most commonly, so this is one of the cases that you can easily get in your clinical examination. And this is most commonly after supracondylar fractures and results from malunions. Again, it happens in children with a peak age between 4 to 8 years, but can happen at various ages. Very rarely you can have a growth disturbance. So in the history, again, you need to check whether the deformity is progressive or not. So most cubitus varus deformities are not progressive, but if you have some kind of growth disturbance, either due to avascular necrosis of the trochlea or some damage to the physis, it's important to rule that out before you embark on any treatment. On the opposite side, you have the cubitus valgus deformity, and this is another case which could easily come up in your examinations. And here, this is most commonly after non-unions of the lateral condyle. This is often progressive. Like I showed in the earlier case, it may have instability, it may not have instability, and sometimes will lead to tardy ulnar nerve palsy, which takes place often many years after the initial injury. But you need to examine for it. You need to check that the ulnar nerve function is all right. Look for any wasting in the hypothenar muscles or sort of ulnar aspect of the distal forearm, and also for any clawing that might be there. So important that when you see this, you also look for what are the other possible problems that may be there. Again, any fixed flexion deformity in the elbow is abnormal. Normally, your elbow should go to full extension. And if that is not possible, we would call it a fixed flexion deformity. In your palpation, you need to palpate various areas, the lateral epicondyle. Again, if you have a tennis elbow, that will be where it is tender. The radial head, you need to check the medial epicondyle. Look for the ulnar nerve. You can have a subluxating ulnar nerve or a dislocated ulnar nerve. Check the olecranon. Check the distal biceps tendon, which you can easily palpate against resistance at the anterior part of the elbow. Okay. Now, we talked about the cubitus varus deformity and the 3-point bony relationship. And this is an area where there's, again, sometimes confusion because strictly speaking, the 3 points, the medial epicondyle, the lateral epicondyle, and the olecranon should remain in the normal relationship, which is an isosceles triangle with a supracondylar fracture. But what happens when you see these patients with a cubitus varus deformity and then examine them for the 3-point relationship is that because of the callus formation, often what you're feeling is not necessarily the exact point of the lateral epicondyle. You may be feeling callus that's formed there, and therefore you may be mistaking exactly what you're feeling as the lateral epicondyle, and what you mark out as the 3 points will not be an isosceles triangle. So it's important to realize this. So you can see the right has the cubitus varus deformity, and if you look at the 3-point, sort of the 3 points which have been marked out, they do not form a nice isosceles triangle as it does in the normal side, which is the left. Again, some confusion in the elbow about range of motion. Earlier, 0 used to be at 90 degrees flexion. Today, 0 is in full extension. That will be the 0-degree position for the elbow. And every as you flex the elbow, that will be counted as the degree of flexion. Okay. So you need to measure the range of motion in terms of flexion and extension. And that is the main movement at the elbow. And of course, supination and pronation, which is the elbow and the forearm and wrist. So full extension, 0 degrees is with the arm fully extended, and full flexion, which will be around 140, 135 degrees with the elbow fully flexed. Supination and pronation should be done with the arm by the side of the body with the elbow in a fixed position. So very often the patients will move the shoulder to get pronation and supination. So make sure that the pronation supination that you're measuring is right in the forearm and not at the shoulder. Again, use something like shown here, a long item which will magnify any sort of discrepancy or restriction of motion in supination and pronation. Okay, then you need to test strength of the various muscles. And in the elbow, this is really the brachialis, the triceps, and the biceps. Okay, so they're done in different positions. So if you want to test the brachialis, do it with the elbow in pronation. And if you want to test the biceps, do it with the forearm in supination. Similarly, the triceps is, the strength is tested with active resistance against, active extension against resistance, okay? So again, for the biceps, you have some special tests like this hook test where you ask the patient to try to put your finger under the biceps when the biceps is made taut by flexing, trying to flex the elbow. And the squeeze test is when you squeeze the biceps, there should be a movement of the forearm, which will be because the biceps also causes rotational movement in the forearm. The Popeye sign, which is the sign that you get when you have a rupture of the biceps, especially the long head of the biceps, proximally, is the classical sign which is described from this comic character Popeye, who has this bulging muscle. And because of the rupture, the muscle tends to sort of form a ball type of shape, which is classical of a biceps rupture. Cozen sign is for tennis elbow, okay, where you dorsiflex the wrist against resistance with the elbow in flexion, which causes pain. Similarly, if you do the same movement against resistance on a chair, that's the chair test. And the mill test is when you palpate the lateral epicondyle and you passively pronate the patient's forearm, flex with the wrist fully flexed, and then try to extend the elbow. Is again a positive test is indicated by pain over the area. Similarly, the golfer's elbow is shows tenderness on the medial side as opposed to the lateral side over the medial epicondyle. And here you would ask the patient to palmar flex against resistance, and there should be pain on the medial side. And similarly, pushing the chair with the elbow, with the forearm supinated, will again give you the same test. You have the Yagasan test for biceps tendinitis, where you supinate the forearm against resistance with the elbow at 90 degrees, and this produces pain at the elbow. You have a lot of chronic ligamentous injuries, which is not so common here in India, but where there's a lot of baseball being played in young children, like in a country like the United States. You have this little leaguer's elbow where children, because of the repetitive trauma due to the valgus stress when they're throwing the baseball, can end up with this problem in the elbow. This you have to evaluate with the valgus stress test, where the elbow is flexed to 25 to 30 degrees, and you give an abduction or valgus force to the distal forearm while the medial collateral ligament is being palpated. Okay, and this will show tenderness or pain in that region. Similarly, for the lateral ligament, you will do it with a varus stress with the elbow flexed at 25 to 30 degrees, and an adduction force is applied by the examiner to the distal forearm. Okay, again, you can feel the tensing of the ligament when this is done. Now, posterolateral rotatory instability is one of the sequelae of elbow dislocations, or it can be a chronic problem over a period of time. And here, the way you test it is have the patient lie supine with the arm to be tested overhead. You grasp the patient's wrist and extend the elbow with a mild supination force applied to the forearm and wrist. The patient's elbow is then flexed while a valgus stress and compression is applied to the elbow, and the patient will wince. So you can see that here, as you're doing, you can see the patient jumping up when that stress is applied, okay? So you can see the wincing there as that stress is being applied with the again, you can see that being done again. That's a bit of an exaggerated response, but it can be quite dramatic if it's really painful. So the same thing you can do it by different ways. The chair sign is when a patient tries to attempt to rise from a chair with pushing down on the chair just with his arm, with his forearms supinated. Okay, so when he does that, if you have a rotatory instability of the elbow, posterolateral rotatory instability of the elbow, it is going to cause pain. You also have valgus extension overload syndromes. Again, something very common in baseball pitchers and not so common here in India. And here you test it by the elbow repeatedly being brought forcefully into full extension while a valgus stress is applied. So you'll get pain at the posteromedial olecranon tip, which will be considered a positive test. You need to do the neurological exam, and I think all of you must be familiar with the nerve supplies to the various parts of the forearm and hand, which you need to be familiar with to do the testing for these, and also the motor activity where you will test the various muscles, the anterior interosseous, you need to check the median nerve and the radial nerve, median nerve, and the ulnar nerve. Okay, the Tinel's test is where when you do a gentle percussion over a nerve and you get tingling distally, which is a sign of either nerve sort of compression, or it can be when the nerve is recovering. So you can get a tinel sign at the elbow with a cubital tunnel syndrome developing, or even when an ulnar nerve neuropathy occurs or an injury occurs, it can be used to see the signs of any recovery in the nerve. So I think in summary, just say that I think it's important that you develop a system and follow it carefully. I think the history will help you guide and direct your physical examination. So I think the history is important, because if you don't take a good history, you're going to be misled into not doing the correct examination. Always compare the affected elbow with the non-affected side. And of course, once you've done your history clinical examination, you will need to supplement it with your further radiological or radiographic investigations and your lab investigations to come to your diagnosis. I think it's important to have this step-by-step protocol of examining your patients to be able to not miss a diagnosis when you're examining them. Thank you very much. So I'm going to stop sharing, and now we'll take questions. I'll try and see what there is in the chat box. So some, okay, so let me see what is kept. Okay, so starting with for one question, I think that's for Dr. Mahanti, is reason for not performing the Trendelenburg test below 4 years, below 5 years. So Dr. Mahanti, do you want to answer that? Hello? Is Dr. Mahanti there? I don't see him there. So Dr. Taneja, do you want to take that?
Yeah, you see that if you have got a child who is less than 5 years, you see it is not possible at all to ask the child to follow your instruction. And therefore, you will always get a false result. And therefore, you need to have a child or a patient who understands what you expect from him. Therefore, we don't do these tests in the children less than 5 years, 3 years, 4 years old child. Okay?
Okay, so in knee examination for ligament, which is considered most significant, translation or endpoint? I think that's for Dr. Bangani.
Yeah. Sorry, what was the question, John?
In knee examination for ligamentous injuries, which is considered most significant, translation or the endpoint?
Well, it's basically the translation. And when the translation comes, the displaced joint come together between the femoral condyle and the tibial condyle. And that's the endpoint. But the translation occurs first. And once it occurs, the joint is reduced, which was subluxated earlier.
Okay. So there's, I think, another question which is to you, which will be the foot, sir, but the foot is already in 10 to 15 degrees external rotation with the hip in neutral rotation. Then how can we measure it from the vertical? I think this is related to the dial test, I believe.
You have to look at the thigh and the medial border of the foot when you're doing a dial test. Mm-hmm. So when you flex the knee, I mean, say patient is in supine position, you flex the knee from 0 to 30 degree and you mark the how much external rotation you have it. Then you bring it out to 90 degree, and if the external rotation increases, that shows that you have a posterior cruciate ligament as well as the posterolateral corner injury. Now at 30 degree, you have external rotation. It remains the same at 90 degree. That suggests that you have only the posterolateral corner injury to the knee joint, and the PCL may be normal.
Okay, so there's another question. What if translation is minimum with a soft endpoint? Well, that's unlikely.
Well, the translation occurs the endpoint. When you have you're doing the pivot shift test. I guess this is the question related to it, right?
Yeah, presumably.
Yeah.
No, I think it's related to the earlier question about endpoint.
So the endpoint is when your tibia and femur relocate into normal position, which is the endpoint of the test.
No, so what I think they want to know is what you mean by a firm endpoint or a soft endpoint, like when you're doing a Latchman's or a draw test.
Yeah.
What do you mean by a soft endpoint and a sort of a firm endpoint, and how do you differentiate translation and the endpoint?
Well, the soft endpoint suggests you that there may be a injury which may be partial. And the firm endpoint suggests that there is a definite injury to both the areas, the ACL and the PCL. I mean, say ACL and the lateral collateral ligament.
So is it that or the other way around? When it's soft, you feel it may move more, while if it's firm, that means that's where it ends, you can't translate it anymore.
Well, it's like you have it starting, you maybe have a soft, but actually the real test positive is at the firm endpoint.
Sure, okay. And then another one, I think, how to perform rotational examination of femur in persistently dislocated, non-reducible patella.
Sorry, sir. Again, a question, please.
How to perform rotational examination of femur in a persistently dislocated, non-reducible patella.
Well, when the patient has a non-reducible patella, patella is sitting on the lateral side of the knee joint. And if you look at the femur is pointing in a straight upward position. And if you want to reduce it, you will have to gently hyperextend it, push it medially, and then flex the knee joint.
Okay, so there's a question from Egypt, Dr. Mona Sala. How can we differentiate clinically between lateral epicondylitis from an elbow plica? I think there are a few things that you need to see. One is that the tenderness in the lateral epicondylitis is actually in the region of the extensor origin. Okay, so it's usually in the muscle there rather than in the joint proper. Okay, so that's one thing. The other thing is the tests that we mentioned. And eventually, I think it's your investigations that is going to finally clinch the diagnosis for you. The ultrasound is something we use very often, especially to confirm a diagnosis of a lateral epicondylitis. But for the plica, you probably need an MRI to be able to be sure about it. Okay, so these are, and then any other questions? How do we measure rotation at hip joint with knee and hip extended? Do we check angle of rotation at foot or patella? So Dr. Manti is not there, I believe. Is he? So I think Dr. Taneja, you can take that for him.
What is the question?
The question is, how do you measure rotation with the, one second, let me get back to it exactly.
With the knee in fully extension.
Yeah.
Knee in fully extension, that if you cannot flex the knee joint, how would you measure the rotation?
Yeah, so in full extension with hip and knee extended,
yeah.
How do we check rotation?
Yeah, you know the method of checking the rotation at the hip joint is that you stand at the end of the bed, hold both the ankle joints, and then you try to move the extremity both internally and externally, which will give you an idea of the rotation, because here there is no flexion at the hip joint, at the knee joint, and knee has to be kept extended. That's one of the methods of measuring the rotation at the hip joint, from holding the ankle and then doing the rotation.
Yeah, so I think that's important. And remember that the degree of rotation can vary between flexion and extension.
Flexion, yeah.
So it's important to do it in both anyway.
Both flexion and extension.
Okay, I think that brings us to the end of the questions on the chat box. I don't know if there's anything else. There's some requests for the videos, because there were some issues in the transmission. So I don't know, that's Dr. Taneja, is this going to be available on YouTube?
Yeah, the whole program is being recorded. It will be all go onto the YouTube. And at the moment, it is going also on the Ortho TV live listing. Everything will be available on the YouTube.
Okay, so that's good for everybody to know.
Yeah.
And one last question for Dr. Bangani. In Macintosh pivot shift test, when leg is moved from extension to flexion, what is interpreted as a positive test? How do we explain the finding?
Well, when you're going to do the test, McMurray test, you flex the knee. When you have flexed the knee and you rotate the knee internally or externally, depending upon, are you suspecting the medial meniscus injury or lateral meniscus injury? Let's say we're talking about the medial meniscus injury. So you flex the knee as much as possible. It has to be fully flexed. Then you externally rotate and gradually extend the knee. Keep your hand on the posteromedial part of the joint. And as you extend the knee, you feel a little slip or a little click. When your tibia and femur comes in contact in the area of the torn meniscus, you feel that click, a slip, and that's where it shows that the test is positive.
Okay, excellent. I think we will now move on to a short break. Dr. Taneja, anything else to announce at this time?
Now we'll have a break of about 10 minutes, 15 minutes. We'll start the session again at 3:20. People can a little bit relax and have a little tea or something. And please come and join us sharp at 3:20. We have an excellent session on the spine. And I would like to thank my chairperson, Dr. John Mukhopadhyaya, and Dr. Khushnood, who has been very kind to have given their valuable time. Thank you, each one. Please come and join us at 3:20. Thank you.
Thank you very much, Dr. Taneja, and we'll close this session now. Thank you.
Bye.
Am I audible? Hello?
Hi, Deven.
Hello, everyone. Am I audible?
Yes, you are audible.
Okay.
When is my presentation, Deven?
Just now, Alaa, you have joined us. Lovely.
Yeah, I
Thank you.
joined.
Okay, Alaa, you are chairing this session from 3:20 to 6:40 p.m. And you have your lecture at 3:50 and then another lecture at 4:20. And that is, you have got two lectures.
You know, I'm a little bit confused. And I thought that, you know, because I'm joining many congresses, so the time zone was not right for me to know from the start. So exactly after how many minutes should I join?
Okay, you will be, you see now it is going to be 3:15. So you will be, after half an hour or so, you will be having your lecture.
All right. That's
hello, Taneja.
So, yeah.
So Alaa, your lecture is very important, and approach to scoliosis patient, and other is the apex correction for the early onset of scoliosis.
So after 30 minutes, I should join.
Okay, right. So is Dr. Goel has joined us? Dr. Goel?
Yes, sir, I am here.
Okay, so Goel, you will have to, you're requested to kindly chair the session.
Right,
and
sir.
Dr. Alaa Ahmed from Palestine will join you. And this is basically mainly on the spine. And you have a very good speaker from Pakistan, Dr. Shabir Awan from Peshawar. And of course, Alaa is an international authority on the spine and scoliosis. He will be with you. And of course, then you have your own lecture. And then we'll have the very good demonstration of the instruments and implants. So it is going to be 3:20. I hand over the mic to Dr. S.C. Goel and Dr. Alaa to conduct this session. Thank you, Satish.
Good afternoon, friends. So we are going to start this session on spine in about 2-3 minutes time. And we have with us Dr. Shabir Awan.
Can you tell me how to share the screen? I'm finding difficulty in sharing the screen. Can you tell me how to share the screen?
So on the bottom you get a green
yes,
icon.
I clicked that. Yes, I clicked that.
Have you opened your file? Please open your file first on the computer.
Yeah, open a file on the screen. Yes, it is open now.
Yeah, and then you click the share screen.
Share screen. But when I share the screen,
Sir, if you see down, there are options: mute, start video, library, and then you have a share screen option.
Setting, okay.
Chat, and after that is share screen. When you look down,
yeah. Yes.
Click on that, and then you will be able to share your screen.
Where in the setting?
No. When you are looking at your laptop, you see a bar below.
Yes.
Which says mute, start video, security, and all.
Yes, it says yeah.
And there, the fifth option is share screen.
Yes, share screen.
And then just click on that, and you'll be able to share screen.
Yeah, I share the screen, but another window comes.
Yeah, and then you select the window which you want to share. So that will be the video with your PowerPoint.
Okay. My PowerPoint is. I have opened the PowerPoint on the. Oh, I see. Yes.
هلا حضرتك بعدها بعد العيد بكون صار لها 3 أشهر.
I'm finding difficulty.
Just click on the PowerPoint thing, which will be your desktop one. And then at the bottom right side, there is a share option.
Yes.
On the same thing, and then just click that, and you will be able to share.
Some other windows come down. Here the window of the video.
Sir, I'm just sharing my screen. Just look at it and then you'll be able to do it, sir.
حبيبي يعطيك العافيه. عندي برزنتيشن اصلا مش بدي احضر، انا عندي برزنتيشن. لا هلا بدي مسكر الصوت. الله معك. يلا دخلوا لي يا جماعه اللي عليه.
अगर इनके स्लाइड अपना ईमेल पे मंगा
Is it your screen, Dr. Shagar? Hello?
Hello?
Are we seeing
Who is
Dr.
the second speaker?
Who is the screen?
Yeah, I think who is the second? Yeah, I can't find. I click the share and share the screen. It won't tab, but it doesn't click on the share. So if the second speaker can start, and meanwhile I can find out that how to. I think it's just more and settings. I can settings, video receiving shows, background general, chat.
لا في فرق نص سنتي بين اليمين والشمال، بس هذا ما بنحسبه اصلا فرق. يعني اذا اقل من سنتي اصلا ما بنهتم، ما بنعرف انه في فرق. ايوه هي واقفه. في شويه ميلان في الحوض طبعا زي ما قلت لكم اكثر من يطلعوا.
Dr. Alaa, are you ready?
Alaa?
Yes.
If Dr. Alaa is there.
Yes, I'm ready. If you want, we can present after 5 minutes. Just give me 5 minutes and I'll be ready to present. Do you want me to share the screen with you guys to show you? Hello?
Yes, sir, definitely.
Yes, please do.
Yeah, sure. Just a second. Here you go. Is it clear?
Yes, it is coming, started sharing. Yes, now it's there.
Good. So I'll stop sharing until you tell me when can I join, all right?
Dr. Shabir, are you got any success?
Yeah, actually I can't share my screen. I don't know. That's my presentation is on my desktop, but I can't share it. I don't know what's.
So, Dr. Taneja, can we go ahead with Dr. Alaa first?
Yes, that's what I was saying.
Yes.
That we can go ahead with Dr. Alaa's lecture. Okay?
Right.
Right.
If anybody
Dr. Alaa,
can help
may I request you, please start.
Stop the videos, settings, zoom, general, background, about. Can Dr. Alaa can start his lecture, please? If
Dr. Alaa, are you there?
Yes, I'm there.
Please start. Please start your lecture, sir.
Sure.
As Dr. Shabir is having problems.
All right. Thank you very much for having me to this beautiful Congress, and I'll be talking about an overview of scoliosis, how to approach scoliosis cases, and also the reference for scoliosis, which is very important for all of us to know. So I'll share the screen with you now. Is it clear, the screen?
Coming, it is coming.
Do you see it?
Yes, yes, sir.
All right.
You are on.
Okay, thank you very much. So, information about the spine. It's very important to know some principal issues about the spine. From birth to maturity, the spine increased threefold. So we need to understand that in pediatric spine, we need to acknowledge the growth of the spine. And we should know that 2/3 of the growth of the spine occurs in the first 5 years of life. So any defect in the spine or any problem in the spine that will prevent the growth in the first 5 or 8 years, it will have catastrophic issues on the patient. So we need to acknowledge that. And then it will be slower from 5 to 10, and then it will increase from 10 to 13 in girls and 15 in boys. And when you don't have the ability to predict the spinal length, for example, because of many reasons, then you can have the arm span. Just put the arm span and it will be 97% of the appropriate spine length. Now for the lung, which is something very crucial. When you deal with pediatric spine, especially for early onset scoliosis cases, the problem of early onset scoliosis, which is scoliosis before 10 years of age, is the lung. It's not the spine. It is the lung, because any deformity in the spine will be associated with deformity in the trunk, and it will restrict the lung growth. And we'll see now how and why. So from birth to the age of 5, thoracic volume increased 5-fold. And until the age of 8, the alveoli will increase by multiplication. So there will be an increase in number of alveoli. But after 8 years, the number will remain as it is, but there will be increase in the volume of each alveoli. So any restriction of the lung growth during the first 8 years of age will restrict the number of alveoli, and it will cause permanent damage and permanent disability of the child. And we need to acknowledge that always in the beginning. So a child with scoliosis, which becomes prominent before the age of 8, will demonstrate hypoplasia of the lung with decreased number of alveoli. This is very important to acknowledge. So the thing that when you see a child who's having some deformity in early childhood, don't tell them the myth, which is not right, that wait until you grow. It's wrong. So scoliosis is simply lateral deviation of the spine, but it's not shifting of the spine laterally. It is a rotation of the vertebra that will cause lateral bending of the spine. And because of that, we can see that there will be a hump. Like here in the picture, we can see that the left side is higher than the right side because of the scoliosis in the lumbar region, and the convex side will be always higher than the concave side. And scoliosis is divided to non-structural, which is flexible. So for example, if you bend yourself and you do an X-ray, you'll see some bending of the spine, but it's not scoliosis. And you can realize that by seeing the pedicles here, the rounded areas which are related to the pedicles, you can see them, they are in an equal distance from the mid-spine region. So there is no rotation. And the examples are like postural, muscle spasm, anything like that. But there is structural, like rigid, fixed rotation. And when you correct, for example, if you have a bending to the left, when you go to the right side, it will not correct. Still you'll have because it's mainly rotation. And the most common type is idiopathic, and you can see congenital, neuromuscular, syndromic cases. And here we can see the example of, for example, in the middle in the middle one, you can see a standing. Always do the X-ray standing, always. Unless the patient cannot stand, like neuromuscular problems, then you do it sitting. If the patient cannot stand or sit, then you do it supine. But standing will show you the mechanical axis and the true angle of the deformity. And here, for example, in the middle, you can see there is scoliosis in the thoracic and scoliosis in the lumbar. But when you bend, like in the left bend on the left side, when you see the bending and there is a correction of the lumbar, then it's not a structural curve. It's a non-structural curve. We call it compensatory curve. So you don't need to acknowledge it for fixation or something like that. This is for planning for surgery. But you need to know which is structural. But you see on the right side, when you bend on the right, it doesn't correct the thoracic. So it is a structural curve. So when you see an X-ray like that in the middle, and you do the bendings or you do traction. Now some people just do traction and do an X-ray. And if you see a correction and the curve will be less than 25 degrees, then it's mostly non-structural and it's a compensatory curve. And the classification, the well-known groups, as I told you before, neuromuscular, congenital, idiopathic, and also syndromic, others like syndromic. And also, if you have a fracture, for example, or a trauma, and it causes paraplegia, 99% will go with scoliosis. Because of that, when we do fixation to the trauma, it's not just to for the trauma, it's to prevent the scoliosis that will come afterwards. And this is an example of severe neuromuscular scoliosis. This is cerebral palsy, and if you don't acknowledge it as a serious condition, you can see on the X-ray, there is a demolition really of the lung on the right side. And if you don't treat it early, it will be very hard to treat afterwards. And it's not for also, when you acknowledge that for treatment in the future, for the sitting position in neuromuscular cases, because their life, some of them, their life is depending on a wheelchair. And if you get them to sit appropriately, they can use their hands in the future. So don't neglect them. And here's a congenital. For example, on the left side, you can see a hemivertebra. And on the right side, you can see what we call it a unilateral bony bar. So there will be inequality of growth in both sides, which will cause scoliosis or kyphosis. Now, for the congenital problems, always we seek to do, not to look at the patient as a spine. 25% will have intraspinal anomalies. 30% have cardiac anomalies. 25% or 30% have urinary tract anomalies. So always when you have a case of congenital scoliosis, do echo for each patient, do MRI to exclude any intraspinal lesion, and always do a pelvic ultrasound and abdominal ultrasound to see if there is a congenital anomaly in the urinary tract. This should be a routine. Any case of congenital scoliosis or syndromic, you need to go through these investigations. Don't look just at the spine. So other causes of scoliosis, neurofibromatosis, and we know, of course, it's a big issue. Trauma, as I told you before, rheumatoid arthritis, and tumors. Like osteoid, for example, it will cause scoliosis. So for idiopathic scoliosis, it's the majority of cases of scoliosis. Nearly 70 to 80% of scoliosis are idiopathic. Can you please mute, because there's somebody, Dr. Kumar Rashid, I think.
Now can you
mute, please?
All other speakers, all other people. Kindly do that.
Because there are sounds of children and
yeah.
Yeah, that's great.
Okay.
So idiopathic scoliosis, the most common type is adolescent idiopathic scoliosis, which is scoliosis. It's a normal child, and then around from 8 to 13 years of age, they there will be a rotation, and it's called idiopathic because we don't know what's the reason, though there are some talks about genetic factors, but it will increase, and 80% of them are girls. So, but don't deal with idiopathic rules as the same as non-idiopathic. This is very important. So idiopathic are classified by age. Infantile idiopathic scoliosis between 0 and 3 years of age. And this will happen. Unfortunately, this is in many parts of the world, it's misdiagnosed. And I'll tell you why. Because if the mother comes to you and say to you that I feel that the child back is inappropriate during giving the child a bath, believe her. And do examine the child appropriately. And do an X-ray. Why is that? Because if you are having infantile idiopathic scoliosis, which is scoliosis without any specific reason, there is no syndrome, there is no neuromuscular disorder, there is no congenital anomaly, but there is a scoliosis. If the scoliosis is less than 60 degrees and you treat them by casting and they are below 1.5 years of age, it will be therapeutic. After that, it will not be therapeutic. So early diagnosis is very important. Juvenile idiopathic scoliosis, it's part of early onset scoliosis, but it's between 3 to 10 years of age. And in infantile and juvenile, male and female are nearly the same, 50%. And the most common type, which is adolescent idiopathic scoliosis, in the practice of pediatrics, find nearly some of the people will have 99% of their cases are adolescent idiopathic scoliosis. Unless you are interested in early onsets, then you'll have, but that majority is adolescent idiopathic scoliosis, 80% are girls. So if you have women in the street and you just do an X-ray for 100 women, you'll have 3 women who are having scoliosis. But 90% of them are non-progressive, idiopathic non-progressive scoliosis, and they might be just discovered by chance. And 10% only of them need treatment. So what is the meaning of progression? You need to examine and you'll see the progression of the curve, and also you'll see the difference between X-rays. But if you have 5% difference in the X-rays, it's not adjustable to say that there is a progression. If you have 10%, there is for sure a progression. So, and if the progression also occurs according to the age, if the progression occurs pre-maturity, that means, especially in females, I'm talking here about adolescent idiopathic scoliosis. If the progression is before menses, it will progress most probably 10 to 15 degrees per year. If it is after menses or after maturity, it will increase 1 degree per year. And this is crucially important to acknowledge that. So if there is a progression, you can see that the patient will be decompensated, and after 90 degrees, it will affect the respiratory system. I'm talking here about adolescent idiopathic. So it will cause imbalance, pulmonary and cardiac compromise, and that is if the curve is more than 100, beside, of course, cosmetic problems. Now, idiopathic scoliosis progression is related to age and maturity, as we said. Size of the curve, if the curve is more than 30 degrees, most probably it will increase. And the location, the majority, it will increase the incidence of progression of the curve, usually increase in the junctional areas, like dorsolumbar region, like upper thoracic and mid-thoracic region. It will increase more than in the straight thoracic area. So I'll show you, this is a case that was 25 degrees, for example, and after 7 years, it became 80 degrees. So you should check the patient and do an X-ray. If it's pre-maturity, do it every 6 months to check the patient. If after maturity, do it every 2 years. Riser sign is very important. And of course, all of you know the riser sign. It's the apophysis of the iliac wing, and it's riser 0 to riser 5. Usually, if it's riser 2 or less, it means that the patient is still having rapid growth and you need to acknowledge that. If above, if riser 3 or above, so the growth is much less. Tanner classification, which is the pubic hair, axillary hair, breast, is also a sign for progression or non-progression of the curve. Also, 25% have familial tendency. So if you have, and I'll tell you afterwards, if you have scoliosis for a patient, you need to check the family. And in the examination, it's so simple. You do what we call it Adams bending test. Just get the patient exactly as we can see in the picture. You'll be behind the patient will bend forward, and if there is any inequality between both sides of the back, then you should refer the patient. And it's not necessarily done by a doctor. It can be done by a social worker who is trained for one day just to see, or the nurse. And it can be done in schools, and preferably to be done in schools between 8 to 13 years of age in female schools, because they are having the increased incidence of this thing. And if there is any skin marker, like café de Olé spots, that might give you an incidence of neurofibromatosis, dimples, hair patch, like here. So you might have some spina bifida or neurological problem, excess flexibility. And always you must check for intraspinal lesions, like the MRI. Nowadays, we do MRI for all patients. Before, there were the more risky patient, which is adolescent idiopathic scoliosis, who is a male, or a patient who is having left-sided thoracic scoliosis in a female, or somebody who's having some neurological symptoms. So you examine for settings, so you do motor examination, you do the reflexes, appropriate neurological examination. Now for the screening procedure, which is very important actually. And it can be done, and it can give some progression of our management, especially in our countries. Early detection is crucial and very important. So as you can see here, simply you can check the child, mainly females. You can check them from their back. They must remove all of their clothes until the pelvis. As you can see here, you must see their shoulders clearly. You cannot put something that will cover the shoulders. It's forbidden, because the shoulders must be level. If the shoulders are not level, then you can predict that there is some problem. Or you must see that the pelvis is level also. That because if there is any discrepancy in the pelvis, then you might suspect that there is some lumbar region scoliosis. So, for example, for this child, you'll see that the pelvis is not equal. One shoulder is higher than the other, and one shoulder blade is higher. That is, on the convex side, you can see that the scapula and the ribs are higher than the concave side, because there will be also a malformation of the ribs during the rotation of the trunk during scoliosis. So if you see anything like that, when the patient is standing, and also you can see the difference also in the measurement, in the distance between the arm and the trunk. So you need to get the patient to have her hands freely down, and you can see. So if there is any uneven shoulder, uneven pelvis, blade is higher in one side, you do Adams bending test, and you see one side is higher, then suspect there is scoliosis and refer the patient. So this is the forward bending test. And you can see that the feet 4 inches apart, knees straight. The knees must be straight, and the toes are even. Palm of the hands should be held together or facing each other. Arms hang down. There should not be some stress, and they must be relaxed. And the head is down, exactly like that. This is the appropriate way. You are behind the patient. Look, if there is any inequality in the back, then send the patient for the orthopedic surgeon or the pediatric spine surgeon to check. So you see here, one side rib cage is higher than the other, and the curve alignment of the spinous process, as you can see, there's a curve, it's not straight. And if the prominence is noted, sometimes you use a scoliometer, but even if you don't have a scoliometer, and many people don't have a scoliometer, then just send the patient. But if you have a scoliometer, if it's above 7 degrees, then send the patient for further check. And you do the right lateral view. This is for the kyphosis. The student should stand erect and is directed to stand first on the right side toward the screener. And you can be on the side of the patient, and you can see smooth, symmetrical, even arc of the back. This is the normal thing. But if you see unsmoothness, as we can see here, there's an apical issue in the back from the side, then the patient might have a kyphosis, which needs further management and further detection. Frontal view. So you'll be facing the patient or the child and repeat the forward bending test, but you are in front. And also if you see any asymmetry on both sides of the back, then send the patient for further examination. You can see here, this is how you see the scoliosis. Any abnormality, any uneven area in the back should be checked. And this can be discovered if even the patient is having 25 degrees of scoliosis. Lateral left view, the same for the kyphosis. So after rescreening, how can we refer the patient? This is very important also to acknowledge. Criteria for reference: unequal shoulder height, unequal distance between arms and the body, prominence of one hip, scoliometer reading more than 7 degrees, accentuated prominence of the thoracic or lumbar. So you can have a checklist and even give it to the nurse or the social worker, and they can just check accentuated sway back, unequal symmetry of the upper back. And parents should be personally contacted if a positive finding has occurred. We must, beside reference of the patient, we must talk to the family about it, and they must be included in the management. So age-appropriate counseling for the students should also take place with parental permission. It's important that everyone involved understands that a positive screening result doesn't constitute a diagnosis of scoliosis. So it's not mandatory. Don't let the family be in a panic, but you should tell the family that there is a suspicion and we need to do further investigations, like getting them to an orthopedic or pediatric spine surgeon, and we might do a plain X-ray. That's all what we need to do. During the initial session, explain the results of the screening and their significance, because you might, especially in our countries, if you don't talk to the family clearly about that, they might not take it seriously. And it might just give a huge difference if they neglect the case for a year. And we know it happens many times in our countries, unfortunately, but we are responsible for not telling the family the exact issue about it. And we need to answer all the questions and provide opportunity for students and parents to ventilate concerns and anxieties, and we must respond to their questions. Provide a written referral form and review to be certain that information being given and being sought from the evaluator is understood by the family. So you should have a written consent. Initial referral should be to the family healthcare provider. And request to complete the referral, discuss that with the family, encourage patients to have the child siblings screened. This is very important, especially in adolescent idiopathic scoliosis. 25%, as we said, might have scoliosis. So we would tell the family that we need to screen other siblings. And follow up students with questionable findings who are not referred to private healthcare providers should be rescreened every 6 months if still there is a growth. Therefore, it's important to keep a list of these students to facilitate scheduling this follow-up session. So treat those people who are progressing. And this should be done by only early detection, appropriate examination, and dealing with the family in details about that to have them with the process of this issue. Thank you very much.
Dr. Shabir, are you ready with this second? Thank you, Dr. Alaa. Very nice lecture. Dr. Shabir, are you ready? Or Dr. Alaa can continue the second one also. As you say, Dr. Shabir, if you are comfortable, you can start. You are muted, sir. Dr. Shabir, you are muted.
You are muted, Dr. Shabir. How are you? Nice to see you. You are muted. You are muted. Unmute.
Oh, yeah. Unmute. Yeah, it's unmute now. It's unmute now.
Are you ready, sir?
So, okay, let me try to share the screen.
Yes, it's coming.
It's coming. And now how to share the screen is... I'm not
I think you should open the file beforehand, before you...
Yes, it is open already. It is open already. Now you are sharing, you are sharing the screen.
Yep.
Is my screen up there?
Yeah, we can see your screen, but not the slides. It is a rainbow color screen.
No, but it says that you are sharing the screen.
Yeah.
Now is it coming? Is it there?
No, sir.
Is it? Oh, what's happening? It's working on my computer and says stop. I stop share and then this goes up to stop sharing share. Desktop one. Which one? Is it not sharing yet?
No, sir. We are seeing the multicolor screen only, but not the slides.
You can see me, but not slides. Okay. So even my computer operator is not able to help me. Desktop one and iPad. Share what? Connect. Say your internet connection is unstable. The preferences.
So in that case, may I request Dr. Alaa to continue his second talk?
Alaa
Dr. Shabir.
To continue.
Dr. Shabir, please email this lecture to Dr. Taneja, and from his office somebody can show it.
Hello.
In the meantime, in half an hour, when Dr. Alaa is speaking, you email this presentation to Dr. Taneja's office, and there probably Dr. Pranaw or somebody will be able to help us. Is that okay?
We can have the other lecture by Dr.
Yes, we are going ahead with Dr. Alaa now. Yes. Dr. Alaa, please.
Thank you very much again for having me. I'll talk about what we call it the APC technique, active apex correction, which is a technique that I'm doing for nearly more than 8 years, and it's mainly for early onset scoliosis. And now I'll share the screen with you, so as we can begin talking about the principles. Do you see my screen? Do you see my slides?
Yes.
Yeah. So we can, the problem of early onset scoliosis is that it is scoliosis that will happen with the patient, any patient, whatever the etiology is, below 10 years of age. Whatever the etiology, whether it's idiopathic, whether it's neuromuscular, congenital, syndromic. And the problem of these things is that they are mostly fatal, though they are not quite common as adolescent idiopathic scoliosis. And I did a technique that can be done, can be accessible to low middle income countries, and it's through posterior tethering, and I'll show you how we can do it. So again, according to the SRS Scoliosis Research Site definition, early onset scoliosis is scoliosis for all spinal deformities in children below 10 years of age, whatever the etiology is. It's not as common as adolescent idiopathic scoliosis, but has higher incidence of morbidity and mortality. And this is the difficulty of that. Because of that, not many people, even who are doing scoliosis, would like to go through early onset. But in my practice, nearly 50% of my cases now are early onset cases. So we can see here from the figure that congenital scoliosis, infantile idiopathic, juvenile idiopathic, we didn't include the syndromic and the neuromuscular. They are nearly 2 per 1,000, and in comparison to 2 per 100 in adolescent idiopathic. But we need to see that the impact of management on the patient and the family is very high, because you need to deal with the patient, and until now, the majority are having a protocol of getting the child every 6 months to do surgery to distract, so as to give continuous growth of the spine and to increase the growth of the lung. But in general, what is the ideal management of early onset scoliosis? The ideal management is to maintain a corrected mobile growing spine with normal trunk and lung growth and with minimal complications. What we have learned in the last 2 decades, that early onset scoliosis is not only a spine problem, it's majorly a lung problem and the thorax problem. And when we deal with scoliosis, in our minds, always we think about the lung growth. Avoid fusion with evolution of non-fusion techniques. Unfortunately, until now, there is no consensus on the efficiency of any of the approved surgical methods. All of them are having many complications, including my APC. So what is the APC technique? As I said, it's posterior tethering. And the privilege of posterior tethering is that most of the spine surgeons are familiar with posterior approach of the spine, not the anterior approach. So it's much easier to learn. But we can look at it as when you put the teeth brace, and with the growth, the teeth will correct spontaneously and you tighten it a little bit. This is the main issue of tethering, is that you don't fuse it. You don't lock it, but you maintain the growth through modulation of the vertebra and gradual correction. This is the tethering technique. Now, what is the unique thing about active apex correction? It is controlling the apical vertebra or the apex of the curve by modulation and growth. Actually, the idea came after we saw the Sheila. The main concept of the Sheila, which was done by McCarthy from Arkansas, is controlling the apex, which was a great idea. But he controlled the apex by fusion of the apex. So we have 3 vertebrae, we fuse them, and then the spine will continue growing. But he realized after 5 years of follow-up that 62% of his cases had a crankshaft phenomenon. The crankshaft phenomena is the nightmare of any pediatric spine surgeon who deals with adolescent idiopathic scoliosis. Why is that? Because when you fuse the apex of the vertebra, you restrict the height, but you don't restrict the growth, especially anteriorly. So it will still grow anteriorly and you stop the growth posteriorly by the fusion. So there will be the crankshaft. What is the definition of crankshaft phenomena? Is still growth of the spine anteriorly. And we had, because of that, the fusion in situ was a bad idea because it will not prevent the rotation of the vertebra. And the APC technique has included two systems, which is the guided growth system and the compression system. Here we can see on your left side, you can see the difference between the Sheila and the APC. On your left side, you can see the Sheila, and you can see the red marked circles, which are the supposed apex of the curve and the fusion of them. So you fuse the convex and the concave side. And all of us, as when we deal with spine, we know what is the meaning of putting screws on the concave side of a child 5 years of age. It's really risky. And you must have a roll for osteotomy or something like that to correct it fully and fuse it. And then there will be a gliding of the rods proximally and distally through what we call Sheila screws that will not lock the rod. It will just let the growth of the spine proximally and distally, and the rod will glide. And this is a good idea that will prevent the technique of traditional growing rod that you get the child every 6 months to distract the rod. But here on the right side in the APC, we put only 2 screws which are marked by the orange. And you can see our hypothesis is that in between them, this is the most wedged vertebra. So you put 1 screw above, 1 screw below on the convex side, and you compress them so as it will have a tethering effect. And that will cause a decrease in the growth on the convex side, and you don't touch the concave side. And the same gliding of the rods proximally and distally, though we don't put now Sheila screws because they are very expensive. Each screw is $1,500. So we use dominoes, and I'll show you how we do that. And when we did our studies and we published our papers about that, we did a CT scan for all patients, a 3D CT scan after 2 years of follow-up to compare the height of the concave side and the height of the convex side. And we realized that in the beginning, preoperatively, we had the height of the concave side 50% as a mean value of the convex side, of the most wedged vertebra. But we realized after 2 years that the percentage was 70%. So the concave side is progressing in the height and in the growth much better than the convex side because of the tethering. Here is a good example of a child who is 6 years of age. She's having early onset scoliosis, as we said. It's a right-sided scoliosis. We can see the line of the spinous process. We can see the uneven back, and we can see on the right side, you can see the X-ray. We have 66 degrees main thoracic curve, and the most wedged vertebra is T8. So we put a screw on T7 and T9 and compress them on the convex side. Here you can see on the left side, you can see the screws. And I usually, in early onset, because children are very small and I don't have a cell saver in my hospital, and most of us don't have cell savers. So I try to use the technique that will cause minimal bleeding. Because in a child, 10 kgs or 15 kgs, 100 cc is making a difference. It's not like 100 cc for a 50 kgs or adolescent idiopathic case. So I usually begin doing 3 small incisions to control the bleeding. And in the 3 small incisions, I usually put proximal anchors, put the 2 screws and the apex, and put the step anchors. And when I put the rods, sometimes you feel that you need to connect them with each other. Sometimes you don't. So here we can see on your right side, you can see the proximal anchors. I usually put 2 levels of screws, or you can put hooks. But if I have uneven shoulder, I put screws. Now I was using a lot of hooks before, but on the rib, of course. But nowadays I use the hooks only if I have associated kyphosis, or severe osteoporotic. And here we can see the blue line, which is the most wedge vertebra, and you can see the screw above and the screw below, and you can see it on the lateral. And we compress it. So this is the distance. When you put the tethered rod, you put a rod for tethering that connects the two tethered screws. Always put 5.5 titanium rod. Don't put 4.5. And this is what we have learned by experience. But, or you can put cobalt chrome 4.75 because biomechanically it equals 5.5 titanium. And here you can see we are compressing the screws. Here you can see compressing them slowly so as not to dislodge the screws. And usually in the thoracic, you compress between 5 to 10 millimeters. In the lumbar, you can compress up to 15 millimeters or 20 millimeters. Then you lock them, both. As we can see, you lock them. So this is how you have the tethering effect. And then you can see here on your left side, you can see the whole surgical field. The screws which are rounded by yellow circles are the tethered screws. And these screws are connected with a rod that I told you, it's either 5.5 titanium or 4.75 cobalt chrome. And you connect this rod with proximal and distal anchors with dominoes, as we can see. This is on the convex side. On the concave side, you just put proximal anchors, put distal anchors, and don't touch the spine. And this is the credibility of our technique, that you don't touch the spine on the concave side, as we can see, even you don't scratch it. So it is a more of a non-fusion technique. And for the dominoes, you make one of the dominoes locked and the other is not locked because it will give a sliding effect of the rod. So here, for example, this is the concave side. And let me go before. And this is the proximal part. This is the distal part. A rod from here and a rod from here. Connect them with a domino. This is on the concave side. But afterwards, and this is a mistake that some of the people wouldn't acknowledge, that you distract maximally. As you can see here, you can see there is no locking here so as to give a space for the rod to slide, but you need to lock it so as to prevent the sliding going proximally. So the only sliding will go distally. So you do it either with one of both pieces of a crosslink, or you cut the head of one of the screws and you put the head, so it will prevent, when you distract, it will not go back. This is the concave side. So you distract maximally, you lock proximally. So when there is a growth on the concave side, it will grow distally, and you don't need to get the patient to come every 6 months because there is a gliding of the rod here, beside the gliding of the rods proximally and distally. And usually I give 4 centimeters for the rod to glide. So we'll have 4 years without any surgery. This is the child after the surgery. You can realize even the correction is wonderful, though we don't intend for correction. But these are around the blue line is the tethered screws. And you can see here the rods, the yellow ones, the sliding of the rods proximally, distally, always with dominoes. One is locked, one is not locked. But on the concave side, because you distract a lot, you prevent the rod from going proximally again, and it only goes distally. We did a study, and it was published in the Global Spine Journal, about cases that I did with traditional growing rod that need every 6 months to go and distract the rod under general anesthesia. and cases that I did with the APC with 2 years follow-up for each. And we realized that there is no statistical difference with the AVT, apical vertebral translation, which is an incidence of crankshaft if it's worsened, the cup angle correction, the kyphosis correction, the sagittal balance, the spine length, which is great that you are doing a technique that you don't need to go every 6 months to a surgery. And it is comparable to the traditional growing rod. We did a study, because I'm an adjunct professor in University of Toledo, we did a study, a biomechanical study. It is a study that we did, a virtual computational study. We had 5 cases of my true cases, and we did a virtual computational study similar exactly to the clinical issue. And the aim was simulation of surgical correction using modified Sheila, which is the APC, for 5 patients with 6 months growth. We did have the true X-rays and the CT scans. And we evaluated the clinical parameters and compared them with the lab parameters. For example, this is an X-ray, and we can see on the right side, this is the model, the virtual model that we did in the biomechanical engineering department in the spine lab in the University of Toledo. As we can see, we have put the screws exactly as we did clinically. And even we calculated the gravity. Here you can see we did the coronal, we did the sagittal. And here are the results. The results are clearly comparable with the clinical results. And we can realize that there is an improvement in the spinal length and the ratio between the apices in the apex vertebra. But we realized that it's not only modulation of the most wedged vertebra. Actually, we didn't know that, but we knew that with the lab, that the 3 vertebrae which are instrumented, the ones with the screws and the most wedged vertebra, all of them modulated very well. And we can realize that the average ratio of the instrumented part was having a growth which is much better than the non-instrumented part, which has only 10% of growth in comparison. So what does this APC technique tell us? That there is limited intervention, decreased incidence of crankshaft phenomena, good control and active correction of the curve, continual growth without needed for repeated distraction, pave ways for further biomechanical studies. The benefits of APC technique, you don't need to do osteotomies, which is very important also as a safe technique, and no screws on the concave side. 2 screws instead of 6, financially much better. Hybrid technique, cheap, and this is very important, and can be done with regular spine implants. As you can realize, all what you need is regular screws, regular rods, regular dominoes. You don't need to have specific, like the Magic or the Sheila. You have only one company, you have specific implants that you must buy, and they are expensive. But you can use, I mean, in India, you have companies that have these instruments and implants, and you can do it with them. Avoid recurrent surgeries through rod sliding. So in conclusion, treatment of early onset scoliosis is challenging because it's heterogeneous population. You need to evaluate case by case, and you need to understand the concepts behind the treatment of early onset scoliosis. Cornerstone of early onset scoliosis treatment is facilitation for optimal condition of growth of the spine and growth of the thorax, and having flexible spine as much as possible. Spine fusion should be postponed as much as possible. More awareness about the holistic approach with consideration of the multiple treatment intervention. You need to decrease that as much as possible. Because of that, there is a shift to avoid recurrent surgeries. Operative complications might be reduced by delaying the age of surgery. Try to delay the age or put a cast or something until you see that the curve is increasing more than 10 degrees, then you must go to surgery, whatever the age is. These are the references that we published, papers for early for the APC technique, if somebody is interested to read them. And this is a book that we wrote about early onset scoliosis guidelines for management in resource limited regions. This is the first book that I'm a co-editor, and my friend Akash Agarwal, who's a doctor in biomedical engineering in the University of Toledo. And I think it's the first book, and it's the only book that talks about how to implement early onset scoliosis management in countries with limited resources. And these are blended learning courses that in Africa and in Latin America. And we talked about early onset scoliosis a lot about that. Thank you very much. Thank you.
Thank you, Dr. Alaa. Very illuminating lecture. And I hope Dr. Shabir has now sorted out the problems. Please go ahead. No, sir, it's same. We are seeing only the colored screen and nothing else. Dr. Shabir, you are muted. Can you switch on your mic, please? No luck, sir.
Is it still not coming?
No, sir.
Is it still not coming, the screen?
No, sir. It is only your screen is there, but we don't see the slides. We see only the colored waves.
Shabir,
So
Shabir, why don't you?
Yes.
Why don't you get your son or your secretary or PG student to help you to get this thing done? It's not a very big job because you see we are.
Yeah, your PA. Yes, your PA did help me, but still it's not coming. She spent 10 minutes with me and showed all the things, and I'm doing the same thing which she said.
Dr. Shabir, why don't you
help me?
Dr. Shabir, why don't you send your slides to someone?
Okay, I can send to the PA of Taneja, and
Yes.
then I can join. Yes, I'll do it in a minute.
Please do that. Yes, and also you can
Okay.
send it, copy to maybe Dr. Goel, who is
I'm doing that.
Yes.
I'm doing that now in a minute.
So,
So if all agree, I can start in the
Yes, you can start. Yes, you can start.
And
You
can you
start
see
and
my
I'll
screen
send
now?
you.
Are you able to see my screen?
so you have to, I think Dr. Shabir has to stop sharing his screen because we can see.
Okay, I stopped sharing. Yes.
Yeah, okay, now.
Yes.
Yes, Arindam, can you see my screen?
I can see it. Yes.
Okay, right. So I start. I thank Dr. Taneja and the team for giving me this opportunity. And I'm talking a little different topic from spine. This is the basic thing about fracture healing. Now, what we see usually is about 10 to 15% of fractures get into the problem of delayed healing in spite of proper immobilization or even repetitive operative interventions. And about 1.9% go into non-union. Why all these things happen? That must be understood. There are three landmark works which define this. One is the Wolff law, we all know about it. It says the bone adapts to the loads under which it is placed. Then Perrin gave a theory which deals with the physiological response to the broken bone to its environment, or the strains and on the fracture site. And the Frost described bone homeostasis as a mechanostat responding to variation in the mechanical environment. So bone healing can be seen from three views: biological, mechanical, philosophical, and even biochemical. When a fracture occurs,
Dr. Goel, just 1 second.
Right.
Dr. Kareem, can you please, Dr. Kareem, Dr. Kareem, can you please mute yourself, please?
When a fracture occurs, there is a hematoma. The inflammation begins immediately after injury, and it is followed rapidly by repair. And after repair, there is a remodeling phase begins. So if we see, basically there are 4 stages in fracture healing: stage of inflammation, stage of soft callus formation, stage of hard callus formation, and stage of remodeling. Initially, there is a hematoma formation because there is bleeding from the muscle ends, from the bone ends, and then gradually there is resorption of the necrotic tissue and infiltration of fibroblasts, then chondrocytes, and then there is an angiogenesis. So damage is occurring not only to the cells, but also blood vessels, bone matrix, and even periosteum, etc. There is a hematoma formation, and clotted blood provides a fibrin mesh which helps to seal out the fracture site so that inflammatory cells and ingrowth of fibroblasts can happen there. And these degranulated platelets and inflammatory cells are there which release various growth hormones like PDGF, TGF-beta, fibroblastic growth hormone, and other cytokines. And these cytokines in turn activate the osteoprogenitor cells in the periosteum, medullary cavity, and also the surrounding soft tissues. And all this stimulates the production of osteoclastic activity as well as osteoblastic activity. So by the end of the first week, the hematoma is organizing. It has been sealed off and all this activity has started. And the adjacent soft tissue is being modulated for future matrix production. So this is a fusiform uncalcified tissue, which is known as soft callus or procallus. And this provides some anchorage between the ends of the fractured bone, but offers no structural rigidity for weight bearing. So at this stage, the fracture is malleable, but not separable. So this is the stage of soft callus. And here, the intramembranous ossification is started. There's the replacement of the granulation with the fibrous tissue and the cartilage, and osteoblasts are growing in from the surrounding tissue. And here, the woven bone is laid down perpendicular to the cortical axis within the medullary cavity. So here you can see the woven bone is being laid down. And in some cases, the mesenchymal cells will start differentiating into chondroblasts also and have some cartilage initially. This cartilage, which has been formed newly, will undergo enchondral ossification, forming a network of bone, and the fracture ends are bridged by this bony callus as it is mineralized, and stiffness grows, stiffness increases, and now it can be called a hard callus, and over which the weight bearing can happen. And next we come to remodeling. Here, the woven bone which has been made so far is getting replaced by the lamellar bone. There is a resorption of the unneeded callus, because initially this callus is formed haphazard all round, and the unnecessary callus is resorbed, and there is a maturation along the lines of stresses, as the Wolff law says, and ultimately there is a restoration of the medullary canal. Now, this is the biological process, but it is also influenced by the mechanics of the fracture environment. And here is when we see about the stability from a mechanical perspective. If there is an absolute stability in the fracture, Then there's a direct healing. The bone grows across the fracture site and there's no callus formation visible. While in a relative stability, there's an indirect healing, callus forms, and then the whole gamut of the bone turning to biological steps goes on. So when there's an indirect healing, there's, as we have seen in the 4 stages, there's a formation and maturation of the callus, and this may be with or without fixation. Maybe with the plaster also, it may be after an intramedullary fixation or less rigid fixation. And here, as you see, the callus is growing and normal callus forms. There may be cartilaginous or membranous ossification there. And that is how it looks on the X-ray when the large amount of callus is forming all around. Then we go to direct healing. The direct healing refers to when there is a direct contact to both the cortices and contact. There's no so here there's no intermittent cartilaginous stage. And the process primarily goes between the 2 rigidly opposed cortical fracture ends. So here the bone is forming between the fracture ends. And here this is what we call it cutting cones. The tips of the vascular stem grow as a cutting cone, which consists of osteoclast. And this cross the fracture line. The osteoclast will be resorbing the dead bone in that area. And then they were followed by osteoblasts and blood vessels. And they require, so to get this thing, we must have an anatomical reduction and a rigid fixation with absolute stability. Here, the lamellar bone grows directly across the fracture site. So we don't get a huge callus in this area. And so with rigid fixation like this, when you've done interfragmentary fixation, you get a fracture union without a callus. If it is a comminuted fracture, then what happens? Here, there is a relative stability. Even if you are fixed with a locking plate or any type of plate, here the fragments in between are not locked that much. And here again, there will be a primary callus formation, and that is how the bone will unite. So here, so that means for healing, we need stability as well as biology. Now the strain factor comes in. What is a strain? Strain has been defined as a change in the fracture gap divided by the fracture gap. And strain determines stability, determines the strain. If it is too much stability, strain will be too much. If it is less stability, strain will be less. A strain theory given by parents says the bridging will not occur when the strain is too high across a fracture gap. If it is too much rigidity, then it will not happen. And if there's a less strain, the body will try forming soft callus. So here intrafragmentary movement stimulates the soft callus. So if there's micro motion occurring between the fragments, a soft callus forms. As the soft callus increases, motion becomes less and less, and so strain becomes less. And this allows the bridging and transition from soft to hard callus. But if the fracture gap has been considerably narrowed down when we put an intrafragmentary fixation or a lag screw, then it is a very high strain environment. And so here the healing is by direct healing. In multifragmentary fractures, as we saw in comminuted fracture, the strain is spread out. And here less strain on each individual fracture gap. So here soft callus bridges and matures. So when it will not heal, if there is a too much strain, if there is an instability which is too great due to fracture gap or fixation characteristics, and in these cases, hypertrophic non-union may occur. Because even if there is an attempt to callus formation, it may not be a useful callus, which is bridging across the fracture site. And here this can be treated by increasing stability to decrease the strain. So if we increase the stability here, then strain will be less and callus will bridge and mature. On the other hand, if it is too little strain, if there's a large gap or the fixation is too stiff, as may happen in a locking plate, then no or very little callus will appear. And that may give rise to an atrophic type of non-union. And this should be treated by decreasing the stability to allow the callus formation, or eliminate the fracture gap and allow minimum strain environment. So either you give a compression in the fracture fragments so much that they become like a fresh fracture, or you decrease the stability, make it more mobile, relatively less stable, then it may allow the callus formation. So to summarize that, it will be absolute stability. For absolute stability, you give anatomic reduction. You have to give a rigid fixation. There should be no motion at the fracture site. Strain here is very low or zero, and primary bone healing with no gap or callus will take place. While on the other hand, in the relative stability, micromotion occurs at the fracture site as you do in a intramedullary interlocking nail, where working length of the nail is very big. Here strain is higher, and secondary bone healing with callus formation will take place. So basically, you see there are four components are there, which there are other factors also which are coming in, like when the cortex, periosteum, bone marrow, and external soft tissue all are contributing, but there are other factors like growth factors, hormones, nutrients, pH of the blood, oxygen tension, electrical environment, and mechanical stability of the fracture, which all play a role. And then there are cellular and molecular factors, which have been, research has gone in them for recently. There are signaling molecules like pro-inflammatory cytokines, transforming growth factors, and angiogenic factors. So all these factors also must be in an optimum level to give this proper healing. As you can see in these pro-inflammatory cytokines are interleukin 1, 6, and other TNF alpha group. Then the TGF beta family cytokines are there. And then there are platelet-derived growth factors, which are in the platelets, which play a role in PRP also. And they help during the early phase of fracture healing. And there's a potent chemotactic stimulator for inflammatory cells here. Then there are other growth factors like fibroblastic growth factors, insulin-derived growth factors, and angiogenic factors. All of them play a role in the healing, proper healing of the fracture. In addition, we have got other systemic factors or hormones like parathyroid, thyroid, vitamin D, and one must have an optimal level of all of them for getting a good fracture healing. Stem cells also have been now seen as a method where you can use them in a non-union, and they will also stimulate the bone growth. And platelet-rich plasma, because it is containing those platelet-derived growth factors also. So if we summarize all of these factors, you can see on the right side of your screen that on day one, there are cytokines, various cytokines are released, and they all come there in that area. By the day 3, the cytokine level decreases, but there is the expression of TGF beta and other BMPs, and angiogenesis begins with angiopoietin. By day 7 is the peak of TGF beta expression and also expression of other GDF. By the day 14, all of these decrease, and the VEGF is expressed, that is vascular endothelial growth factor. And by day 21, all of them decrease, and by this time,
is very
has already formed.
for your mind socially.
Excuse me. Dr. Sachin, Dr. Sachin, please mute yourself.
कोई बात नहीं, मैं मेरा और क्या ऑफिशियली 6 मिला तेरे को 2 बार, वो भी एक बार जब बैक हो गया था ड्यूटी करते हुए.
Dr. Sachin Kumar, please mute yourself.
Dr. Sachin Kumar, please mute yourself.
So now we come to the non-union. What is non-union? Non-union, various definitions have been given. It is when the biological process is stopped and a fracture is not expected to unite unless surgically intervened. Another definition has been when a minimum of 9 months have elapsed since injury and the fracture shows no visible progressive sign of healing after 3 months. Usually, the bones, the upper long bones in the upper limb take 6 to 12 weeks, in the lower limb up to 2 to 4 months. A normal bone healing requires good reduction, contact between the fragments, and proper immobilization. And what is a delayed union? Delayed union is one where the biological process is not stopped. It is growing, but it is very slow. So it is taking more time than the time frame given for each bone. And this may be different depending on the associated soft tissues. Then there are various other factors. Mechanical stability we have seen already. Then inadequate vascularity also can lead to non-union. There is an excessive soft tissue stripping, vascular injury, or poor bone contact, which may be because of soft tissue interposition, malposition or malalignment of the fragments. There may be a bone loss, or there may be a distraction of the fracture site. And then there are some contributing factors. Among them, smoking and tobacco use is very important, but there are others like infection, certain medications, advanced age, systemic medical conditions, poor functional level, venous stenosis, burns, radiation, obesity, alcohol abuse, malnutrition, and vitamin deficiency, etc. And for good union, we must have a good reduction and alignment, stable osteosynthesis, absolute asepsis, and smoking habits and diabetes also must be controlled. Absolute causes of non-union will be interposition of the soft tissue and distraction. These are the two conditions where fracture hematoma is disturbed and union will not take place. While other causes are relative, like inadequate improper immobilization, that is for plaster patient, ischemia at the fracture site, like you get in fracture neck femur or fracture of the talus, scaphoid, infection if there's an open injury or arterial infection, improper reduction of the fracture fragment. These are the relative causes where union may be delayed or sometimes non-union may happen. What is inadequate improper immobilization? It is the fracture is reduced, held in the plaster, and we know the dictum is the plaster must extend one joint above and one joint below. If it is not followed, then fracture is relatively mobile in the fracture plaster and it may not unite. Then the plaster must be for adequate period of time. That is when soft callus has formed adequately and is going to hard callus. If you remove it early, then fracture may not unite because there is an increased motion at the soft callus. Like you see here, this small nail is not giving adequate stability to the fracture. There may not be improper reduction when there's no fractures are not aligned properly. Ischemia, like we said in the fracture neck femur, may happen. Stripping of the soft tissues, bone loss, radiation, infection, all these can lead to non-union again. Now, what are the types of? There are three basic types of non-union: hypertrophic, oligotrophic, and atrophic. In hypertrophic, you see callus forming on both the sides. In oligotrophic, very little, less callus, and atrophic, practically no callus forms. This is the hypertrophic non-union, where the fracture was put in the plaster, but never united because of the excessive motion. While on the other side, right side, you see atrophic, where the bone formation is less. Atrophic non-union doesn't have any attempt at callus formation due to biological defects in the fracture site. In hypertrophic, callus is present in abundance, but is not bridging the fracture. And this is due to instability at the fracture level. Clinically, we diagnose a non-union when there is a painless abnormal mobility at the fracture site. And this cannot be seen if there is a nail inside. Then we see about the relative motion. Extreme cases, there may be pseudo joint formation also. The two fragments are always moving. And so there may be even, when you open it, you may even find a synovial tissue there. And this is known as pseudarthrosis. Delayed union may show abnormal mobility after the expected time of union, but fracture ends are painful and tender, and these fractures may unite even with the conservative treatment. The treatment of non-union is to provide a stable environment for mechanical stability and biological environment by bone grafting. So hypertrophic require only mechanical stabilization and stable osteosynthesis, because bone grafting may not be required in a hypertrophy because biology is okay, callus is forming. While atrophic, you need a biological stimulation also to give by autologous bone grafts. So treatment of non-union is open reduction, freshening of the bone ends to remove the sclerosed tissue, internal fixation, and bone grafting. I think I will stop here and we can discuss it further. Dr. Arindam?
Thank you, Goel. Very nice lecture, very, very informative lecture. And I think we have received the PowerPoint presentation of Dr. Shabir, and we can share that, and Shabir one can give his lecture. कहाँ है वो अपना बोलने वाला कहाँ है ठीक है इसको बोलना पड़ेगा ना कि मैंने Dr. Shabir, your slides are ready now.
Okay, you can hear me now?
Yes, we can hear you.
I'm very sorry that I create a lot of trouble to all of you. I don't know, I'm not so illiterate computer wise, but anyhow, it's happened.
Shabir,
my name is, yes, please.
Shabir, whenever you want to change the slide, just say next slide and we'll change your slide.
Yes, please.
Now you can go ahead with your lecture. Okay. Right.
My name is Dr. Shabir Awan. I am consultant orthopedic surgeon with a special interest in the minimal invasive spinal surgery. My 90% practice is back pain and sciatica. Next slide, please. Bismillahirrahmanirrahim. Next slide. Lots of love and flower from Pakistan, particularly my own town Peshawar, which is once known as Pashpapur, which means city of flowers. Next slide, please. Next slide. You cannot teach a man anything. You can only help him find it within himself. Next, please. Says the Galileo. Next. I never teach my people. I only attempt to provide the conditions in which they can learn. Say next slide, please. Says the Albert Einstein. Next slide. Roadmap of today's presentation is introduction, spinal anatomy and deformities, how to read the diagnosis. Next, please. Items to carry for exam, clinical examination. Next, please. Take home message and conclusion and thanks. Next, please. Next, please. Next. My mentor used to say that to be a good orthopedic surgeon, you must be a good technician, carpenter, mason, tailor, ironsmith, mathematician, detective, and psychologist. And particularly the back pain patient, you must be a good psychologist. Now, the spine is so jigsaw puzzle that nobody knows what's going on. So there are so many remedies. If you see, there is an attack on spine. Next, please. And you just continue, click, 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 click. Plates and screws, wires and pliers, nut and bolts, pins and washers, hook and rods, hammers and chisels, cutter and benders. So you can see you can use all these things, wrench and screwdrivers, nibblers and rasps, yes, needles and tubes, medicine and herbs, and then spiritual and traditional remedies. So it's a jigsaw puzzle. Spine is a jigsaw puzzle. We play with the numbers, curves, planes, angles. We'll carry on. You just click lines, triangle. I'll just going on. Degrees, columns, and motions. Now, next slide for the numbers, please. It's not. Yeah, there are 33 vertebrae, 23 discs, spinal nerves are 31, planes are coronal, sagittal, and transverse. There are 4 curves, which are 2 primary curves and 2 secondary curves. Next, please. Spinal planes, as mentioned before. So next slide, please. Next. Next slide, please. Spinal curves at birth, we have the C-shaped curve at birth, and then when the child start lifting the head, the cervical curve develop, and when start walking, the lumbar curve develops. So there are 2 primary thoracic curve and sacrococcygeal curve, and 2 secondary curves, which are the cervical and lumbar curve. Next, please. Next, please. Function of the spinal curves. Curve absorbs the shocks. It supports the weight bearing and additional space for viscera in the thoracic cavity and the pelvic cavity, and S-shaped curvature provides the flexibility and strength. Next, please. Deformities in the sagittal plane and sagittal plane kyphosis and lordosis. So there are 2 types of deformities. One is non-structural sagittal deformities, and other is the structural sagittal deformities. In the non-structural sagittal deformities are the postural and, yeah, next please, reducible compensatory. Deformities in the coronal planes are scoliosis, kyphosis, non-structural deformities. I should open another kyphosis. There are 3 types of kyphosis: smooth kyphosis, postural kyphosis, and angular kyphosis. Now, look from the side, it's a, yes, next please. Next. Lordosis, that's a postural lordosis, increased lordosis, and loss of lordosis. Next, please. Combination of deformities, that kyphoscoliosis and lordoscoliosis, then when the both sagittal and coronal combined, they create these deformities, and the scoliosis is a 3D spinal deformity. Next, please. Next, please. How to reach a diagnosis? It's a history. Next, please. From the patient or parent or caregiver, examination, that's general physical examination and specific examination, investigations, that's imaging, lab test, and the special diagnostic operative procedures. And then differential diagnosis by exclusion or inclusion methods, and then diagnosis comes. So you have to follow these. What is history? History is a story of a patient in their own words about the illness, constructed into a concise, comprehensive, and informative text by a doctor. Next, please. Story versus history. Story may be irrelevant, disorganized, annoying, and irritating, whereas the history, yes, please, next slide. Whereas the history should be thorough, systematic, concise, informative, carefully taken, and patiently compiled. Next, please. Next, please. Difficulty in history taking. Language barrier, social barrier, uncooperative patients, elderly patient, hearing impairment, malingerer, depressed, and disinterested patients. So these are difficulties you may face in getting the history. Because getting history is important, you can get 80% diagnosis from the history, and then 10% diagnosis from the examination, and then 5% from the investigation, and 5% still remain undiagnosed. So basic requirement for the examination is a professional get-up, professional behavior with a smiling face, professional kit, through thorough knowledge of the spinal anatomy and disorders. Because if you don't have the knowledge, then you cannot examine any part, because you don't know what you are looking for. So be a good listener, have a good sleep and night before the exam. Do not discuss much outside the exam hall, and do not ask the other candidates about the question being asked. because sometimes they tell you strange stories. So don't ask any question. Whatever you have learned, that's enough, and you will produce in the exam. Go to the exam with a relaxed mood. Next, please. The big day to prove. So big day to prove that whatever you have learned from your mentor, from your books, from your practice, you have to prove on the day of exam. So be prepared for the big day. Next, please. Next, please. Items to carry out. It's a huge list, so I don't want to go through these lists. It's a huge list, but you need even less than 10% of those, but you have to carry all these with you to impress the examiner and to show that you know all these things can be. I don't want to go one by one, so it's just a huge list. You can take it from the presentation. So coming to the spinal landmarks. Number one, the spinous process vertebra, which is C7, T3T spinous process is the medial border of the scapular spine. Next slide, please. Yeah, vertebra prominence. You just click on T2 is a jugular notch, T3 is a medial end, and you can just, there are 3 or 4 landmarks which you can remember. For example, the spinous process C7, upper part of the scapular spine is T3, and then lower part is T7, and the iliac crest is L4. So these are a few landmarks you have to remember. Next, please. Thoracic spine, just gross anatomy, the 12 vertebrae and vertebral prominence, costal facets are from T1 to T9, and vertebral size increases from T1 to T12. Spinal canal diameter varies, and smallest is at the T4 to T7. Lumbar spine, yes, you can go next slide, please. Yes. Lumbar spine, there are 5 lumbar vertebrae. Largest is vertebral body in the axial spine. Lordosis is 60 degree, 40 to 60 degree, and apex of is L3. Shape of intervertebral disc produce the lordosis. Cauda equina begins at L1. Next, please. What to look in the spine? Eye sees what mind knows. The congenital anomalies like a spina bifida, scoliosis, in traumatic you see the fractures, degenerative spondylosis, prolapsed intervertebral disc, infective in TB, neoplastic, METS, primary inflammatory process like ankylosing spondylitis, metabolic osteoporosis. So before, yes, please, next slide. Before embarking, you have to greet the patient with a smiling face. Check the patient ID, which is important. Check the patient ID that you are seeing the proper patient. Make sure that patient makes yourself and patient comfortable first. Make sure that privacy is maintained. Ask the nurse to accompany you when you are going to see a female patient. Introduce yourself. Explain what you will do. Seek the permission. If uncomfortable, ask the patient to let you know. Appropriate exposure is mandatory. It's a golden rule: look, feel, and move. But before look, feel, and move, you have to see the next slide, please. See the gait and posture and the, yes, you just click on the posture and general condition of the patient. Then look, feel, and move, and measure the test and probatic test, vascular status, other joints, hip and knee, and PR in case of Cauda equina syndrome. The important thing in this slide is that we normally examine the spine, but we forget about other structure. For example, the knee joint, the hip joint, the shoulder joint. Sometimes these symptoms are coming from those joints. And similarly, the varicose veins and vascular status. Next slide, please. Gait. Dr. Taneja have given an excellent lecture this morning, so there's no need of going to just mention the types of the gaits, that what gaits you can have in a patient. Intelligent gait, hemiplegic. Next, please. Posture. You can, yes, posture, please. This normal posture is this one, where the forward posture, thoracic kyphosis, lumbar lordosis, and sway back. So these are the, and if you see this picture here, this is the normal picture where the occiput is touching the wall and thoracic back is touching the wall and heel is touching the wall, whereas this is the mal posture. Next, please. Now coming back to look, feel, and move. The skin. Next, please. In the skin, you see the scars that previous injury or previous surgery or injury, pigmentation, that neurofibromatosis, abnormal tuft of hair in the spina bifida, shape and posture you see from the front, from behind, and from the side. Then asymmetry, you can see about the chest, trunk, and pelvis. So this is important that in the look and the feel, in the look, sorry, you see these things: the skin, shape and posture, and asymmetry. Next slide, please. From the front, you see the head, neck level that are there in the center, and the level of the shoulders, nipple in the male patients, and pelvic obliquity, and the field and the feet leg length discrepancy, which will be apparent, not the true. And chest shape, pectus excavatum and pectus carneatum, you can see from the front. And rib hump from the side, yes, you can. The next slide, please. From the side, you can see the spinal curves. Plumb line is that the line, vertical line, which touches the ear, center of the shoulder, center of the hip, center of the knee, and the lateral malleolus of the fibula. Lordosis, you can see the hyperlordosis and increased kyphosis, senile osteoporosis. Next, please. Scheuermann's disease, ankylosing spondylitis, Gibbs deformity. Yes, next, please. Yes, I've explained this. Gibbs deformity, there's a TB spine and fractures. You can see such, and some congenital anomalies. Next, please. Loss or reversal of the lumbar lordosis, spinal infection, prolapsed intervertebral disc, and ankylosing spondylitis. You can see here is this X-ray. There's a loss of lordosis, and here in the upper picture you can see that it's a very straight. Next, please. Hyperlordosis. It is usually spondylolisthesis, and you may feel some gap also there, and but it is sometimes normal in the females. It may be due to the flexion deformity of the hip also. Next, please. Looking from behind, head, neck, level shoulders, as we have seen from the front. So from the back, we see the shoulders, scapula, iliac crest, obliquity, dimple of Venus, which may vary. And deformity, you can see the scoliosis or rib hump. Next, please. And symmetry of the trunk. Looking from behind, again, you see the level of the shoulders, and there is a curve and uneven hips. And this is the sciatic tail listing due to the sciatica. From behind, yes, please. From behind, you can see the skin, swelling, lipoma, cold abscesses, dimple, scars, sinuses, bed sores, birthmarks, and abnormal trunk furrows. These are the scars you see here. Yes, please. There's surgery here done. They have done these tattoo marks to hide the scar. Pigmentations. Next, please. Feel. You feel the superficial feel and deep feel. Palpation. You can in the midline or the spinous processes and on the paraspinal muscles, you just tap gently. It's a superficial feel. You can just feel the temperature, and if there is any abscess near the skin, you can feel that, but you will not get much from the superficial feel. You will get from the deep feel when you press the spinous processes and paraspinous muscles. Sometimes the paraspinal muscles are very tense and stiff, and there is a pain on the palpation. Next, please. Spinous processes, interspinous ligament, unstable, unusual prominence or step, as in spondylolisthesis, tenderness, and bony structures. Intervertebral tissues, paravertebral muscles, and ligaments. And next comes the third portion of the look, feel, and move. There are four types of movements in the spine. It's a flexion, extension, lateral bending, and rotation. Next, please. flexion, that's ask the patient to touch the toes, may or may not touch the toes, which is normal. It's I can't touch the toes, so I'm normal. Measure the flexion excursion. And next slide, please. Schober test, that you just make a 2 points of 10 centimeter apart, make a horizontal line across the venous of dimple, and then take a 10 centimeter vertical line up there, and ask the patient to bend. Ask the patient to bend forward and measure the distance between the two marked points. That one is that horizontal, which is venous of dimple. Another, you made it 10 centimeter above that vertically. So normally it is increased in 5 centimeter or more is normal. Next, please. Extension, stabilize the patient and ask the patient to bend backward. Next, please. Normal extension 30 degrees. So lateral flexion, ask the patient to slide the hand down to the side to reach the knee. So it is normally it's a 30 to 45 degrees lateral flexion on the right and lateral flexion on the left. Next, please. Spinal rotation, make the pelvis fixed by you, or ask the patient to sit on the stool. But it is better to ask the patient to sit on the stool because the pelvis gets stable. By holding the pelvis, it may not get stable. So it's better to get the stable by sitting on the stool. Next slide, please. You can see this picture here. Now, thoracic and lumbar spine, these are the degrees of the flexion and extension and normal rotation, lateral bending. Next slide, please. Provocative tests are the SLR. Raise the leg with the extended knee. It's okay. So SLR test, femoral nerve stage test, and cross SLR and slump test. These are the 4 tests which you do as a provocative test. Next, please. Straight leg raise the leg with the extended knee. Note the degree where the patient feels the pain, and check the distribution of the pain, and then lower the leg 10 degrees and dorsiflex the foot. So if the pain is reproduced, it is positive. Next slide, please. Picture. Positive pain is reproduced. It is between 30 to 60 degree here. So you just raise it and then bring it down and put this. This is SLR in the sitting position. Next, please. Cross leg, you move the normal leg over the leg which is you are suspecting that for the intervertebral disc, and if the pain is produced, it is positive. Next, slump test is that you ask the patient to sit and extend the knee in the slouch position. First to make him slump, and then extend the knee, and when you ask the patient to neck forward flexion, the pain is reproduced, and if you ask her to extend the neck, the pain is relieved. Next, please. Femoral stage test, place the patient prone and flex the knee and lift the hip into extension, and the pain is produced in front of the thigh and at the back. It is the femoral stretch test is positive. Next, please. Now, as I said before, that apart from the checking the only spine, you have to see the other joints, for example, sacroiliac joint, hip joint, and knee joint. Next, please. Neurological examination, you see the sensory, motor, and reflexes. Next, please. This is the crunch slide for the lumbar and cervical mismatch. If you see here, the lumbar spine, under the pedicle L4, the L4 nerve comes out, exiting nerve comes out. So the central disc or paracentral disc will not affect the L4 nerve. Whereas if there is far lateral disc herniation, that may affect. But here, if you see, the affected nerve is L5. So in the lumbar spine, always the one number less than the more than the pedicle. I mean L4 pedicle, there is a disc bulge of L4, L5. So L5 nerve will be affected. Whereas you see in the cervical spine, as the anatomical root is horizontal. If you see here, it is vertical. But if you see here, it is a horizontal. So the disc, both discs will affect the same number. And when the extra C8 nerve, there is no C8 pedicle. So it is above the T1 level. So from there transition starts. So the nerve which is T1 is pedicle is here, and T1 nerve comes out below the pedicle. This is mismatched because there is no C8 vertebra. Next, please. Now we'll quickly go through that L2, L12, T12 and L1 will affect the L1 nerve root, as I said before. Sensory changes will be upper thigh, and motor changes will be hip flexion L1, L2, L3. Next, please. L1 and L2 will affect the L2 nerve root. Sensory changes would be mid thigh, and motor function will be hip flexion, which is from L1, L2, L3, and adduction is L2, L3, L4. Knee extension is L2, L3, L4. Next, please. L2, L3 will affect the L3 nerve root. Sensory changes will be distal part of the thigh, including the knee. And motor will be hip flexion L1, L2, L3, and knee extension L2, L3, L4. Next, please. L3, L4 will affect the L4 nerve root, and sensory changes would be the medial side of the leg and medial side of the foot. Next, please. Next. Next, please. And motor is ankle dorsiflexion, tibialis anterior, and knee extension L2, L3, L4, and femoral stretch test will be positive. Petal reflex L4 mainly. Next, please. Next. L4, L5 will affect the L5 nerve root, and sensory changes would be the dorsum of the foot and leg, and motor changes will function will be the hip abduction, gluteus medius, and big toe extension, tendinal break gait, and SLR will be positive. Next, please. L5, S1 will affect the S1 nerve root. Sensory changes would be lateral and plantar aspect of the foot, motor, hip extension, ankle plantar flexion, and foot eversion, peroneus brevis and peroneus longus. Next, please. Ankle reflex is positive, and SLR test is positive. Next, please. Summary of the lower limb sensation that L1 groin, L2 anterior thigh, L3 anterior knee, L4 medial leg, L5 lateral leg and medial dorsum, S1 lateral foot and dorsum, heel and sole, S2 is a posterior leg and thigh. You can see here. Next, please. Next, please. Reflexes, there's L3, L4 knee jerk, S1, S2, S1, S2 ankle jerk, and S5, L5, S1, S2 plantar reflex. Next, please. Take home message is, click one by one, please. Click one by one, please. Professional get-up and attitude. Number 2, thorough knowledge of the spinal anatomy and disorders. Explain the procedure and seek the permission. Keep the privacy of the patient intact. Concise, comprehensive history is mandatory. Extra spinal structures such as joint and vasculature. Start from the gait, posture, difficulty in walking, sitting, and getting up. Follow the golden rules of the look, feel, and move and special test. Next, please. An examination of the spinal cord injury patient is not completed without the PR examination. Pay the thanks to the patient and at the end of the examination. Thank you very much.
Thank you, Dr. Shabir. Very delayed but very good lecture. So now I think we'll move to instrument and implant section.
Hello.
And Dr. Arindam and Dr. Rajesh Gupta to take over now.
Okay, hello everyone, and welcome to the final subsection of today's scientific program. So we have decided to divide this subsection into 3 parts. The first part will be a video which we have made, and we will show you that video as its own audio, and it is now used as a part of the Harvard Combined Orthopedic Residency Program. So it's about basic instruments, and then after that, Dr. Rajesh Gupta will show you further more equipment, basically orthopedic centric equipment. And finally, I'm going to give a discussion on implants and the changing design of implants over the last few decades. So I'm going to start by sharing my screen, and I hope the video comes on. Share screen. Okay, can you see?
Good day, everyone. I'm Dr. Sasinder, consultant orthopedic and arthroscopy surgeon.
Okay, can I just ask you, can you see and hear?
Video is not seen, sir.
Pardon me, video is not seen?
Yeah.
Can you see the video?
No, sir.
Okay. In that case, you can't see the video either.
No, Random, we are seeing only the you and
participants. Only participants are seen, sir.
Okay. Can I just stop?
Sir, I have the video also. Can I try from here?
Yeah, please. Please, 1 second.
Sir, can I try from here?
Yeah, please do.
Yeah, okay, just let me try. Otherwise, I'll start my talk.
Okay, the small tooth process is always called asin, and small non-tooth process is also asin process.
Yeah, Rajesh, you are on.
Tooth process causes less damage to the tooth.
Sir, just a minute, sir. Just I'm trying.
No, it came. The slides came, but it again went off.
Tooth process.
Sir,
yes,
sir,
yes.
Sir, can you see it?
Yes, we can see.
Okay, fine.
Good day, everyone. I'm Dr. Sasinder, consultant orthopedic and arthroscopy surgeon from Apollo Hospital, Muscat. Thank you very much for this opportunity to talk about commonly used orthopedic instruments. Let us start with the very commonly used instruments. So, the most commonly used is the forceps. Here we have toothed forceps and non-toothed forceps. You have long and short. Okay, the small or small tooth forceps is others called adson, and small non-tooth forceps is also adson forceps. The tooth forceps causes less damage to the tissue because it can easily pick up the tissue, whereas the non-tooth forceps crush the tissue more. So it is used only when needed for very sensitive tissues like the nerve. When you don't want to actually hold it strong, but you just want to manipulate the nerve a bit. And coming on to the scissors, this is the Mayo scissors and this is the Messenbaum scissors. Mayo scissors are slightly broad and flat, and this is a curved Mayo scissors used for dissecting tissues with a blunt tip. These are Messenbaum scissors. They are narrow and long. This is a curved Messenbaum scissor. This is a straight Messenbaum scissor with blunt tip, and it's a curved Messenbaum scissor with a blunt tip. All are used for dissecting tissues. This is a suture cutting scissor. The shape is specifically made like this in order to pick up the suture under one of the blades and cut it. This is a sponge holding forceps, to pick up a sponge and for preparing the area. These are mosquito forceps or small hemostats. This is a straight small hemostat or straight mosquito, and this is a curved mosquito or a curved small hemostat. This is a long artery forceps or a hemostat forceps. This is straight and this is curved. This is also a curved artery forceps. This is a long straight artery forceps. Okay, and we will go on to the needle holders. As a needle holder, if you see the difference between the straight artery and the needle holder is more stout and more strong in order to be able to manipulate the needle into the tissues. This is a cocker. Cocker is for holding the tissues very strong and manipulating it. This is straight cocker, and this is a curved cocker. Okay, these are the Alaa's forceps. In order to take hold of tissue, usually a fascia or a tendon, it has serrated head that articulate with each other in order to hold the tissue strong. And this is again a curved long cocker. This is a straight cocker. This is a barred park knife handle in order to fit knives of various shapes and sizes for the surgery. Here you have the Langenbach retractor. You have options of deep and small, broad and small. This is a bone nibbler. This single axis, this double action, single action bone nibbler and double action bone nibbler. It's used for nibbling away pieces of bone. This is a bone cutter. See, if you see the bone nibbler is shaped something like that, you have a scoop sort of tip, whereas in a bone cutter it's more flat and sharp. And this is a double action bone cutter. This is a curette. You have a rounded part and a more oval part. This is for curating away infected surfaces or fracture surfaces, blood clots, fracture surfaces, or in case of non-union, fibrous tissue from fracture surfaces. This bone lever is used to move away the tissues from the bone. For example, you have this at the bone, you just clip the bone lever. After you make an incision on the periosteum and elevate the periosteum with the periosteum elevator, you slip the bone lever under the periosteum and remove the tissues away from the bone. That way you can expose the bone and make sure that you don't have some major vessels or nerve under the bone before you use a bone lever. For example, in an anterolateral approach of the humerus, don't use a bone lever too deep. You could damage the radial nerve. This pointed bone holding clamp. This pointed bone holding clamp, big one and small one. The difference between a tower clip and a pointed bone holding clamp is the bone holding clamp points towards each other, whereas the tower clips point slightly away from each other in order to pinch the tower. This is again a bone holding clamp. It's a bird beak plate holding clamp. It has two surfaces. One surface allows the plate to be held against. It's shaped in such a way that you can place the plate on the bone and hold the bone and the plate together after you have reduced the fracture before you place the screws. This is a plate bender. There's the plate. Yeah. This is a plate bender. So basically, you use the bender in two different directions, like this, in order to bend the plate in either direction. Okay. So you have a more narrow slot for the 3.5 plates and more broader slot for the 4.5 plates. Okay. So this is a sleeve. When you use a drill bit on a bone and you're using a more minimally invasive approach, you use a sleeve in order to protect the soft tissues from the drill bit. Okay, so this is it's a drill bit sleeve, and this universal sleeve used for both central for making hole in the center of a DCP hole or in an eccentric way. The arrow has to be pointing towards the fracture so that The drill hole is made away from the fracture in order to achieve compression at the fracture site. Okay, so this is a depth gauge. You have a small hook on the tip of the depth gauge. After making the drill hole, you put the depth gauge through the drill hole, hook it on the undersurface of the bone, and then push the upper part of the depth gauge. And once it is done, you have a measurement there, and that is the length of the screw that you have to take. Okay, so the hook on the tip of the depth gauge allows you to go through the drill hole and then hook on the undersurface of the bone, and then you push this part and make a measurement of the screw length. This is cannulated T-handle shaped screwdriver. This goes with a thin K wire. This is a guide wire. Okay, fine. This is a bone saw used along with the electric saw. Okay, this is the periosteum elevator. This is an osteotome. These are all osteotomes. This is a chisel. And this is a chisel. I will tell you the difference. See, first of all, in the periosteum elevator, you have a thumb rest. Okay, so this is one way in which you can identify which is a periosteum elevator, and it is more curved. So basically, once you have made an incision on the periosteum, you just place on the incision and elevate inch by inch. This is an osteotome. It is beveled on both sides. So this is a narrow osteotome, this is a broad osteotome, and this is a medium osteotome. It is used for cutting bones. This is a chisel. It is beveled on one side but not beveled on the other side. This is a straight chisel and this is a curved chisel. It is used for taking off growths from the surface of a bone. Or for example, you have done a plate removal and you have extra bone, then you chisel off the extra bone from the surface of the bone. It is not used for cutting bone. Osteotome is used for cutting a bone. So you have the drill bits here of various length and size. What I mean by size is the thickness of the drill bit. So for example, for a 3.5 system, you use a 2.5 millimeter drill bit or a 2.7 millimeter drill bit. And for a 4.5 system, you use a 3.5 millimeter drill bit. And here you have cavers of various thickness. You have in 1 millimeter, 1.2, 1.5, 2 millimeter cavers. This is a combi hole plate. You have dynamic compression holes, and also you have locking holes. The locking hole, the inner part has threads that locks the locking screw head to the locking hole threads. So once you have drilled the bone and you have made assessment of the depth of the drill with the depth gauge, then you go in with the tap in order to create the threads before you insert the screw. This is not needed for a self-tapping screw. However, if the bone is very strong, then you have to at least make an entry hole with a tap so that it becomes easy for you to push in the screw. And this is a regular screwdriver. Like previously I showed a cannulated screwdriver. And then here you have the self-retaining forceps in order to push away the soft tissue, especially when you are short of an assistant or when you have a minimally invasive procedure, when you want to push away the tissues and do your procedure with minimally invasive incision. For example, you're doing a mini open rotator cuff repair. You want to make an incision in the deltoid and push away the deltoid fibers and go inside and expose the rotator cuff. That is when self-retaining forceps is very useful. And here you have the mallet. useful for most orthopedic procedure. One small tip with the mallet is never make, this is not an instrument for the mallet, but I will just show. Never make single taps, uncontrolled taps. It's easier and more controlled to make double taps in a controlled way. And one particular point I would like to make here is the way to hold a forceps is to have your ring finger in one of the ears and the thumb in the other ear, and have the remaining two fingers supporting the artery or needle holder. That way you have very good control of the instrument. This is not the way to hold the instrument, and this is not a good way to hold the instrument. Have the ring finger in one of the ear and thumb in the other, and have it supported with the other fingers. Okay, thank you.
So I'll. Okay, thank you, Dr. Gupta. That was very helpful. Now, may I request you to please complete the rest of the presentation about instruments and implants.
Yeah. So just, can you see my screen now?
Yes.
Visible. Okay, fine. Just a minute. Just setting the things right here. Okay, good afternoon, everybody. First of all, I must thank Professor Taneja for giving me a chance to speak on this subject. You know, we rarely speak on this subject, you know, on this forum of the PG teachings. Thank you very much, sir. So I'm going to talk on instruments and implants. This is very basic talk for the postgraduates. So no conflict of interest. Now, first of all, we will be talking about nailings, different type of nailing used in orthopedics. Now, a student must know what is this nail is. No, this is a rush nail. This has two ends. One is a beveled end used for easing the entry into the medullary cavity, and other end is a, you know, this is curved and hockey shape end, and this is used for extraction of the nail, and it also prevents the migration of nail into the medullary cavity. So it is indicated in the fracture of the both bone forearm, in the fracture of the fibula, or also in the fracture of the proximal humerus. But the disadvantage over here is it does not provide any rotational stability. Very rare these implants are used these days, but the student must know about these things. Now this is a Talwalkar square nail. This nail is for, on the left side is for radius, and on the right side is for ulna. Now ulnar nail has a pointed end, and the other end is serrated, and this is inserted from the tip of the olecranon process. This is the radius nail, and this has a notch on one end, and we insert it from the radial styloid or from the dorsum of the distal radius, and this notch goes up into the radial neck. So this is Talwalkar square nail for the forearms. Now this is Anders nail. Now Anders nail has a eye on flattened one end, and this eye is used for extraction and insertion purpose. Other end is blunt, and it is, you know, flattened from side to side, and it is used in the treatment of, you know, shaft fracture, fracture of the intertrochanteric fractures. But the disadvantage here again is it provides only partial rotational stability, and it is used in pairs. So this is Anders nail. Now nowadays we are using this nail. You know, this is a titanium elastic nail, and this is used in fracture of the forearm. The most, you know, common indication is fracture shaft of the femur in children. It can also be used in fracture of the tibia. So it comes in different sizes from 1.5 to 5 mm. So this is a common nail used nowadays. Now, student must also know this type of a nail. This is the Kunchner's nail, and it was discovered by Gerard Kunchner way back. So it has eyes on both the ends for the extraction of the nail, and it is slotted on one side. Okay, thus when we insert the nail, the slot has to be on the anterolateral aspect and the eye is towards the posteromedial aspect. So its cross section is like a clover leaf nail. So it is indicated in the fracture shaft of the femur. But what is asked is, what is the ideal indication of this nail? So ideal indication is the fracture shaft of the femur at the level of the isthmus, transverse fracture in a young patient. So that is the ideal indication to use the K nail. Now here comes the Kunchnar's V nail. It has eye only at one end, other end is beveled, and its cross section is V shape. So this is used in fracture of the tibia. But in both these nails, there is an issue of the rotational stability. They don't provide the rotational stability to the fracture. Now comes the interlock nail. Now most of us are now using interlock nails. So Moderne of Germany was a pioneer of this interlock nailing. These are cylindrical nails of various bends and angulations with proximal and distal holes for the bolts. Now it can be used in a static way or it can be used in a dynamic way. So if you see these holes, they are the static holes on both ends. Now this is, if you see this hole is a dynamic hole. Okay, this hole is a dynamic hole. This is for femur and this is for tibia. Now here comes this. Now these are the distal locking bolts and this is the proximal locking bolts. Now see, the one of the hole here is a dynamic hole. It is an oblique hole. It is an oval hole in this direction. So this is for femur, shaft of the femur fractures, and this is curved nail. This is a curved nail like this, and curve is very uniform. Now here comes the antegrade femoral nail. Now this has the provision for these pins, you know, these cannulated bolts to go into the fracture neck, into the neck of the femur. Now what is the advantage? If there is an associated fracture of the neck of the femur along with the shaft of the femur, we can use this nail. So this is known as antegrade femoral nail, and it has dynamic hole on both the sides. Now this is the proximal femoral nail, and this is indicated in the intertrochanteric fractures. And this again has two, you know, pins here, two bolts here to go into the femoral neck. Now most of us are using this implant nowadays, you know, in place of DHS, but no, there are indications for this nail as well as for the DHS. Here comes tibial interlock nail. So this is, you know, this bend is known as Herzog bend. Initially, in previous, you know, these nails, the bend is at the junction of the upper third and the lower 2/3. But now, with the new designs, it has changed. You know, now this is around 2 inches from the proximal end. It is not down there at the 1/3. Now, this has an advantage. If the fracture is at the, you know, proximal third, the fracture does not displace, you know, otherwise there is a apex deformity. You know, the proximal fragment gets lifted up. So to prevent this, there is a change in the design. Here comes expert tibial nail. This is an advantage. This is again a further modification of interlock nail tibia. It has a lot of, you know, locking bolts at the proximal and the distal end. And this is used primarily used for fracture upper third of the tibia. And the advantage of these oblique bolts is it fixes, you know, very well in the cancellous bone. So this is the advantage of expert tibial nail. Now coming to arthroplasty instruments, these are all, you know, implants. They use with these instruments we use for total hip. I'm going very briefly about that. Now this is a Thompson's hip prosthesis. You know, it has no holes, and this is used where calcar is deficient. Now, what is the difference between these two? This is Austin Moore prosthesis. Austin Moore has the holes. So these are the hemi-arthroplasty implants. They are not used, no, very common these days, but they are still indicated in fracture neck of the femur in very elderly, sedentary, old patients where life expectancy is not more than 2 years. And these holes are for the grafts, and bone also grows into these slots. Now then comes bipolar hip prosthesis. Most of us are using this implant nowadays. Now, what is the advantage? Advantage is there is a movement at two places. One is between the head and this acetabular cup, polyethylene cup, and the second is between this outer shell and the acetabulum. So there is motion at two planes, at the two levels, thereby decreasing the erosion and damage of the bony acetabulum. So its life is longer than the hemiarthroplasty Austin Moore or Thompson. Okay, but it has to be used as a cemented implant. We have to use cement in this case, so longevity increases. The range of motion also is more than the hemiarthroplasty, the Austin Moore. Then comes the modular bipolar prosthesis. Here you have three components, like this is a stem and neck, then this head component is separate, and then this is the acetabular component is separate. Now what is the advantage? You can change the neck length by changing the size of the head. Okay, so you can compensate for any limb length discrepancy on table. Now comes total hip replacement implants. Now you have this stem, you have the femoral head, you have the polyethylene liner, and you have the acetabular shell. So all these implants, they are different. They are all different. Total knee arthroplasty. Now this is a femoral component, this is the tibial tray, this is the insert, and this is the patellar component. Just in brief. Now coming to the more important thing, platings. Now this is not plating. First I am discussing the hip implants. Now this is a condylar blade plate. Okay. Now it comes with a blade length of 50 to 80 millimeter and blade width is 18 millimeter. Now it comes in two angles, between the blade and the stem of the plate. It comes in two versions. One is 95 and one is 130. This is this proximal contour. It accommodates the greater trochanter. Okay, it is for the greater trochanter. Now 130 blade plate is commonly used for intertrochanteric fractures, and the 95 blade plate is used for reverse oblique intertrochanteric fractures, subtrochanteric fractures, and the supracondylar fractures. Few of us are still using this implant. Now this is the implant. Now coming to the DCS, dynamic condylar screw plate. This plate is used for reverse oblique type of intertrochanteric fractures and subtrochanteric fractures. It can also be used for intercondylar fracture of the femur and supracondylar fracture of the femur. Okay. Here also the angle between the barrel and the plate is 95 degree. So this contour again accommodates the greater trochanter. It comes only in one barrel length, barrel length is 25 millimeter. So this is a barrel plate, this is the leg screw, and this is the compression screw. Now this is it. Now these, two proximal screws are for the 6.5 mm cancellous screws. These two are for the 6.5, and these screw holes are for the 6.5 mm cortical screws. Coming to DHS, most of us are using this implant, and we are well versed with this implant. This is the barrel plate. It comes in this barrel comes in two sizes. One is a short barrel, 25 millimeter, and then there is a standard barrel of 38 millimeter. The inner diameter of the barrel is 8.2 millimeter, and the outer diameter is 12.5 millimeter. The angle between the barrel and the plate most commonly used is 130 and 135, but they come in the sizes for the angle between 125 to even up to 150. Okay, comes up to 150. Now, where it is used? It is used in intertrochanteric fractures, basal neck fractures, and sometimes in valgus osteotomy when wedge is less than 85 millimeter. What is used in valgus osteotomies also. The diameter of the lag screw is 7.8 millimeter, and the thread diameter is 12.5 millimeter. You must also remember this. Okay, this is 8 millimeter, and this is 12.5 millimeter. So it works on the principle of controlled collapse. So there is a controlled collapse and the fracture gets compressed and there is a healing of the fracture. Now comes orthopedic plating. So plating can be different in different modes. It can be a compression plating, neutralization plating, bridge plating, or buttress plating. So this is the DCP, dynamic compression plate, most of us are using. Okay, the holes in the plate, they are oval and they are slanting. See this, you can see my arrow here, and they are slanting. So they are oval hole with a slanting, inside this. Now, what is the principle of DCP? What is the dynamic compression principle? The holes of the plate are shaped like an inclined and transverse cylinder, which I have already shown you. Like a ball, the screw head slides down the inclined cylinder. So here, the sphere glides into the cylinder. Sphere is what is sphere? Sphere is the head of the screw. It glides into the cylinder. Because the screw head is fixed to the bone via the shaft, it can only move vertically relative to the bone. So the horizontal movement of the head as it impacts the angled side of the hole results in the movement of the bone fragments relative to the plate and leads to the compression of the fracture. Okay, so if you see this diagram, here is the fracture. This is the central screw. You put first this central in the neutral mode, and this is in the loaded mode or a centric mode. What is the centric mode? It is 1 millimeter away from the center. So when you tighten this screw along with the bone moves toward the other fragment, leading to the compression. Okay, so this is the sliding end. See here, the screw will move. If you insert it here, the screw will go to the center along this line and it will move the underlying bone, leading to the compression at the fracture site. This is again the same diagram. Now this is the screw in the neutral mode in the center, and if you put the screw in the centric mode 1 millimeter away, then if you tighten this will move like this in the slanting mode, inclined mode, and it will go towards the center here, thereby compressing the fracture. So this is the principle of DCP, you must remember. Now this is a broad DCP for use in fracture of the femur and tibia. Sometimes there are alternating holes. Now this is a LCDCP. Now what was considered as a disadvantage of DCP? It doesn't have these striations here, scoops here. Now it is said that when you use DCP, it leads to when it compresses the bone, it leads to the avascularity of the periosteum. But here in this case, it is LCDCP. The footprint of the plate over the periosteum is less. So chances of avascular necrosis of the periosteum are less. Now these are again, you must know different types of the shape of the plates. This is a T-shaped plate. This is again as DCP. This is a semitubular plate, this is a cobra plate, and this is the T plate. This is a L plate. So all these plates, you must know because they are used in different situations. Now, this is a semitubular plate. This is very thin plate, 1 millimeter only thickness, and they are mainly used for fractures of the fibula, fracture of the ulna, and sometimes maybe fracture olecranon or fracture of the clavicle. Now comes to very important, what is a screw? What is a screw anatomy of the screw? Now, this is the total length of the screw. Now, this is the head and this is the shaft. Shaft, this part is known as shank, and this is the other threaded part. Okay. Now, there are few definitions. What is core diameter? Core diameter is solid part of the screw from which the threads come out. And the strength of the screw depends on the core diameter. Okay, the strength of the screw depends on the core diameter. Core diameter has to be equal to the drill bit. So if we are using 3.2 drill bit, it means core diameter is 3.2. Okay, you must remember this. For 4.5 screw, we are using 3.2 drill bit. And if we are using tap is of the same diameter as that of the thread diameter. Suppose it is 4.5 mm screw, the 4.5 mm drill bit, 3.2 mm drill bit, and 4.5 mm tap. It must be clear to you. Now comes the pitch. What is pitch? This is the pitch. It is a distance between the two threads. It is a distance between the two threads. So when a screw is turned whole 360 degree, this is known as the one pitch. So it advanced by one pitch. Okay, and this is the thread height which is projecting from the core. So thread height is also very, very important in different types of the screws. So all these things should be very, very clear when you are given screw in the examination. Okay, now this is the cortical screw. Now what is the difference between a cortical screw and a cancellous screw? Now it is a head. Now, the heads are different types of slotted in different ways. The most commonly is a hexagonal shape, but there is flip shape, there is a cruciate shape, there are so many shapes of the heads. Now this cortical screw is threaded throughout. The cortical screws are threaded throughout. The pitch is small and the thread from the core is lesser in size. So thread height is less, and core to thread to core diameter ratio is less. So again, pitch is less, fully threaded, the thread height is less, and the thread to core ratio is also less. So this is cortical screw. Okay, this is used in the cortical bones. Here comes the cancellous screw. Now see the difference here. This can be fully threaded, 32 millimeter threaded, and 16 millimeter threads. So it comes in different variations. Okay, now here the pitch is more. See here, the pitch is more, the thread height is more, but the core diameter, the thread to core ratio is more. So this is used in cancellous bones, and this greater height of the thread and the more pitch will lead to the less chances of pull out of the screw from the cancellous bone. So there are less chances of pull out. So this is the difference between cancellous and the cortical screws. Now cancellous screw, there are cannulated cancellous screws, comes in different sizes. Now this is the locking screws. Now see what is the difference here. The difference here is there are threads on the head also. There are threads in the head also, and which fits into the the threaded hole of the plate, locking plate. Now there are locking cancellous screws locking cannulated cancellous screws, and this is the malleolar screw. You must also know the malleolar screw. Here, it is again partially threaded, 4.5, but it has a refined tip. So there is no need to tap the hole when you are putting the malleolar screw. And here again, the distance between the pitch is more and the thread height is again more. You must know about this screw. This is the Herbert screw. Now what is there? There is no head here and there is a differential pitch. So this is the proximal end and this is the distal end. And this whole of this has to embed in the bone. Nothing remains out. So this gives compression to the fracture. And most common example where we use it is the fracture scaphoid. So this is Herbert screw. These implants we have already seen. I'm not going to discuss that. But one implant you must know here, this is Muller device. I have told you in a fracture, transverse fracture or oblique fracture of the forearm or wherever in the long bone diaphyseal fractures, one of the things we can do compression is by the compression mode in the shape of the hole. And the second one, this device is the Muller device. We can give compression to the fracture. Now, how this Muller device works? See this picture. Now, if there is a fracture here, one of the fragments of the bone is fixed with 2 screws, and to the other end, this Muller device is fixed. It is fixed to the last screw, and then with this unique article screw, the other end is fixed. Then when we compress this, there is a compression of the bone fracture here. So while tightening this screw here of the Muller device, see here, the bone is pushed towards the other fragment. And then while compression is achieved, we fix it with the screws in the other fragment. So you must know this is AO Muller device. Now, few things about Steinman pins. It comes in different sizes. This is used for skeletal tractions, 3 to 6 millimeter, increment of 0.5 millimeter, length is from 15 to 30 centimeters. This is the Denham pin, again used for skeletal traction in the osteoporotic bones. Here there are striations in the center. So it is used in osteoporotic bones. Sand screw, everybody must be knowing, we use it for skeletal, for fixator purpose. Okay, for the tibia, for the humerus, and for the femur, there are different sizes, 4.5, 5, and 5.5. For the radius, 3.5. And for the metatarsal and metatarsal, it is 2.5. KYs, we all know, we have seen, everybody must have seen the KYs. We do use it for different purposes, for fixation of the fractures, for skeletal traction in the pneumatic bones, etc., etc. And it comes in different sizes, 1 to 3.5 millimeter. It is a trocar on both sides, or it is a single trocar only on one side. Now coming to last few slides, they are handheld plaster cutting instruments. I think postgraduates nowadays, they are not versed with these instruments. Only ward boys cutting our, plaster, this thing, plasters. So these are the different types of the plaster saws. And this is a plaster spreader. After cutting, we have to spread it. This is scissor, and this is again plaster shear for cutting the plaster. And this is a plaster bender. And this is on this side and left side is plaster opener saw. So these are the handheld, instruments for plaster cutting. And nowadays we are using this electric cutter for cutting the plaster. Now this you have already seen. I'm not going to ready? Hello. I'm not going to talk on this. We have already covered in our video. So with this, I finish my talk. Share screen. Stop.
Okay. Thank you, Dr. Gupta. That was a very detailed and I think a very knowledgeable talk, very useful for the postgraduates. Now, I think we've come to the very last talk of the entire session on the entire day. And up till now, what we have done is basically we have covered only the factual things. Now, what I'm going to ask you to do is think a little bit about this subject. So I am screen sharing. Can you see my screen?
Yes, sir. Seen.
Great. Okay.
So please do full screen, sir.
Yeah, I'll do that. Now, can you see?
Yeah.
Okay, great. Now, so let's talk a little bit in general about orthopedic trauma implantology and whether we should be actually studying it as a subject. Okay, so this is what we've been through in this session. Now let's have a look at a few fractures. These are bizarre fractures in the lower limb and some more simpler fractures in the upper limb. Now, you have a variety of nails which have just been discussed, all different types of nails. You have different types of plates. Now, for a postgraduate student or someone who is starting his or her practice in orthopedics, suppose we have a fracture and we want to know what is the best implant we have to fix it, because there are so many implants. So where do we acquire this knowledge of an orthopedic implant? Do we ask a colleague? We can ask in person. We can ask our colleague to WhatsApp a suggestion. We can go into the internet, look at the various company brochures. We can ask our medical representative. We can ask various commercial enterprises. But do we actually look at orthopedic literature? Is there any sort of encyclopedia of implants which we can access? And the answer is a limited yes. Now, why limited? Because there is one manual which we can always look at, and that is the AO manual, which we all look at. But it only shows the innovations and products of one commercial institution. After all, we all know that AO is part of a commercial group of companies, and they have their own favorite implants. They often ignore the innovations of others. And AO has its own philosophy which they try to propagate. And not all orthopedic implants have been invented by them or even accepted by them. And sometimes they take a long time to accept various types of implants because it may not match their current orthopedic philosophy. So what is an orthopedic implant? An orthopedic implant is a medical device manufactured to replace a missing joint or bone or to support a damaged bone. The medical implant is mainly fabricated using stainless steel and titanium alloys for strength. And sometimes there is a plastic coating if we are trying to mimic the synovial membrane of a joint. And this is done to act as an artificial cartilage. And if we look at implants, basically implants are used for four things: trauma, arthroplasty, tumor surgery, and occasionally we use it as soft tissue reinforcement in modern ligament reconstruction. Now, the question is that how the implants in trauma, how are they unique? Well, the first thing is that bones are rigid structures which have various types of muscle attachments which are pulling strongly in different directions. As the bone is intact, the parts of the bone do not move relative to each other, but all the movement happens at a joint. But whenever you have a fractured bone, then the bone is unable to resist muscular contraction and they are pulled apart and you land up with a deformity. All bones, they heal, most of them, at least except perhaps intracapsular neck of the femur, they all heal naturally in the presence of a blood supply. But fractured bones do not have a capacity to self-reduce against the muscular pull, because unless they're actually harnessing gravity, such as when we use a U-slab or a sling. Okay, now what is the basic objective of a fracture treatment? Objective is to restore the musculoskeletal tissues to the pre-injury status of anatomy, physiology, and function. And we have done this by summarizing fracture treatment in 3 stages. Reduce, which is just reverse the bones to the pre-injury status, retain the fracture fragments in some form, which is either we can use a conservative or a nail or a plate, and finally give rehabilitation by way of physiotherapy. Now, if you look over here, you can see that this is a fracture, and various types of pulls and pushes have moved the bone out of the original position into a different position, and that has been neutralized by using all these implants over here. But there is one fundamental difference that trauma implants have from other orthopedic implants. Implants which are used in arthroplasty, tumor surgery, and soft tissue surgery are usually replacements to the original structure, whereas trauma implants have a temporary role. So most of the fractures which we deal with should heal and consolidate definitely within 2 years. And after that, the role of the implant becomes redundant. Now, this principle, that the fact that trauma implants have a temporary role, other implants have a permanent role, this is actually very important when we design different types of implants. So let's think about this a little bit further. So since orthopedic surgeons use more metal than any other specialty of surgery, then why is it that implantology is a term which has never been associated with orthopedics? The term implantology has only been used for the attachment of artificial teeth in the jaw. So I think it's time that orthopedic surgeons should start thinking in terms of actually studying the various different implants which we have used historically and are still using now, which are changing all the time. And this term we are coining as orthopedic trauma implantology. Now, the first thing is that there is very little academic work on this subject. As you have seen, apart from the AO manual, there is no other manual. Whatever literature you see comes from commercial companies, and yet metalwork has been used since 1895. And there is virtually no documentation of the hundreds of implants, thousands of implants, maybe lakhs of implants which have come and gone, some of which have become popular, some have become useless, and this has happened again and again over the last 100 years. Now, just coming to my personal views, after I started doing orthopedics in 1986, almost all the implants, everything I learned as a junior has become obsolete. Even the basic orthopedic principles, the pillars, the concepts, concepts of absolute rigidity, relative rigidity, not to use an implant in an open fracture, all these basic orthopedic concepts which were taught to us have been turned around by 180 degrees. What has changed? Everything has changed. Surgical incisions, surgical exposures of the fractures, handling of the soft tissue, orthopedic general equipment, the purpose of the operation, the surgical steps and the goals of surgery. But that is not all. The radiology has changed with various types of C-arms and O-arms. The orthopedic furniture has improved with better traction tables, radiolucent hand tables. The material sciences have got better metal alloys, polyethylene, flexible reamers. The anesthetic techniques with the regional blocks have changed. The antibiotic regimes have changed. The intensive care support we require has changed. There are newer MIPO techniques, more minimally invasive surgery, use of indirect reduction of fractures. The entry points of nailing have changed. The specialized orthopedic equipment has changed. But what has changed the most? Orthopedic implants. And when we say, okay, now I am going to nail this fracture, I am going to plate this fracture, what we don't think about is which nail am I going to use, which plate am I going to use? What are the plates available today? What are the nails accessible to me? Why are these designs? Why are they changing? So let's have a quick look at this. Initially, diaphyseal fractures were treated by an open K-nail. The metaphyseal fractures had an open plating. Plates were used mainly for diaphyseal fracture in the upper limb, but they failed in the lower limb. The nails gradually became closed. They became antegraded and locking. But then the nails and the plating, they started encroaching on each other's territory. So you started having nails encroaching on the metaphyseal region with the PFN. The longer plates started encroaching on the proximal distal shaft. So you had long DHSs. Nails became more versatile with more locking options, and plates started becoming anatomical. So if we look at it in this way, that the determinants of outcome in any internal fixation is fundamentally based on 5 issues: the surgeon factor, the patient factor, which is the fracture geometry, the surgeon's factors, which is basically his training and skills, the non-physical infrastructure which is available to you, the manpower, the junior technicians, nurses, etc., the non-orthopedic backup with your allied specialties, the ITU, your physical infrastructure with your C-arms, and the implants which are available to you. And this has basically, we have looked, there is a kind of a dichotomy between the nail and the plate. The nail, which is a surface implant, which is fixed to the bone with screws. The plate, sorry, I beg your pardon, this slide is the nail and the plate. So the nail is a internal device locked to the bone with screws, and the plate is a surface implant. And the plate was originally an open surgery, but has proceeded to MIPO. The nail started as open surgery and has proceeded to closed nailing. The plate was originally meant for diaphyseal fractures in the upper limb, but it has now been extended to various metaphyseal fractures. And the nail, which was also for the diaphysis of the lower limb, has extended to various types of metaphysis of the bones and joints. So these are the various types of nails and plates which are available. We started with the Sherman round plate, then we proceeded to the DCP, and finally the locking plate. So you can see here all the principles which have been discussed a little while ago. And then the K-nail, which was straight with no locking, and then it was used in a retrograde manner. Gradually this moved on to closed nailing, which was antegrade, and then finally interlocking nails and with their reamers. Now the plates kept on evolving with the pre-contoured plates, the plates for special regions of the body, such as the clavicle, the calcaneum, plates for arthrodesis. And then of course, we are now talking about navigation in trauma surgery and various type of robot-assisted computer surgery, as well as MIPO over here. And then the nails kept on moving further with expert tibial nails, which had more locking options, nails for special regions of the body, the PFN, nails for arthrodesis, as well as computer-assisted and navigation. So you can see that the take-home message from this is that it has been an onward and forward march of both the nails and the plates, who have almost been competing against each other ever since they were invented. They have competed more and more for market share by continually evolving and extending their indications. Generally, nails require more infrastructure. Nails are the stronger implant and therefore dominate lower limbs, which are weight-bearing. Plates dominate the upper limb, where precision is required and angular stability is important. Now, what is the future? Well, the nails and the plates are here to stay, but they have often been replaced in certain situations by innovations in external fixation and the Elizarov in certain cases. There is a lot of usage of TENS in pediatric cases, and sometimes today replacement surgery is being done for complicated fractures, especially around the hip, for complicated fractures around the hip. So to stay dominant, both nails and plates and other implants will have to continue to evolve, because the only thing constant in life is change. Thank you very much.
Thank you, Arindam. Very nice exposition of the whatever has changed in orthopedics in last so many years. Now, as all the talks are over, there is some time for discussion, and may invite any question. I don't see anything in the chat box as yet, but if there are any questions, we can.
There are my postgraduates are sitting there, you know. Anuj, ask the question. I think there should be some interaction. Otherwise. Anuj?
Good evening, sir. Yes, sir, I'm here only. Sir, could you just explain the principle of, again, the concept of principle of plate fixation?
You mean to say dynamic compression plating, right?
Right, sir. Right, sir.
So, see, I have already explained the principle is sphere glides into the cylinder. You must keep this in mind, you know. And if you see DCP has holes which are, you know, in the oval holes. And the holes, they are slanting on the sides. The holes are slanting on one side. So what you do is, when you are fixing, suppose we for example, a transfer fracture, we are fixing in a forearm, you know, or wherever in the shaft. Suppose we are fixing a transfer fracture. Now we put in the plate. Now there are, you know, lot many things, you know, when we need a exact, you know, compression of the fracture, we have to pre-bend the plate a bit according to the AO principles. Now, if you put in the first screw is always put central. Central means neutral guide. Okay. And you don't tighten it fully. You fix the one fragment with this. And on the other side, when you are putting a load screw. Load means eccentric screw that is 1 millimeter away from the center. And according to the geometry of the underside of the, you know, screw head and the plate slanting position hole, when you tighten it, the screw will move towards the center along with the bone. And when it moves, it will compress the fracture. It will compress the fracture. So that is the principle. Is understood?
Yes, sir. Thank you, sir.
There's another thing, that if you are using the modern plates, then it's a combination of the cortical screws and the locking screws. Okay, so basically,
that is a combi hole.
Cortical screws will compress, and they will bring the plate closer to the you know, bone. It will hold it very well. Whereas the locking screw, it doesn't actually pull it in the same. It doesn't pull it, but it is there to, you know, because in every part of the body you don't need that. So there are parts, if you look at the pre-designed, you know, the pre-contoured plates, and there are some parts which are reserved for cortical screws and some parts which are where you put the locking screws. So you have to, you know, understand the fracture geometry, that where you need the plate to come closer and where you don't need that. And you have to, you know, plan your surgery and use the screws accordingly.
This is a simple principle of DCP only. Therefore, there are different variations in that, sir.
Yes.
Sir, I have one more question for.
Yeah, carry on.
And Rajesh, there are some questions for you in your chat box. You can go on to chat box and see those two
chat
questions.
box, sir. Just a minute, sir.
Just go on to the chat box. Just go into chat.
What is there? Is in anti-glide is addition to have any advantage? So anti-gliding plating principle is different, you know. Anti-glide principle is different. Here, when basically we are using this anti-glide principle in few of the fractures, and the commonest fracture is the distal, you know, the distal fibula, you know, lateral malleolus fractures. Now here in anti-glide principle, we are fixing the proximal fragment, and sometimes we don't fix the distal fragment, and distal fragment is compressed with the plate. That is the anti-glide principle. It has nothing to do with the interfragmentary fixation. Is clear?
The other thing about the buttress is that it holds it up, you know. So buttress plate, like it's like the old Smith plate, you know, it is holding up. It's a buttress. So it's at a different, slightly like a cobra pushing up the bone.
Yeah, sir, he is talking, the question is anti-glide.
No, in this, you see the chat box, the buttress mode. It's talking about the buttress plate as well.
I don't know. There's only one message here. I don't know.
Okay.
So in anti-glide, we fix the proximal part or distal part?
Proximal part, you know, proximal part, 2 or 3 screws only. You can fix the distal part also with one screw, but it is not needed.
But so if we fix the proximal part, then that will slide down over the distal fragment.
It does not. That is the beauty. It does not slide down.
So there is a difference between the buttress and the anti-glide. Buttress is one in which you may not fix the upper part, but anti-glide is when it is in that narrow area, and when you dynamize it, it goes and locks there. But still, you have to fix on both the sides. Anti-glide, you have to fix both the sides. Buttress, you may fix only one side.
But sometimes anti-glide we don't fix, sir. Distal one. If required, maybe one screw, like maybe locking one screw.
Answering the other question, anti-glide doesn't mean proximal or distal. It will depend on the angle.
Principle.
It is for
exactly.
Yes, it will depend. You have to make an acute angle. In that, the other fragment goes in. So you have to fix both the sides, and you will fix first the side with the obtuse end.
Exactly. So suppose sir, in fibula, suppose the middle part is proximal. I mean, middle fracture line is proximal and distal is lateral. In that case, if you fix the proximal part, then what will happen? That will slide down over the distal fragment.
It is not indicated in all the fractures of distal fibula. You know, this is a oblique fracture where the distal fragment is, you know, posteriorly up. So it is just, this plate is just pushing that fragment down. It is just holding that fragment down. You cannot do anti-glide principle in each and every transverse fracture or cumulative fracture. No.
Okay.
There's another thing in fibula. If you have an oblique fracture, then you should first put the compression screw across the fracture and then use the plate as a neutralization. You got me? So you need to put a lag screw across the fracture first, which will hold your fracture properly, and then so that the lag screw can take the strain and it doesn't break under the stress and strain, then you put the neutralization of the plate on the side. So, you know, that is the principle you have to follow.
That is against the principle of, sir, anti-glide. Basically we are putting a lag screw is a different concept. Then we are fixing the fragment with the lag screw, and then we are putting the neutralizing plate.
Okay. Sir, one more thing. Suppose there is, corresponding drill bit and the screw sizes.
Yes.
So what is the concept, behind this? We'll have to mug it up, or there's some, concept related to that?
See, I think I have made it very clear in the, slide. When we are using 4.5 screw, we are using 3.2 drill. Is it okay?
Yes, sir. Okay.
Now, what is 3.2? 3.2 is the core diameter of the screw.
Okay. Got it. Yes. So that's the concept.
You must be very clear on this. 3.2 is the core diameter of the screw.
Okay. So that will be the drill bit size.
What is the, now you tell me, what is the tap diameter?
So tap is the screw. Total diameter of the thread. That is the tap diameter.
Yeah, so 4.5.
That will be 4.5.
So tap is 4.5, right?
Yes.
So this concept has to be very, very clear. So it is the core diameter, which is the tap diameter.
Okay, sir. Got it.
Which is the drill diameter, not tap. Drill diameter, yes.
Drill diameter. So second thing you have shown this PFN, one is having only one screw, second is having 2 screws, where we find the Z effect. So can you just put some light on that?
See, there is a lot of nailing concepts, some people were using gamma nail with 1 screw, now people are coming with 2 screws. Now there is a PFN A2, people are using only 1. So these are different concepts in proximal fracture nailing, proximal femur nailing. So there is a Z effect, there is a reverse Z effect. So then it comes under a PFN.
So can you put some light on that Z and that reverse Z effect?
Z means the proximal screw, it comes out and distal remains inside. Okay, reverse means the proximal remains in and distal comes out. So this is the Z effect, you know. Proximal comes out and distal remains inside. So there is a migration of the screw out. So that is the Z effect.
Try to think of the letter Z, okay, like this.
Yes.
So one going this way, the other one going that way. That's
Yes,
Z
sir.
effect. And if it's reverse, it's the other way around. Okay.
Okay.
We'll have some, full discussion on nailing. So this
Okay,
is
sir.
only instruments in orthopedics. Anyway, good question. Any other? Sir?
Then we may close down. Dr. Taneja, sir.
Sir, Dr. Taneja, sir.
This has been a wonderful session. There was an excellent presentation by our WOC President, Dr. Alaa, talked about in scoliosis and a very high-tech, the correction of the apex in early onset scoliosis. Very high-tech lecture. But anyway, it was a good information to all the students and faculty. And of course, Goel, your lecture was a very basic lecture, and especially for the postgraduate, they should know the type of the non-union and difference between non-union and delayed union and the principle of the union. Very well talked about, and I'm sure the students must have greatly been benefited. The presentation of the different instruments on a video was very informative, and I think every student must have enjoyed that and benefited themselves. And of course, the lecture by Rajesh Gupta, who is always very energetic, very dynamic, and who is always full of energy and work, who talks with great passion. I like, Rajesh, your lecture because you always talk from the bottom of your heart and with great passion. You are a good teacher. Keep it up. And
Thank you, sir. Thank you very much, sir. Thank you very much.
You to be join our group. We hold these courses from last 26 years. Few faculties keep changing. You have joined us for the first time.
Thank you, sir. Thank you very much.
And you have, and of course, Arindam is his lectures are very innovative and very new ideas. He comes, and his lecture on this implant is a very good lecture. And I think the students should know that how the philosophy in the internal fixation of fracture is changing from day to day. There's a competition between nailing and plating, and you will see that the time is not very far off when we will be having a metal-free orthopedics, because now there are a lot of biodegradable implants are coming, a lot of tissue transplants are coming, a lot of new ideas are coming into this thing, because after all, a lot of things which are now going on in the orthopedic presses are market-driven, and which we all know this thing, and gradually we have to be very careful. I have only one message to my young budding orthopedic surgeon, is that please make sure that any fracture which can be treated conservatively, just don't jump over to the operative treatment. The conservative treatment is much more difficult to practice than to do the operative surgery. These are not my saying. These are the saying of a great man, John Chandler. Okay, the conservatism is an art, and surgery is a skill. Anybody can open it up, bring the two ends together and just put in a plate. Not a very difficult job. Anybody can do it. I know a few people in Indore who are running a nursing home, and their children are doing surgery. And of course, they have seen it because after all, they're technician jobs. So wherever you can treat the fracture conservatively, don't jump over to the surgical treatment. Think over what is the best treatment for the patient, what you would have liked for yourself and for your own brother and sister. That is the best treatment that you can give it. Dr. Goel, he's a very great academician, and his contribution in the orthopedic world, particularly in my country, India, is tremendous. He has been the editor of the Indian Journal of Orthopedics, and he is the past president of Indian Orthopedic Association, and now he is the president of the Orthopedic Association of the SAARC Countries of India chapter, and he has made immense contribution in the field of orthopedics, and we share many things in common with Satish Goel. I always enjoy talking to him, and he's always very supportive of our course. And with these words, I will like to end this session. And yes, and I once again thank Dr. Shabir. Although he had difficulty in presenting his slides, but eventually he did it. Very good lecture. I enjoyed that. And Alaa, of course, is one of us who has been practicing pediatric spine surgeon, has done an extremely good job done. My congratulations to all the speakers of the today for their excellent presentation. And we'll see you all tomorrow. I'm happy that on an average about 120, 130 students were constantly on and has been joining us. And maybe we'll have more students tomorrow who will be with us. Thank you once again, and see you all tomorrow at 12 o'clock. Thank you. Good night. 12 o'clock Indian Standard Time. Yeah.